Good morning, everyone. It is my absolute privilege to welcome you all to this continuing medical education program, Together in Medicine, exploring every specialty, organized by IMA Sullia branch in association with the IMA Academy of Medical Specialties Sullia chapter. Medicine is a vast and ever-evolving field, and collaboration among specialties is the key to holistic patient care. Today, we gather not just to enhance our knowledge, but to foster a spirit of unity and learning across the disciplines. We have an enriching session ahead with esteemed speakers who are pioneers in their respective fields. Before we begin, let us extend our gratitude to the organizers, faculty, and all the attendees for making this event possible. First, I would like to call upon our first speaker, Dr. Geeta Doppa ma'am, who is going to speak on a topic, HPV vaccination. And I would like to invite Dr. Indira Dodda-Ballapur and Dr. Karunakar sir to chair the session. And now I would call upon Dr. Divya to introduce our speaker.
Dr. Geeta Doppa ma'am, a life committed to healing, teaching and uplifting the rural India. Dr. Geeta ma'am is a distinguished obstetrician, educator and researcher with a deep commitment to high-risk obstetrics, infertility and rural healthcare. Her passion extends beyond hospital walls. She is a firm believer that quality medical care should reach every woman, especially in rural India. Ma'am is serving as a professor and head Department of Obstetrics and Gynecology in KVG Medical College, Sullia since 2012. She is also a medical educator, mentor, high-risk obstetrician, infertility specialist, researcher and author. Dr. Geeta ma'am is deeply committed to improving the maternal health care in rural India. Ma'am works tirelessly to bring advanced obstetric care, infertility solutions and medical education to unserved communities. She has played a pivotal role in strengthening the medical community through her leadership in IMA Karnataka and IMA Sullia. Her contributions include regular Central Working Committee member, Chairman IMA Academy of Medical Specialties Karnataka State, past Chairperson Women's Doctors Wing IMA Karnataka, President IMA Sullia, Vice President IMA Karnataka State Branch, Honorable Secretary IMA Sullia. Apart from these, ma'am is also an executive committee member of Mangaluru Obstetric and Gynecology Society, member and coordinator of Practical Obstetrics Committee, National OBG Society, FOXY. Geeta ma'am has been honored with several prestigious awards for her outstanding contributions to medical and community service. She received the Kannada Kasturi Award in 2021. IMA Karnataka State President's Appreciation Award. She has also honored with Dr. Kanak Goyal National Award for her significant contributions to the Safe Motherhood Project. Additionally, she received the WDW Chairperson's Appreciation Award from the National IMA at NatCon Prayagraj in 2022. Ma'am envisions a future where no mother loses her life due to lack of medical care. No mother struggles alone with infertility and every young doctor is guided with passion and purpose. Ma'am continues to inspire change, leading with knowledge and compassion with an unwavering commitment to improving the maternal health in India. Thank you.
A very good morning to one and all. So today's state level CME, which is organized by IMA Sullia and IMA AMS Sullia branch chapter. So the first talk for today's CME will be on HPV vaccination. So as we know, cervical cancer is the second leading cause of death in women in India. First being carcinoma of the breast. So January is celebrated as Cervical Cancer Awareness Month, and 4th of February we all celebrated the World Cancer Day. So this cancer cervix has the highest burden. See, one woman dies of cervical cancer every 8 minutes. So in this 15 minutes of my talk, we lose 2 ladies because of this preventable cause, that is carcinoma cervix. And over 67,000 ladies lose their life in India because of carcinoma cervix. So this is the burden of this deadly but preventable disease. If you compare with the world, India shares 27% new cervical cancer cases and 27% deaths due to cervical cancer if we take the whole global scenario. Then we all should work for this cervical cancer Mukt Bharat. How can we do this? One is by prevention with vaccination. Secondly is detection by screening. So 99% of these cases of carcinoma cervix occur because of this HPV virus. There are 200 different strains of this HPV. Among that, around 40 strains are oncogenic. So this HPV, it has mucosal genotypes, cutaneous genotypes, then high risk, low risk genotypes. So varying from different types of cancers to genital warts, it affects the men and the women both. So these are the different HPV types and what problems they cause. So mainly HPV 16, 18 are highly oncogenic, which are most important in causing cervical cancer, penile cancer and oropharyngeal cancers. Then there are low oncogenic potential HPV viruses too, and HPV 6, 11, 13, 32 are low oncogenic ones. They are causing only non-oncogenic. They don't cause any cancers but genital warts. So in nutshell, these are the main important types of HPV viruses. Yes, so not only cancer cervix, it affects oropharyngeal cancer, anal cancer, genital warts, penile cancer, vulval cancer. If we see this chart, we can understand this HPV affects men and women both. So HPV vaccine will help both girls, boys, men and women. Now what this HPV does? This is regarding the cervical cells. It enters the cervical cell, the HPV DNA goes into the cervical mucosa and it enters the epithelial cell. But most of the time, because of the immunity of the body, in 2 years, 90% of the infections are cured by themselves. But in immunocompromised patients, low socioeconomic condition, poor hygiene, STIs, in such patients, it progresses to the cervical cancers. Yes, this is regarding the CS cervix. It can be cured in the transient stage, but if it is not taken care, it progresses to the deadly malignant stage. So these are the different percentages of cancers which are caused by this HPV virus. Yes, so 16, 18 oncogenic, 6 and 11 are the ones which cause the warts. So most of the vaccines which we have now are targeting against these 4 types of HPV viruses. Yes, so the HPV cannot spread because we should know about this HPV too by hugging, holding hands, sharing toilet seats, swimming pools, hot tubs, sharing food, sharing utensils. The HPV won't spread, but spreads by sexual contact and passed from the mother to the baby. That is vertical transmission. And it can be prevented by using barrier contraception, regular checking of the STDs and also by HPV vaccination. So in 2018, in the FIGO Global Declaration, it was told that cervical cancer elimination program should be done. And accordingly in 2020, the World Health Organization said by 2030, we should eliminate the cervical cancer. It means less than 4 cases per lakh women should be the target by 2030. How can we achieve this target? What is the target given by WHO? 90, 70, 90. 90% of the girls must be vaccinated by HPV by 15 years of age. 70% of the women should be screened with high performance test, that is HPV testing, by the age of 35 and 45, at least twice in their lifetime. And 90% of the women who are diagnosed with cancer of the cervix, pre-malignant lesions of the cervix, must receive the treatment. So this is 90-70-90 strategy of the WHO to eliminate cancer cervix by 2030. So now let us see the Western world. 90-70-90 is the target. The Western world has around 50-90% of vaccination, 80-90% of HPV screening, and 80-90% of the women are treated who are diagnosed with cancer. But what is the condition in India? It is pathetic. Vaccination, it is only 0 to 0.1% of the target group are vaccinated. Only 3% of the women are screened, and only 10% of the women diagnosed with pre-malignant and malignant lesions are treated. So we are far, far, far way behind. Yes, so what may be the major factors? One is maybe there is no awareness, no lack of commitment in the healthcare providers, lack of infrastructure, policy makers. So lots of factors are there. So it's like daily in India, an Airbus is crashing with 185 women on board, because daily we are losing 185 ladies because of this cancer. So for this, we all have to do this prevention by lifestyle modification, regular screening and vaccination. So this HPV vaccine, so how it helps? So it introduces virus-like particles into the body. These virus-like particles produce antibodies and whenever to attack these VLPs. And then whenever the patient or the person is infected with HPV, the antibodies will act and protect the person who is vaccinated. So mainly it acts by producing the virus-like particles in the body. These vaccines will not cause the disease because it does not contain the viral DNA. Then if 1,000 people are vaccinated, then 20 deaths are averted. So one vaccine in 2 doses protects against 6 major types of cancer: cervical, vulval, vaginal, endometrial, oral and anal. Yes, adolescent girls are the important target for us because the studies have shown that highest immune response is achieved when we immunize the young adolescents as compared to the young adults. Then before their first sexual contact, if they have vaccinated with HPV vaccine, definitely they are protected. And also the cost. Before the age of 14, if they are vaccinated, we need only 2 doses. Yes, so what is the different schedule of giving this HPV vaccine? From the age of 19 to 14, that is our main group which we have to target. So 2 doses, first dose at 0, second dose will be at 6 to 12 months. And if the child is not vaccinated during this group, then 15 to 26 years, we need 3 doses. So 0, 1 to 2 months and 6 months. So this way we have to complete the vaccine schedule. So many times doubts are there. If the dose we are late by taking the dose, what should we do? So it has been told during 1 year period, you should finish all the 3 doses. In case if you are not able to take at the stipulated time, in 1 year period, finish the doses. What about pregnancy? If accidentally a patient is pregnant, if she has taken HPV vaccine, there is no need to do medical termination of pregnancy, but the next remaining doses we can give in the postpartum period. Then what are the different HPV vaccines which are licensed and available in India? So one is Gardasil. So it is a quadrivalent vaccine which works against 4 different types of HPV, 6, 11, 16, 18. It is licensed in India only for the females, and girls 9 to 14 years, 2 doses. Women 15 years and older, 3 doses. Gardasil 9. Earlier we used to get Cervarix, but now it is not available. Gardasil 9, it is a nonavalent vaccine which works against 9 different types of HPV. Males and females it can be given, and the company tells it should be given in the 3 doses. This ray of hope is Cervavac, which is the vaccine which is produced in India by the Serum Institute of India, Pune. So this vaccine is a quadrivalent vaccine licensed for use in male and female, and it can be given in the girls, boys, men and women. At present, we are having a ray of hope because of this Cervavac vaccine, and Government of India has told that shortly they will include this HPV vaccine in the National Immunization Schedule. If that happens, it will be really a very good change for the Indian women, which will avert so many deaths because of carcinoma cervix. So this Cervavac vaccine, presently it is costing 2,000 rupees for single dose, and if it to take 2 doses, it is 4,000. But if it is Gardasil 9, it costs around 10,500 for a single dose. So we are expecting this vaccine to change the scenario in India shortly. It is available now, but not free or any given by the Government of India. Australia was the country which introduced first this HPV vaccine in the National Immunization Schedule, and now they are in the verge of elimination of carcinoma cervix, and they have given for both girls and boys in the immunization schedule. Now recently many studies have come which are telling that one vaccine is sufficient. So this committee of the WHO has told that one vaccine is equivalent as giving 2 doses. But in India, as of now, we are following the 2 and 3 dose regimen only. But recently in Nepal, they have started vaccinating the girls above 9 to 15 years, and they have started giving only 1 dose of HPV vaccine. Then, even if you take the HPV vaccine, screening is essential, because we are giving HPV vaccine which is targeting against few types of viruses. But the disease can be caused by other types of viruses too. So screening and vaccination must go hand in hand. So let us all work together to vaccinate, do the regular screening by Pap test and HPV testing, and let us all join hands together for this Cancer Cervix Mukt Bharat. Then, as Louis Pasteur said, why talk of cure when you can prevent it? So cancer cervix is 100% preventable cancer, and yes, we all must become ambassadors in preventing this cancer cervix, spreading awareness about this HPV vaccination and screening methods. So Karnataka State OBG Society, the FOXI and IMA all are working together for this zero cervical cancer and Cancer Mukt Bharat. So let's join hand together for this noble cause. Thank you.
Hello. Good evening. Good morning, everybody. Madam, there is a hindrance, like whenever we explain the necessity of the immunization, there will always be hindrance like corona vaccine given, and there are so many complications. So you should have taken care of that side effects also.
Yes.
Should be highlighted, madam.
Yes. So as far as side effects are concerned, this vaccine has got no side effects except for some fever, rash, pain at the site of injection. Some girls may have some syncopal attacks or fainting attacks, but none of the severe side effects have occurred because of this vaccine. So whenever we explain to our patients, to the girls, we should always tell that it has got no side effects. And just for taking precautionary measures, we ask them to stay in the vaccination clinic for 15 minutes, we observe them and we send them. But none of the studies have shown any major problems occurring because of this virus vaccine.
Relationship to menstrual cycle days. Yeah, exactly when should be given in relation to menstrual cycle, ma'am. There's also a growing doubt.
Yes.
Whether if they are menstruating, can it be given? That is one of the doubt.
Yeah, no problem. No problem with anything. The girl can take vaccine anytime. But if she's having menstruation, if she's feeling weak, pain is there, you can give in the days wherever she is comfortable. But there is no study which tell it can be given at this time or that time. Any time the girls between 9 to 14 years can be given this vaccine in 2 doses.
Thank you for wonderful coverage of the HPV vaccine. Hope this will be coming to the Indian National Immunization Program as soon as possible. Till then, we don't wait for the government to do anything. We had to put our hands for our health. So everybody will be HPV, like to spread the knowledge, and everybody should be taking in active part in immunization of the whole country, whole community. Thank you. Thank you, Geeta madam.
Thank you, everyone.
From the audience, is any queries? No. Okay. So now I request Dr. Indra, the developer madam, to honor our speaker. It was an informative session. Also, we thank Jyoti from Serum Institute of Pune to sponsor this session as well. I would like Dr. Veena madam to honor her.
I extend my gratitude to Serum Institute of India. Ms. Jyoti, she is the representative coming to Sullia all over from Mangalore. Thank you very much.
Now I call upon Dr. Ravikant Gio sir to deliver talk on surgical approach to stress urinary incontinence, and I would like Dr. Divya to introduce her.
It is both an honor and privilege to introduce a distinguished figure in the field of obstetrics and gynecology, Dr. Ravikant Gio sir. A name synonymous with excellence, innovation and dedication, sir has made an incredible mark in pelvic endoscopic surgery, endometriosis management and infertility treatment. Sir's contribution extends for beyond the operating room. As an academician and researcher, sir has published numerous scientific papers in national and international journals, and has authored the pivotal chapter in the textbook, A Practical Guide to the Third Trimester of Pregnancy and Puerperium. His work not only enriches the medical community, but also serves as a guiding light for aspiring gynecologists. Sir's leader and influence in the medical field are evident in his esteemed position. Chairperson of the Endoscopic Committee, Kasoga, Executive Committee member of Foxy Society, Honorable Secretary of IMA Sullia branch. His exceptional contributions have been recognized with some of the most prestigious awards, including Foxy Achiever Award, Eve Endoscopy Excellence Award, Yuva Sadhaka Award 2024. But beyond this, what truly sets Sir apart is his passion and vision. He believes that innovation in surgery, coupled with education and mentorship, is the key to transform women's healthcare. His dedication to training young doctors ensures that the future gynecologist surgery continues to evolve with the highest standard of care. Let's welcome a visionary surgeon and an inspiring leader, Dr. Ravikant Gio sir.
Thank you for those kind words. Good morning, everyone. Respected dignitaries, chairpersons. Today we are all here. Super specialty or specialty doctors get together. Usually we'll have our own associations as a union, but today we have all specialty doctors have come together for a common cause. So let us share our experience and make this event a better one. So I'm going to discuss on surgical approach in a stress urinary incontinence, which is disturbing to the many of the females. Those they are having problem, they do not come forward to tell that, so they are having this problem. Mainly they will be holding it and even stop them from getting into the public, any of the gatherings. So, but there are treatments available for it. Patient need not be suffering this, as it is an age-related and it is a very common problem. let us try to understand this, how we can tackle these problems, how we can help those women, those who are suffering from stress urinary incontinence. So let me begin with the one question that how many people have seen these patients and coming to the OPD complaining that they have a leaking of urine. So this is one such example where we can see that patient can have with a mild stress of abdominal, there can be loss of urine. Though it is not significant enough, but it is disturbing to those women, they will not come to any social gatherings. They will hold themselves. Sometimes it can be the reason for developing a depression in those women. I am going to discuss under these headlines: definition, evaluation of the patient, medical method, surgical method, especially both vaginal and abdominal method, and summary in the end. So as we can see that the prevalence is very high. Nearly 49% of women will have some kind of stress incontinence before the age of 40 to 50 years of age. And it definitely impacts their negative quality of their life. So as the disease is there since age old, this is not a new problem, but only in 1994, American Urological Association had made a guidelines about this. So let us try to understand various types of stress urinary incontinence. Stress urinary incontinence needs to be differentiated to treat them. We cannot treat each and every incontinence with one kind of treatment. So whenever the patient is having a loss of urine, may not be significant, but some amount which is disturbing to them, that is called stress urinary incontinence, following coughing, laughing, or getting up from the bed when walking. These are called stress urinary incontinence. It can be because of the urethral mobility, or it can be because of the intrinsic defect in the sphincter itself. So intrinsic defect in the sphincter should be dealt completely differently when you deal with the mobility of the urethra. And then it should be differentiated from a urge urinary incontinence. Urge incontinence means when a patient is having a urge to pass urine, she cannot hold it for longer duration. She has to evacuate. But if she does not evacuate, then they will lose a significant amount of urine. The loss of urine in a stress incontinence is minimal amount, but in urge incontinence it is significant. The whole bladder may be evacuated. So, but it should be different because urge incontinence mainly neurogenical causes. Stress incontinence is a mechanical problem where we can treat it. Urge incontinence, not much amount of treatment is. So some patients will have both urge and stress urinary incontinence as age-related problem. We should counsel those patients that only stress part can be treated, but urge part may remain, may continue. Otherwise, the patient will think that the fail of surgery or fail of medical treatment. So how to evaluate these patients of a stress urinary incontinence? The most important is the urinary diary. At least 3 days of 24 hours, what time of the day she lost a urine, how frequently, what is the amount. Urinary diary for 3 days will help us understand whether it is a stress incontinence or it is a urge incontinence. And detailed history, as I mentioned, what is the occasion, how it was lost. Physical examination also will show that whether these are the tests we can do to find out whether it is a urge or stress incontinence. Traditional method is the Q-tip test. We will put one swab into the urethra and see whether there is a mobility of the urethra more than 30 degrees following a stress, coughing, laughing. Will it move? If it moves, it is going more favor of a stress urinary incontinence. If it does not, it may be intrinsic sphincter defect. Similarly, we can go for a post-void residual urine, which is completely different problem, where patient may have a stenosis, patient may have a weakness in the bladder. Those are the different reasons. So those patients should be separated so that we should check for a post-void residual urine. If it is more than 100, it is significant. Urine analysis to check for a urinary infection. So many a time what happens, urodynamic, which is not very available in widely, need not be tested in all of the patients with the stress urinary incontinence. Only those patients, those are having a complicated or mixed type, only are those who have failed following a medical or surgical treatment, only those patients should be considered for a urodynamic testing. So transperineal ultrasound, which is non-invasive. When compared to a Q-tip test, we have to put a swab into the urethra, where transperineal ultrasound, we have to do a scanning which shows the neck of the bladder. So when the neck of the bladder is seen, what is the position when the normal patient and what happens when there is a stress. If it is more than 13 millimeter difference is there, then those patients are considered as a stress urinary incontinence. So intrinsic sphincter defects is very, very important to differentiate because treatment is completely different. If it is intrinsic sphincter defect, we have to inject the bulking agents. Botox injection is usually injected into the periurethral area. So it should be differentiated. So negative in the Q-tip test, bladder neck rest and stress test is less than 30 millimeter. That means it is negative. Urethral closure pressure is very easily, patient is going to lose the urine. And valsalva pressure is also less than 60 meter of water. And if you do urodynamic study, so these are lead pipe type, fixed type, or stove type of, so these are the differentiating point. So what are the pharmacological treatment we can consider for these patients with the stress urinary incontinence? Most important is the lifestyle modification. Exercise definitely is going to improve the strength of the muscle. So definitely it is going to helpful in these patients, and avoiding all the coffee, any irritants, even smoking, beverages, all these going to reduce the chances of stress urinary incontinence. And they also contribute to the surgical or medical treatment. Bladder training, so means as frequently as possible, they should be evacuating the bladder, so that whenever, even if there is stress is there, their patients will not have a loss of urine. That's also very good way of reducing the stress urinary incontinence in the beginning time. And many a time we expose this patient Kegel's exercise, which improves the tone of the pelvic muscles and the pelvic floor muscles. Whenever the most important part about the Kegel's exercise is that they do not understand what exactly it means by Kegel's exercise. They should do the act of holding the urine when she wants to pass. So that is actually the Kegel's exercise. There are various other techniques to confirm whether their patient is really doing it or not. That we are going to discuss it later. And it should be done 3-10-3, like means at least 3 seconds, 10 settings, 3 times daily. So that will give a very good results in over a period of 4 to 6 weeks. And it can also be, if the patient is not getting Kegel's exercise, then you can go for a neuromuscular stimulation, where patient can have a similar effect just by stimulating the pudendal nerve, perineal nerves, and they will have a exercise-like effect. Biofeedback, as I mentioned, if the patient doesn't understand what exactly it means by Kegel's exercise, some devices are kept in the vagina. Ask the patient to do a Kegel's exercise, then there will be visual and biofeedback. When the patient understands that, whether the patient is actually contracting urethral muscles or perineal muscles or gluteal muscles. So that can be understood by this biofeedback, which is very useful in improving the quality of Kegel's exercise, and then definitely it improves the continence part of these patients. Electrostimulation, most importantly here definitely acupuncture is going to help in these patients. So many studies have shown that mild to moderate type of significant improvement in the acupuncture, usually 30 minutes a week, and then for a period of 12 weeks, and followed by that they should be continuous maintenance. They cannot stop like that. Once the Kegel's exercise like stress incontinence is improved, they need to be kept under maintenance, but less frequently when compared to an intensive phase. There are devices, those patients are not willing for surgery, are not fit for surgery. In those patients we can go for a gel harm or ring pessary, which is definitely going to improve the mobility of the urethra and improve the quality of life in these women. So what are the pharmacological options are there? So we can have a most commonly used is a miragobrain and vibograin. Anticholinergic drugs also can be used, but they have a side effect of dryness of the mouth, dryness of the lacrimal secretions. So very beta-3 adrenergic drugs are very commonly used, and they are safe. Mild to moderate type of stress urinary incontinence are very well controlled by this method of treatment. Dual excitin is also very good. It's a serotonin and noradrenaline reuptake inhibitor, but the side effect is suicide and violence among these patients. So that is the major limiting factor when you use these drugs. So estrogen definitely it improves. Whenever in the postmenopausal patient, if we use the estrogen cream for a 4 to 6 weeks, these patients will have an increased vascularity of the urethral mucosa. So then there will be improvement in the stress incontinence in these patients. Tricyclic antidepressants also can be tried, but they are associated with the major adverse reactions. What are the surgeries that are available for these patients, which is definitely is going to improve the quality of the patient in these patients? So here we can go for a abdominal method and vaginal method. In the vaginal method, again, abdominal vaginal method is there, completely vaginal method is there. So this is the one abdominal vaginal method where tension-free vaginal tape. Either we can use a synthetic mesh or innate organic material like rectus fascia also can be used, which can be fixed to the urethra, to the retropubic space, to the anterior abdominal wall, which definitely improves the mobility of the urethra. And in our vaginal part, we can go for a transobturator tape, where instead of fixing it to the retropubic space, to the abdominal wall, here it is fixed to the obturator membrane, which is also having a 70 to 80% very good results in these patients. Let us consider one such patient where we have done transobturator tape. 1 centimeter incision is taken, 1 centimeter below the urethra, and the space is created in the retropubic space up to the ischiopubic rami on either side. Here, care should be taken that at any cost we should not injure the urethra. Accidentally, if you injure the urethra, we should not continue with the surgery. So, patient better to repair the urethra and then put the catheter for longer duration, and then these patients should be done surgery in the later period. So, in the same setting, we should not consider for going for a TOT, which is a foreign body material which will be kept in the mid-urethral sling. So, we are going to create a space in the retropubic space which is entered up to the ischiopubic rami, and then a stab is made 3 cm lateral to the clitoris in the groin region, and then we can use the transobturator needle. Transobturator needle is specially designed for a transobturator tape. We are going outside in technique. Only thumb is used to press it vertically downwards till you meet the index finger in the obturator membrane, and then it should be curved inwards and then bring it through the incision. Now we have to feed the transobturator tape. This is 1 centimeter broad and 15 to 18 centimeter in length. It is a polypropylene mesh. Most important part in this is whenever you are doing this surgery, asepsis is very, very important because it's a foreign body. Any site of infection, the only way to stop it is we have to get rid of the graft. So care should be taken that we do not produce any sepsis during the surgery. Similar procedure is considered on the opposite side. The needle is kept to the vertical to the incision, and then it is stabbed till we reach the obturator membrane. The finger is there inside the vagina, and then it is brought through the incision. The same thing we have to do. Now we have to feed the mesh to the needle, and then it is brought out. Now the most important part of the surgery, that is tension-free vaginal tape. It should be tension-free. If it is tight enough, it can obstruct. Patient can have a retention of urine. Earlier patient had only loss of urine only during stress. Now patient will have all the time retention of the urine, which is more disturbing than the stress urinary incontinence itself. So artery forceps should be used to guard the tape, and then it should be tightened over it. Next is we have to cut the mesh on either side. What the excess mesh is cut, and the skin is pulled up so that mesh goes deep inside and does not get. So most of these patients are dry immediately after the surgery. Patient need not wait for months together to get the effect of the surgery. Immediately after the surgery, these patients are completely dry. It gives an immediate result. And patients will have an artificial ligament in the mid-urethral area. And then abdominally what we can do is we can attach the paravaginal tissue near the urethra at the neck of the bladder to the pectineal ligament. So this also gives the very good results, especially in those patients, those are having a moderate to severe type of stress urinary incontinence, which is not giving very good results with a transvaginal route. So better to go for an abdominal route in those patients, and these patients will not have a side effect like groin pain, and any foreign body is not much used in these patients. So better when compared to a vaginal method. So here we are attaching the first thing we have to do is separate the bladder from the anterior abdomen, that is enter the space of Retzius. So for this, care should be maintained that we do not open the bladder here. It should be proximal to the apex of the bladder. And we can see on either side there is a obliterated umbilical artery, that is median umbilical ligament. These ligament, the dissection should be kept between these two to prevent injury to the inferior epigastric artery, which is there next lateral to the obliter umbilical artery. Then once the dissection is completed, we can see that there is a ischiopubic rami is there. So once we see the ischiopubic rami, now that our dissection is complete, now we have to extend dissection on either side to see the obturator membrane. So once we see the obturator membrane, now we have to identify the urethra, bladder and the vagina. It should be attached to the paravaginal tissue. We should not take a stitch through the urethra or stitch to the bladder. So this is the non-absorbable suture, that is ethibond is used, and the stitch is taken through the paravaginal tissue. We can see vagina is identified by white, shiny and smooth and vascular structure, whereas urethra and bladder is identified by fibrofatty tissue and more vascular. The vessels are running on the vagina are longitudinal, whereas vessels running on the bladder are across. That's the way to identify it. Now we can reattach the stitch to the pectineal ligament, which is present from pubic symphysis to the iliopectineal line. So we can use these non-absorbable sutures. Usually 2 stitches are taken on either side. Even this also gives a nearly 90% of results, even moderate to severe type of stress urinary incontinence. And these patients do not have a side effects like groin pain. And here we don't use the mesh. So chance of infections are very, very less when compared to a transvaginal tape. But even then, care should be taken that we do not injure the obturator vessels, which are very near to the obturator membrane. So, and here the stitch tight should be tension free again. We should not pull the vagina well in so that it should not produce any obstruction. So this is the Bush Colpos suspension, which gives very good results, which can be performed along with other abdominal surgery, or we can do only Bush Colpos suspension if it is necessary. Finally, we will close the peritoneum that was opened in the beginning to start of the surgery with the absorbable sutures like polyglactin, which is popularly called as Vicryl. Later, we can confirm that we do not take a stitch through the bladder or urethra by doing a cystoscopy. Cystoscopy is not a must, but it is safe to do a cystoscopy in all these patients so that inadvertently we are not injured the urethra or the bladder on either side. So in summary, stress urinary incontinence definitely is a disturbing, and some patients do not come forward. So when a patient comes for some other reason, you should ask this history of, if any history of stress urinary incontinence, or if any abdominal surgery or vaginal surgery if you are doing, you should take history that whether the patient is having a stress urinary incontinence. If it is there, definitely it can be treated either physical exercises, pharmacological method, or we can go for a surgery if it is not possible. Most of the time, miragoprine and vibegrain are very good results, giving very good results, mild to moderate of stress urinary incontinence, and then adjuvant with a Kegel's exercise with a various mode. And rings also can be used in those over morbid patients. Usually we go for a vaginal approach, which is less invasive and less costlier. But in those patients we are doing abdominal surgery, then we will go for an abdominal method, or if a vaginal method fails, we can go for an abdominal method. So stress urinary incontinence need not be left alone. So we can have a various way of treating these patients, and then we can bring back their smile. Okay. Thank you for patient listening.
It was a very nice presentation, sir. Only thing, being foreign body, what is the side effects, ma'am?
Okay.
Being foreign body, what could be the complications future, sir, we can expect, because it's a less hygienic area, and people will be not very aware of the hygiene, whether they are following or not. So once you have put the tape, what is the care and what will be the complication at the worst?
Yes, thank you. That's a very good question. So post-operatively, these patients are usually kept for a vaginal estrogen cream, minimum for 6 months, so that mesh erosion does not happen. Because these are usually more post-menopausal patient, estrogen deficiency is there. If you are not getting enough thickness of the vagina during the dissection time, in those time, there is a possibility that the mesh can get exposed. Once the mesh is exposed, then it produces a secondary infection. So to prevent that, estrogen cream is post-operative, they are followed up. And if any small site of infection, if it is present, it should be treated as quickly as possible. But after 1.5 months, usually most of the patients will not have any symptoms due to mesh.
Thank you, sir, for a very good information. As you said, the symptom is only one, but the etiology is multifactorial. The assessment of the patient is one step, and counseling of the patient that she will be cured and to what extent. Yeah, presented very nicely, and thanks you very much for the very good videos. Thank you.
Thank you, sir. Thank you so much.
I request Dr. Karunakar sir to honor our speaker as a token of our appreciation. Now I request Dr. Sri Krishna Bhatt to honor our chairpersons as a token of our appreciation. Now I call upon our next speaker, Dr. Deepak Haldipur sir, who is going to talk on a topic, common misconceptions in treating ENT disease. I call upon Dr. Mohan Appaji sir and Dr. Soumya ma'am to chair the session. I request Dr. Sandra Maria John to introduce our speaker.
A very good morning to everyone gathered here today. It is with great pleasure that I extend a warm welcome to Dr. Deepak Haldipur, a highly respected ENT surgeon whose expertise and dedication have made a significant impact in the field of otorhinolaryngology. An alumnus of the prestigious Bangalore Medical College, Dr. Deepak V. Haldipur is an internationally renowned ENT surgeon who brings immense experience spanning over a period of 3 decades in the field of otorhinolaryngology and head and neck surgery. Currently, he holds the position of Director of ENT and Head and Neck at Trustwell Hospitals, Bangalore. He is one of the foremost ENT surgeons of India who has mastered excellence in skull-base surgeries, both endoscopic, anterior and lateral skull base. He widens his immense knowledge as a mentor surgeon for cochlear implant programs in various institutions and hospitals. With extensive experience in cochlear implants, endoscopic sinus surgeries, ear microsurgeries, laser stepidotomies, thyroid and head and neck surgeries, he is among the few surgeons in the country excelling in these fields. His special interest lies in endoscopic skull-base surgeries, including CSF leak repairs and pituitary surgeries. Embracing technology and innovation, he utilizes state-of-the-art instrumentation to ensure the highest standards of care and optimum patient outcomes. In addition to organizing several seminars, CME courses and conferences at the international, national and regional levels, he has also served as the President of Association of Otolaryngologists of India. He is also an active member of several esteemed otorhinolaryngology societies, including Cochlear Implant Society of India, the Sinus Endoscopic Society of India, the Indian Society of Otology and also the Indian Society of Rhinology. He has delivered multiple talks on various subjects pertaining to head and neck surgery and ENT, contributed articles to prestigious publications, and also performed multiple live surgical demonstrations as guest instructor at various academic events. Apart from the surgical skills, the most notable attribute which stands out is the humane approach to the patient and the ability to treat with a smile, along with an immense passion for teaching. Once again, I welcome you to the dais, sir. I would also like to extend my warm welcome to Dr. Mohan K. Appaji and Dr. Soumya to chair the session.
Good morning, everybody. There is an old saying in English, there are lies, damned lies, and statistics. I would like to modify it a little bit. There are lies, damned lies, and the CVs. There is only one disclaimer: whatever they told about me are all damned lies. Don't take it seriously. This talk is not for the stalwarts and the masters who are sitting in the front 3 rows, because they have reached where they have to reach in life. This talk of mine will be for you guys there, the middle and especially the backbenchers, because all my life, student life, I was a backbencher. And I have one witness here, Dr. Mohan Appaji, who will tell you about that after I finish the talk. If I can become the president of National ENT Association, if I can become the president of Indian Society of Ophthalmology, which I am now, if I was invited by the American Society of ENT to deliver a lecture there, any of the idiots in this gang can do it. What is required is self-belief. Mahendra Singh Dhoni said, to play cricket at top level, it is not just the skill. Skill is second. Confidence is first. So, my talk here today is not about some high-tech things in ENT. No. Today, a medical student feels an MBBS is just like an SSLC. It will take me nowhere. And a post-graduation is like PUC. And only if I do super speciality, I can think I am a doctor. Sorry to use this word, bullshit. There are only 2 types of doctors in the world, the good doctors and bad doctors. 2 hoods to your qualifications. MBBS means Bachelor of Medicine, Bachelor of Surgery. You can do anything as long as you are trained well and skilled enough. And to become a good doctor, you basically require only one good quality. You have to be a good human being. If you are a good human being, you will automatically be a good doctor, because then you will have the only quality which is required to be a good doctor: empathy. If you can actually imagine that the patient is your relative, immediately you will realize as an ENT doctor whether this illness you can treat, or you should refer it to the next best man who is good at that. That's all is what you need to do. This talk of mine is a very simple talk. I'll try to finish it fast. Because one, you are the younger generation and you're used to reels. Your attention span, very difficult. 20 minutes, 15 minutes, TikTok videos. No, not our times. So I would like to keep it very, very short. But I repeat again before I start my talk. If an idiot and a moron like me can be standing here in the podium for IMA and for an institution like KVG started by Kurunji Venkatramana Gowda, you people can do much better than me, man. All the best to you. I think the biggest challenge for me is this, because this I don't know. I'm a technical, I don't know how to use it, or is it not working? You said you press this to do the next. It's not my fault. It's not working. Till he gets it right. One of my junior postgraduates told me, sir, in every talk when you start, the first 2 minutes we find you are a little nervous and then you are very confident. I said, I always wait to see whether the bloody slides will come and the videos will play. Because I trust computers and laptops the least. When they crash, they really crash. It's working. 1990, when I finished MS ENT, I was going in a car, dropping a gynecologist for a delivery. She was a senior gynecologist. And she told me, Dr. Deepak Haldipur, what do you do? I had just finished MS ENT 1 month back. I said, Madam, I am an ENT specialist. She said, that is okay, but what do you do for a living? See, in our department, hysterectomy is there, cesarean is there. ENT only tonsil, and only summer holidays, some cases are there. 1990 February, this was the scene, 34 years back. Today, believe me, tonsillectomy is 0.1% or 1% of all the surgeries I do in the whole year. Not because I learnt lot other surgeries, the indications for tonsillectomy have come down. So this is for all the non-ENT doctors practicing ENT. Bacterial tonsillitis has come down drastically. Post-COVID, I am seeing maximum viral tonsillitis, which becomes aphthous tonsillitis. So because now I am senior, because a donkey can also become a horse after 34 years of ENT practice, I get most of the second referrals. Patient is telling me 14 days of throat pain and I am not able to swallow my saliva, but no temperature. And patient has already been given 3 antibiotics. I withdraw all, give them deflazacort or methylprednisolone for 4 days, probiotic and a good painkiller. 3rd day the patient is fine. Today, tonsillectomy I do more for obstructive sleep apnea. I do more adenoidectomies for ear infections. So if any child or a parent comes to you at the age of 3 saying frequent respiratory infections, please don't blame it on the adenoid and tonsil. You can remember somebody blaming, no, we are okay, last 70 years all the mistakes were done. Like that, adenoids and tonsils, no. Why the frequent infections occur up to the age of 6.5? We are putting children to school, play school by the age of 2. That's the first biggest mistake. Too much of socializing. In Bangalore, if you come on Friday and Saturday, if there's a general holiday in between, Bangalore looks like a resort on Friday, Saturday, Sunday. Because all the jokers have gone to Markera home resort, here, there. Now that 1-3 dip. And when you go in the flight, when you go in the AC cars, buses, so many people, cross infections. And we are advising, get that adenoid removed, get the tonsil removed. The best age to think about adenoidectomy, tonsillectomy is 6.5. Why 6.5? That is when you have cell-mediated immunity. Number 2, your first set of teeth will start falling. The second set is permanent and you don't want the child to have mouth breathing then, because the mid-maxillar development and the facial structure development gets changed. So the indications have come down drastically. Only in 4 types of cases I do adenoidectomy, tonsillectomy before the age of 6. Frequent attacks of ear pain, frequent histories of ear discharge, school complaint or complaint at home, child is not listening or hearing properly, and a restless child, even after maximal medical treatment for allergy and infection, is snoring and turning and tossing. Laryngitis. I have seen lot of doctors prescribing antibiotic for laryngitis. Useless. Either steroids or enzymes work. And one more thing, please remember, whenever you give an antihistaminic, tell the patient the moment the watery secretion of the nose stops, stop the antihistaminic. If you continue it for 1 or 2 days extra, the mucus becomes thicker, they go into sinusitis, chest phlegm becomes thicker, but more important, the vocal cord becomes dry and the voice becomes squeaky or whispery. Antihistamines are the first culprits. So hydrate the larynx and gargle with aloe vera diluted with water. Lymph node hypertrophy, I'll not go into this. This is all really technical. All that I depend on these investigations. But only thing about lymph node, whenever you get a FNAC report of reactive lymphadenitis, be very careful. Look out for lymphoma. Lymphomas are far more common nowadays. And many lymph nodes have been delayed, and the lymphoma diagnosis has been diagnosed. Delayed. Smallest doubt, go for a ultrasound guided core biopsy or the best excision biopsy. It will save a life and so much of headache. Vertigo, one of the most badly treated problems in medical practice across all specialties. The neurologists don't have a clue. The ENT surgeons treat it very badly. For the practicing doctors, I'll give you a simple analogy. Vertigo, remember 90. Okay? The bad fellows like me in the back bench don't think of 90 as something else. Forget Patiala. Okay? 90 means of all the vertigo cases, 90% of them are otogenic, coming from the ear. Out of the 90% vertigos coming from the ear, 90% are due to benign paroxysmal positional vertigo. Out of this 90% of BPPVs, 90% are due to posterior canal BPPV, which can be treated by a simple maneuver called Epley's maneuver. Any physiotherapist can do it in a simple room without any high-tech gadgets. If you can learn to treat a posterior canal BPPV properly by doing an Epley's maneuver, you can treat 64% of all vertigos in the world. And still in ENT itself, this knowledge is not there. We immediately give them either cinerizine or beta-histine. Number 2, these vertigo cases, first think of otogenic. The next biggest component today I see is migraneous vertigo. Migraine in the younger age presents as headache. Once you cross the age of 40, it turns towards vertigo. Nearly 4% of all cases I have seen are migraneous vertigos. Next come the lows. Low BP. High blood pressure has never caused vertigo in mankind. Low BP, low sugar, low hemoglobin, low heart rate. If you have bradycardias, which can be diagnosed by a good Holter valve monitoring, you can diagnose the cardiac vertigos. And these are the ones which cause the vertigo. And finally, very small percentage, 0.3% may be having some disease in the brain. And what do we see? Anybody gets giddiness, check the BP. Oh, high BP. Or do ECG, 2D echo, angio, everything. And then we turn the head like this. It is left posterior canal BPPV. We do a maneuver, it is gone. I am not saying that look down upon the other things. You should know, as it was written in our book, when you make a common diagnosis, you are commonly right. When you make a rare diagnosis, you are rarely right. But if you are a super specialist, always remember, rare things can rarely occur. And your job is to diagnose that. Phobic vertigo. In fact, today, I do have a fairly busy outpatient in Trustwell Hospital. I see around 70 to 75 outpatients every day. I have my witness Mohan Appaji here. Believe me, out of these 75 patients, nearly 45 to 50 of them have some kind of associated anxiety or vertigo. And at least 1/3 of these people, whether they come with throat pain, whether they come with headache, giddiness. 33% of all the illnesses I see in my OPD today have become psychogenic, related to anxiety or depression or both. Why is this happening? I will get into this, though it is non-ENT. Why are we becoming anxious and depressed? Because we have become very focused. Our teachers told us, be focused on your profession, on your job. We forgot the advice. We got focused on ourselves. Morning when you get up and till you sleep, your mind keeps on talking to you. And it always keeps on cheating you. Deepak Haldipur, you are 62 years. You took the bus at 9:35 Airavat from satellite station. You got down at Sullia at 3 o'clock in the night and you came to the lodge. You have seen 70 patients yesterday and you have done 4 surgeries. And now you have to get up here, have breakfast and again give this talk. Then again 11:45 you have to catch another Airavat. You should be getting tired. You should be getting tired. This is what your mind keeps telling you. In Kannada we call it as Nanage Kashta. Whatever problems you have, now you imagine. Suppose you are in Manipur. What is our state? Suppose you are in Gaza Strip. What is our state? After 40 years of medical profession, because I finished my MBBS in 1985. I started my practice 1985 November 28th. I can tell you 3 things. In the world, India is the best country, and after being the president and CEO of AOI and visiting all the states, Karnataka is the best state. And I tell you honestly, being the doctor is the best profession. One minister who had come to my consultation told me, "Sir, you like me, but you don't seem to respect me too much as a minister." I said, "Boss, you can be minister for 5 years, 10 years. Till 4 people carry me to the grave, I am a doctor." It is the fact. I have no VIPs in my practice. Everybody knows it. In my consultation chamber, there are only one set of VIPs. They are called as doctors. Right? And I know Mohan Appaji shares the same sentiment. Vertigo, I spoke already. I don't want to speak so much. Chronic vertigo. There is no term called chronic vertigo in medical field. Please remember, chronic vertigo is idiopathic. Idiot doctor, pathetic patient. The doctor didn't diagnose and treat it properly, so it has become chronic vertigo. This is another disease which all of you will be seeing. Because diabetes, India has become the diabetic capital. I am seeing lot of cases of skull base osteomyelitis or the gangrene of the ear. All of you, please take care of your diabetes. 2016, during my hernia surgery, I was found that my HbA1c was 7.6. Next day, I dropped my lunch. Till date, I eat only 2 meals a day. And weekly 2 days, I eat only 1 meal, OMAD. My HbA1c today is 5.52. No medications. I walk 8 kilometers a day. In the morning, between 5 to 6:30. Now it is known that all the medical diseases are due to only 4 problems. Food, obesity, fatty liver, blah, blah, blah. Tobacco, inactivity or activity. And last, temperament and attitude. Whether you have hair on the top or not, it's not important. What you have inside the skull and how it works is most important. So this is going to be, most of you doctors will be treating a lot of these cases. It has to be with good diabetes control, good antibiotics. Emergencies in otology. If any human being comes to you and says, suddenly I've stopped hearing in 1 year, or if any human being says, I've got tinnitus, which is going on for more than 6 hours, please don't neglect. Get an audiogram done and start intratympanic steroids immediately and IV steroids. You can restore the hearing. It is usually due to vasospasm of the cochlear artery. Please don't delay the treatment, because once you cross the golden 7 days, especially 48 hours, it is lost. And if the patient comes to me or Mohan Appaji after 1 month, there is very little that we can do. Sudden sensory neural hearing loss and sudden tinnitus lasting more than 1 hour is an emergency in ENT. Please treat it aggressively. You can't have a lifelong tinnitus because some doctor was negligent. These are the treatment protocols. Cough. Now, just like any other specialty, I get a lot of patients coming to me also with chronic cough. And I have found 2 categories new in this, which is missed by many people. A lot of these patients are on ACE inhibitors or beta blockers. And unless you withdraw this and see, they will be receiving inhalers, rotahalers, so many things, treatment for reflux. The second category of cough that I have seen in the elderly after COVID or lockdown is anxiety related cough. I have seen it in people above the age of 70. Nocturnal cough, not responding to any medication, responds to anti-anxiety drugs and antidepressive drugs. Adenoids I already spoke. By the way, don't rely on X-ray adenoids. Please go for a diagnostic endoscopy. Very simple test, gives you the correct size of the adenoids. Nasal bleed, we will see it more and more common in summer because we are cutting a lot of trees, too many buildings, too many vehicles, too many air conditioners. So February to May, everywhere in the country you will see nasal bleeding, nasal crusting. Simple solution, dip cotton in water, keep it for 20 minutes in both nostrils, morning, afternoon, evening, take out the cotton after 20 minutes, wipe it with a Johnson bud, remove all the crusts, don't remove it with your fingernails and cause injury. It will encourage more crusts. And then you apply simple petroleum jelly or Vaseline twice a day. Best solution for recurrent epistaxis of summer. That's it, packing, I do spinopattern ligation. One of the biggest overdiagnosed conditions in ENT, even in medical colleges everywhere, deviated nasal septum. By mistake, if you go with loose motion to ENT department, they will take a X-ray PNS and say you have got a DNS. This is the reality. And by the way, so many patients of you will come with phobic breathlessness. Patients with panic disorder, patients with anxiety neurosis, patient with hyperventilation syndrome will be suffocating. And they come and tell you, I can't breathe. Don't go by the endoscopy, X-ray and go ahead and do surgery. Placebo effect, 15 days the patient will be fine. Then he or she will be after your blood. My block is not going, in fact it is increased. So please, this one teaching should happen in medical colleges, in every department. Whether it's Ophthal, ENT, when a patient comes with headache, they should know that there is a psychogenic element and 33% of these patients can be having only anxiety and depression. It's very important. Similarly, I strongly feel in primary school, middle school and high school, we should teach children what do you do when you fail. We are just teaching them how to get 80, 90, 95, 98, almost thinking that if you don't get 98, it's the end of the world for you. It is disturbing to see some 10th standard student or PUC student committing suicide because of performance anxiety. It is because we have not taught them. No? Sinusitis, again overdiagnosed. In fact, sinusitis is a medically treatable condition. 1 or 2% is the one which requires surgery. Ethmoidal polyps, medical treatment, now biologicals have come in, omalizumab, benralizumab, it is giving very good results. I am using omalizumab because ethmoidal polyps, even if you do surgery, a recurrence is a rule rather than an exception. I already spoke about sudden hearing loss. That's it. I have come to the end of the talk. All that I want to tell you guys, don't get carried away by what the software guys earn in the initial phase and all that. After 5 years, 10 years, they are no longer in demand. Half of them will come to your chamber with anxiety, depression, broken marriage, everything. Believe me, medical profession and legal profession is a wonderful profession because you actually see money when you are mature enough to handle it. There is nothing bad about being a doctor. Buggers, you are in the best profession in the world. You better make it count. If I see any of you guys lamenting, I'll be the one to kill you. All the best.
Friends, you just heard Deepak Haldipur talking. He's a very good orator. He has given lectures in so many places, forums, all over India, even at abroad. I know him personally for past 3 decades, more than 3 decades. We started practice together at Bangalore, together. I had a proud privilege of working with him in my beginning of my career. To tell you honestly, he is a master and a teacher for teachers. He's a teacher for teachers, I can say that much. And he is a father of Entrain and Alembic, what is that Alembic? Master class. In fact, he started this program in a country, especially in Bangalore. Now his hospital, Trustwell Hospital, is a tertiary care hospital. I know personally what they are doing because a lot of feedbacks I keep getting. And the complicated case, of course, I refer to him. I call him, when I find difficulty in my surgical practice, I just call him. He guides me, you do this, like this you have to do. So I take advice. Any junior people, any postgraduates can contact him directly if you have any ENT problems, surgical problems, head and neck and all. He's a versatile man, he does everything, master of all. So I said he has groomed many junior consultants, postgraduates, like a medical college it is, his hospital, Trustwell Hospital, especially his department, and they got a DNP seat also now recently. Many junior people, they have trained them and they have gone back to their places. Even they are getting junior people from abroad, from other states also getting trained and going, imparting knowledge, and they are going to their back home, they are delivering the services there. More than that, the first message, take-home message today was, be a good citizen. Your skill academics is next. So being a good citizen is, that's what he was talking initially. being a good citizen in the country is utmost, then you will become a good doctor. Once you are a good citizen, automatically you are a good doctor. So how we praise the profession. In fact, you must, during our COVID times, he spoke on IMA against a minister. He spoke. I forgot that minister name.
Worth forgetting.
Huh?
Worth forgetting, I see.
Yeah. He spoke so loudly it had become viral. Because he criticized the doctor. That's the reason in IMA form he just blasted that minister. He did not see anything because he's so passionate about the medical profession. So our friendship, because this was my institution, for almost more than a decade I worked here. So I love to come here. So organizing madam, she called me, you have to moderate this session. I readily agreed. My good friend is coming here, that's the reason, and plus my old college also. So I love to visit again. Chidanand, our medical director, is here. I met him for the breakfast. So it is nice to share nostalgic moments, which, of course, we did a lot of work in our department when I was here. This KBG was projected up to Srinagar. I presented the cases at Srinagar also. Almost all the CMEs and workshops and conferences I used to present from what we are doing in the KBG ENT department. Thanks for calling organizers. Thanks for calling me, inviting me for this program. Thank you very much. Thank you, our medical director and chairman of this college. Thank you.
Only one thing I can tell about sir is we are very lucky to have an international faculty as a speaker today. Thank you so much, sir. Thank you.
Any questions from
No
the audience?
international. I was a backbencher in Bangalore Medical College, MBBS, MS, ENT. Okay.
Any questions from the audience? Okay. Sir, it was an apt presentation for the wash problems. So it is our honor to be you to be here, and I ask our chairperson to honor our sir, Dr. Deepak Haldipur, for grace.
No, I am happy because me and Mohan Appaji, we conducted a live surgery workshop in this college 10 years back. That time Dr. Chidanand was ill. He could not be there. So I met him today. I missed him that day.
Now I call upon Dr. G.K. Bhatt to honor our chairperson. Dr. Mohan Appaji sir, renowned ENT surgeon in Madikeri.
G.K. ಭಟ್ರು ಒಂದೆರಡು ಮಾತಾಡ್ಬಿಡ್ತೀನಿ ಇವ್ರ ಬಗ್ಗೆ. ಯಾಕೆಂದರೆ ಇವರು ನನಗೆ ತುಂಬ ಆತ್ಮೀಯರು. ಮಡಿಕೇರಿಗೆಲ್ಲ ತುಂಬ ಸಾರಿ ಬಂದಿದ್ದಾರೆ, ನಮ್ಮ ಮನೇಲಿ ಉಳ್ಕೊಂಡಿದ್ದಾರೆ ಇವರು. IMAದು ಏನು ಪ್ರಾಬ್ಲಮ್ ಇದ್ದರೂ ಇವ್ರಿಗೆ ಫೋನ್ ಮಾಡಿದ್ರೆ ಇವರು ನಿಮಗೆ ಸಾಲ್ವ್ ಮಾಡ್ತಾರೆ. ಏನಾರ ಡಾಕ್ಟರ್ಸ್ ಪ್ರಾಬ್ಲಮ್, ಎಂಥ ಪ್ರಾಬ್ಲಮ್ ಇದ್ದರೂ ಹಿ ವಿಲ್ ಸಾಲ್ವ್ ಇಟ್. ಆ್ಯಂಡ್ ಹಿ ಈಸ್ ಅಂಕಲ್ ಆಫ್ ಅವರ್ ರವಿಶಂಕರ್, ಡಾಕ್ಟರ್ ರವಿಶಂಕರ್, ಪ್ರೊಫೆಸರ್ HOD ಆಫ್ ENT ಡಿಪಾರ್ಟ್ಮೆಂಟ್ KBG ಮೆಡಿಕಲ್ ಕಾಲೇಜ್. ಸೊ ಇವರು I want to see him as a president of Karnataka state. Maybe shortly he may become. Wishing him all the good in the career, IMA career.
Thank you, sir.
Dr. Soumya.
Ladies and gentlemen, as we continue with the today's proceedings, it is now time for the inaugural program of our CME. We are honored to have esteemed dignitaries with us to officially mark the commencement of this academic gathering. Let us now proceed with the inauguration program.
It is my immense pleasure to welcome you all. IMA Sullia, in association with IMA Academy of Medical Specialty, is conducting a whole day continued medical education, that is a CME program, together in medicine, exploring every specialty today. So it is my pleasure to invite all the guests are gathered here. I would like to call upon to Dr. K.V. Chidanand, sir, President of Academy of Liberal Education, to inaugurate the function. Also, I welcome upon Dr. Deepak Haldipur, Director of Trustwell Hospital, Bangalore. Dr. Vijayalakshmi Madam, Senior Pediatric Cardiologist, ex-Professor of Sri Jayadeva Institute of Cardiology as well Bangalore Medical College, to grace the occasion. Also, I like to call upon our IMA President, our dynamic lady, Dr. Veena Madam, on the stage. Also, our Secretary, Dr. Ravikant Gio, as well our IMA AMS Secretary, Dr. Shruti Madam, on stage. Also, I welcome everyone who gathered here, delegates as well the speakers over here. Thank you. So now let us call for meeting and calling of the session. So bell has rang. It is time to start our program. So I think let us start the program by prayer by Dr. Nikshay.
अभीष्टवरद श्री महागणपते अभीष्टवरद श्री महागणपते अभीष्टवरद श्री महागणपते आगम वेदान्तरहितपते अभीष्टवरद श्री महागणपते कवीन्द्र रवि विनुता చరణ కమలములు నమ్మిదిని చరణ కమలములు నమ్మిదిని చరణ కమలములు నమ్మిదిని అభీష్టవరద శ్రీ మహాగణపతే అభీష్టవరద శ్రీ మహాగణపతే ఆగమ వేదాంతరహితపతే అభీష్టవరద శ్రీ మహాగణపతే
Now I call Dr. Shruti to give the IMA prayer.
Good morning all. IMA prayer, kindly repeat after me. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Flag salutation. We, the members of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it and realizing our responsibilities as the aggregated members of this national organization. We swear we will dedicate everything in our power to see it fly high in the Committee of Nations. Long live IMA. Thank you.
Thank you, Madam. Now I call upon our active IMA President, Dr. Veena Madam, to address the welcome address to the gathering.
Good morning, everyone. I'm very happy to stand before you to arrange one academic session by IMA Sullia, almost a state level one, because we are having here international speakers. It was very honor to our IMA Sullia as well as to Sullia too. Indian Medical Association started in 1928 in the view of to make allopathic doctor in under one umbrella, and I was thinking our medical students should able to know about IMA, because I heard few people are telling after internship also we never knew IMA was in our place. I'm not telling about in Sullia, all over Karnataka we were not knowing about IMA. So I thought at least our students should know, our postgraduates should know about IMA, and IMA is the only one which can help us in our journey, whatever Deepak Kaldipur sir said, to achieve the heights whatever they are achieved. Only thing is required is the commitment to our subject. Whatever I had asked the Deepak Kaldipur sir, why you took ENT? Did you have passion in ENT when you were MBBS? ENT siktu adakke serde bere enu yochane madilla. That's what he had said. Alla sir, ಯಾಕೆ ENT ತಕೊಂಡ್ರಿ ಅಂತ ಕೇಳಿದಾಗ ENT ಸಿಕ್ಕಿತು ಸೇರಿದೆ ಅಷ್ಟೇ. But he reached the height. It's dream of every ENT surgeon or anybody to become like Deepak Kaldipur sir. So I'm very happy to welcome Deepak Kaldipur sir in behalf of IMA Sullia AMS and all of you. Thank you sir. And Dr. Chidanand sir is the founder president of Sullia IMA, and sir is always happy because Sullia was the first IMA to become like all life members. All 40 members were life members. This is important because when IMA was started, there was a yearly membership and life membership. So many people wanted to become the yearly member. They were not ready to become the life members. And sir was strict in becoming, everyone is the life member. That's why Sullia, when it started, all life members, and now also we are all life members. But on the contrary, now Indian Medical Association is removed the yearly membership. It's like all members are now life members only. And whichever program we do from Indian Medical Association, whatever program, sir is there with us and his support is there always with us. I heartily welcome you, sir, from Indian Medical Association Sullia, IMA Sullia chapter, and all your beloved students of KVG Medical College, undergraduates, house surgeons and postgraduates and our faculties. Thank you, sir. Welcome, sir. And Vijayalakshmi Balekundri, madam is next to going to deliver her lecture, and what Vijayalakshmi madam, they will be telling you before. I don't want to tell all those things, but she is sweet 74. I said yesterday, sweet 16. Illamma 74, she said. And the enthusiasm she has. She is a first pediatric cardiology, cardiac internist of South India. I am very happy, madam, here come to Sullia. She is coming second time to Sullia. She had come to our college. For IMA, she is coming for first time. I am heartily welcome you, sir. You, madam. And why IMA? We are always thinking, we know now every day one or the other things are happening in the society and doctors are blamed for that. And we have to remember, sir was telling we have to have manaviyate, manushyatva, everything. But when we treat the patient get cured from us, but when we are in the bad position, nobody will come and rescue us other than the other doctor or the Indian Medical Association. And we have a Karnataka Professional Protection Scheme. Once you become a member, I am a member only, you can become the KPPS member. And we have a social security scheme to become all those things, to take the advantage of Karnataka Professional Protection Scheme and Social Security Scheme, Karnataka Health Scheme. We have to become IMA member. I am requesting all of the interns and postgraduates and the undergraduates, once you register and in the KMC, after your KMC registration is over, please become IMA member in your respective places. There is no problem. And if at all you want to go to the other state or other district or other branch, there is a transfer. There is no problem. We won't charge also for transferring. You can get a transfer. So I am very happy to see all of you. And Indian Medical Association's other objective is to conduct continuous medical education and our together in medicine, exploring every speciality. And it is the speciality era. Sir said MBBS means we are thinking it is just SLC and speciality is like PUC. But whatever speciality we are, we should be knowing the other speciality also. To Sir said, so we have to know this is our speciality or to refer whom in the golden time, so that the patient will be getting the best of best from us. So that is another objective of IMA. That's why we are arranging CME here. And 1974, Academy of Medical Specialties also started. That chapters we started in Sullia also. So in this, all the speciality they can register, and we are made a chapter. Only our motto is we should be updated with every speciality. We should not tell in front of patient, this I don't know, this is new to me, because we know the patients are, now everything they will see in the Google and they will come. So we should be updated. That is the importance of continuous medical education. I am very happy to make the program here, and I welcome everyone, the faculties, speakers, and the chairpersons, and all the dedicates, and our chief guest, and our president, our honorary secretary, Dr. Ravikant, and IMA chapter secretary Shruti. Welcome you all. Thank you, one and all.
It is our tradition to inaugurate the function with lighting the lamp. I am call all our dignitaries to light the lamp, and yeah.
सम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तु ते ओ दीपब्रह्मरूपस्थं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्थं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छां हि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठे गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः
It is the time to welcome and Dr. Vijayalakshmi Madam, my teacher in BMCRI. Also, she is the chief guest of this occasion to address the gathering.
Om Shri Gurubhyo Namaha. It's a pleasant pleasure and proud privilege to be here in IMA and IMAS of Sullia. Sullia ಅಂತಂದರೆ ಸುಂದರವಾದ ಲಯಬದ್ಧವಾದ ಲವಲವಿಕೆಯ ಊರು ಸುಳ್ಯ ಅಂತ ಹೇಳ್ಬೋದು. ನಿಮಗೆ ಅನಿಸಿರ್ಬೋದು ಇಷ್ಟೊಂದು ಬೆಳಕಿದೆ, ಇಷ್ಟೊಂದು ಲೈಟ್ಗಳಿದೆ, ದೀಪ ಯಾಕೆ ಬೆಳಗಿಸಿದ್ರು ಅಂತ ಕೇಳ್ಬೋದು. ಯಾಕೆ ಅಂತಂದರೆ ಎಲ್ಲರಿಗೂ, ಅದರಲ್ಲೂ ಡಾಕ್ಟ್ರುಗಳಿಗೆ ಅತ್ಯಂತ ಪ್ರಮುಖವಾದಂಥದ್ದು ಈ ದೀಪ ಬೆಳಗಿಸೋದು. ಅದರಲ್ಲಿ ಇರೋ ಎಣ್ಣೆ ಅಹಂಕಾರದ ಸಂಕೇತ, ಬತ್ತಿ ಅಜ್ಞಾನದ ಸಂಕೇತ, ದೀಪ ಜ್ಞಾನದ ಸುಜ್ಞಾನದ ಸಂಕೇತ. ಪ್ರತಿಯೊಬ್ಬರಲ್ಲೂ ಅಹಂಕಾರವನ್ನು ಇಂಗಿಸಿ ಅಜ್ಞಾನವನ್ನು ಉರಿಸಿ ಸುಜ್ಞಾನವನ್ನು ಬೆಳಗಿಸಿ ಎಲ್ಲರನ್ನೂ ಸುರಕ್ಷಿತವಾಗಿ ಉತ್ತಮ ಆರೋಗ್ಯವಂತರಾಗಿ ಮಾಡೋದೇ ಈ ದೀಪ ಬೆಳಗಿಸೋದು. ಒಂದೊಂದೇ ಹಚ್ಚಿದಾಗ ಅದು ಉರಿಲಿಲ್ಲ, ಎಲ್ಲವನ್ನೂ ಸೇರಿದಾಗ ಉರಿತಾ ಇದೆ. ಅದು ಇನ್ನೊಂದು, ಡಾಕ್ಟ್ರುಗಳು ನಿಮ್ಮಲ್ಲೇ ಜಲಸಿ ಇರಬಾರ್ದು. ವಿ ಆರ್ ಆಲ್ ಒನ್ ಫ್ಯಾಮಿಲಿ. ಡಾಕ್ಟ್ರುಗಳು ಒಂದು ಅನ್ನೋ ಭಾವನೆ, ಯುನೈಟೆಡ್ ವಿ ಸ್ಟ್ಯಾಂಡ್ ಅನ್ನೋದನ್ನು ನಾವು ಅರ್ಥ ಮಾಡ್ಕೊಳ್ಬೇಕು. ಹಳದಿಪುರ ಅವರು ಹೇಳಿದರು ಎಂಪತಿ ಅಂದರು. ಎಂಪತಿ ಅನ್ನೋದಕ್ಕೆ ನಮ್ಮಪ್ಪ ನನಗೆ ಹೇಳಿದ್ದನ್ನು ನಿಮಗೆ ಹೇಳ್ಕೊಡ್ತಾ ಇದ್ದೀನಿ. ನನ್ನ ತಾಯಿಗೆ ನಾನೇ ಆ್ಯಂಜಿಯೋಗ್ರಾಮ್ ಮಾಡಿದೆ. ಆ್ಯಂಜಿಯೋಪ್ಲಾಸ್ಟಿ ಸಕ್ಸಸ್ಫುಲ್ ಆಗಲಿಲ್ಲ. ವಿ ಕುಡ್ ನಾಟ್ ಕ್ರಾಸ್ ದ ಲೀಷನ್. ಬೈಪಾಸ್ ಹೇಳಿದಾಗ ನನ್ನ ಅಕ್ಕ ತಮ್ಮ ಎಲ್ಲ ಕೇಳಿದರು ಗ್ಯಾರಂಟಿ ಕೊಡು ಅಂತ. ಗಾಬರಿ ಆಗಿಬಿಟ್ಟು ಅಪ್ಪನ ಕೇಳಿದೆ, ಅಪ್ಪ ಏನು ಹೇಳಲಿ ಅಂತ. ನಮ್ಮಪ್ಪ ಅಂದರು, ಊರವರೆಲ್ಲ ನಿನ್ನ ಹತ್ರ ಬರ್ತಾರೆ. ವಾಟ್ ಎವರ್ ಡಿಸಿಷನ್ ಯು ಟೇಕ್ ಫಾರ್ ಅದರ್ಸ್, ಯು ಟೇಕ್ ಫಾರ್ ಯುವರ್ ಮದರ್. ರಿಮೆಂಬರ್ ಒನ್ ಮೋರ್ ಥಿಂಗ್, ವಾಟ್ ಎವರ್ ಡಿಸಿಷನ್ ಯು ಟೇಕ್ ಫಾರ್ ಯುವರ್ ಮದರ್, ಲರ್ನ್ ಟು ಟೇಕ್ ಫಾರ್ ಅದರ್ಸ್ ಅಂತ. ಇದು ನಾವು ಕಲಿಬೇಕಾದಂಥದ್ದು. ಪ್ರತಿಯೊಬ್ಬರು ನಮ್ಮ ಹತ್ರ ಬಂದವರು ನಮ್ಮ ಕುಟುಂಬದವರು ನಮ್ಮವರು ಅನ್ನೋ ಭಾವನೆ ಇದ್ದರೆ ನಾವು ಯಾವತ್ತೂ ಯಾರಿಗೂ ಮೋಸ ಮಾಡೋದಿಲ್ಲ, ಉತ್ತಮವಾದಂಥ ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಡ್ತೀವಿ ಅಂತ. ಹಾಗಾಗಿ ಈ IMA ವೀಣಾ ಅತ್ಯಂತ ಶ್ರಮಜೀವಿಗಳು, ಶ್ರದ್ಧೆಯಿಂದ ಮಾಡುವಂಥವರು. ಅವರ ಪ್ರೀತಿ ಮೇಲೆ ನಾನು ಕುಂಭಮೇಳದಿಂದ ನೇರವಾಗಿ ಇಲ್ಲಿಗೆ ಬಂದಿದ್ದೀನಿ. ಹಾಗಾಗಿ ವೀಣಾ ಅವ್ರ ಜೊತೆಗೆ ನಾವೆಲ್ಲರೂ ಕೈ ಜೋಡಿಸಿ ಈ ಸುಳ್ಯದಲ್ಲಿ ಇರುವಂಥ ಎಲ್ಲ ವೈದ್ಯರು ಅತ್ಯಂತ ಉತ್ತಮಕ್ಕಾಗಲಿ, ಅದರಲ್ಲೂ ಕೂಡ ನಿಮ್ಮ ಮೆಡಿಕಲ್ ಕಾಲೇಜಲ್ಲಿ ಓದಿದಂಥ ಮಕ್ಕಳು ವಿಶ್ವವಿಖ್ಯಾತರಾಗಲಿ ಅಂತ ಹಾರೈಸ್ತಾ, ಭಗವಂತ ನಿಮ್ಮೆಲ್ಲರಿಗೂ ಆರೋಗ್ಯ, ಆಯುಷ್ಯು, ಸಂಪತ್ತು, ಸಮೃದ್ಧಿ, ನೆಮ್ಮದಿ, ಯಶಸ್ಸು, ತೇಜಸ್ಸು, ವರ್ಚಸ್ಸು, ಓಜಸ್ಸನ್ನು ಕೊಟ್ಟು ಸುಳ್ಯದ ಹೆಸರನ್ನು ವಿಶ್ವವಿಖ್ಯಾತ ಮಾಡಿ ನಮ್ಮ 2ನೇ ಮಣಿಪಾಲ್ ಮಾಡೋ ಹಾಗೆ ಆಗಬೇಕು ಅಂತ ಹಾರೈಸ್ತಾ ನನ್ನ ಮಾತನ್ನು ಮುಗಿಸ್ತೀನಿ. ಶುಭವಾಗಲಿ. ನಮಸ್ಕಾರ.
Thank you, madam. Now I call upon Dr. Deepak Haldipur, sir, to address the gathering.
I spoke almost everything. Okay, maybe one more point. Whatever specialty you take, I think Kannada, a lot of you understand? Yeah. ನೀವು ಯಾವುದೇ ಒಂದು ವಿಷಯ ಅಥವಾ ವ್ಯಕ್ತಿ ವಿಷಯದಲ್ಲಿ ನೀವು ಪರಿಣಿತಿ ಪಡೆದ ಮೇಲೆ, ನೀವು ಒಳ್ಳೆ ವ್ಯಕ್ತಿ ಆದಮೇಲೆ, ಒಳ್ಳೆ ಡಾಕ್ಟರ್ ಆದಮೇಲೆ ಇನ್ನೊಂದು ವಿಷಯ ನೆನಪಿಟ್ಕೊಳ್ಳಿ, ತುಂಬ ಗಂಭೀರ ವ್ಯಕ್ತಿ ಆಗಬೇಡಿ. ಗೌತಮ್ ಗಂಭೀರ್ ಆಗಬೇಡಿ, ವೀರೇಂದ್ರ ಸೆಹ್ವಾಗ್ ಆಗಿ. ಆದ್ರಿಂದ ಆಲ್ವೇಸ್ ಹ್ಯಾವ್ ಎ ಸೆನ್ಸ್ ಆಫ್ ಹ್ಯೂಮರ್, ಆಲ್ವೇಸ್ ಹ್ಯಾವ್ ಎ ಸ್ಮೈಲ್ ಆನ್ ಯುವರ್ ಫೇಸ್. ನನ್ನ ಪೇಷಂಟ್ಸ್ ತುಂಬ ಜನ ನನಗೆ ಹೇಳ್ತಾರೆ, ಸರ್ ನಿಮ್ಮನ್ನು ನೋಡಿದ ಮೇಲೆ, ನಿಮ್ಮ ಹತ್ರ ಮಾತಾಡಿದ ಮೇಲೆ ಅರ್ಧ ಕಾಯಿಲೆ ವಾಸಿ ಆಗೋಯ್ತು ಸರ್ ಅಂತ. ತಕ್ಷಣ ನಾನು ಹೇಳ್ತೀನಿ, ಇನ್ನೊಂದು ಅರ್ಧಕ್ಕೆ ಮೋಹನ್ ಅಪ್ಪಾಜಿ ಹತ್ರ ಹೋಗಿ ಅಂತ. ಆ ಥರ ನಾರ್ತ್ ಇಂಡಿಯಾದಲ್ಲಿ ಹೇಳ್ತಾರೆ ಖಡೂಸ್ ಆದ್ಮಿ ಅಂತ. ನಿಮ್ಮನ್ನು ನೋಡಕ್ಕೆ ಬಂದ ಪೇಷಂಟ್ಗೆ, ನಿಮ್ಮನ್ನು ಮೀಟ್ ಆಗಿ ಬಂದ ಫ್ರೆಂಡ್ಗೆ, ನಿಮ್ಮ ಫ್ಯಾಮಿಲಿ ರಿಲೇಟಿವ್ಸ್ಗೆ ಏನಪ್ಪ ಇವನೊಬ್ಬ ಬಂದ ಪೀಡೆ ಅಂತ ಅನ್ನಿಸ್ಬಾರ್ದು ಅಲ್ವಾ? ಈ ದೀಪಕ್ ಹಳ್ದಿಪುರ್ 2ನೇ ಸಲ ಸ್ಟೇಜ್ ಮೇಲೆ ಬಂದಂಗೆ, ಗುರು ಬಂದ ಇವನು ಮತ್ತೆ ಪಿಟೀಲ್ ಕುಯ್ತಾನೆ ಇವಾಗ ಅಂತ. ಸೊ ಬಿ ಆಲ್ವೇಸ್ ಹ್ಯೂಮರಸ್. ದ ಬಿಗ್ಗೆಸ್ಟ್ ಬೆನಿಫಿಷಿಯರಿ ವಿಲ್ ಬಿ ಯು, because at the end of a 11-hour working day, you will go back home with a smile on your face and a song on your lips. I am telling certain things not because I am trying to tell you I am something. I am just sharing what I do. Again, Mohan Appaji knows I work 11 hours non-stop every day, morning 8 to evening 7. My logic is simple, 11 and 13. I give 11 hours to life, and life gives me 13 hours, 6 days a week. And those 13 hours are mine. Nobody dares ask me what I do. It is my personal time. But those 11 hours, I work in all seriousness. I don't believe in what Narayan Murthy said or what somebody else said, how many hours. If each one of you can work 48 hours a week, that is 8 hours 6 days, or 9.5 hours 5 days, and those bloody hours you better be bloody serious. The remaining you enjoy your life. All the best. God bless you.
Thank you, sir. You have given a wonderful message to the gathering. Now I call Dr. K.V. Chidanand, sir, founder president of IMA, the inspiration to the program, to address the gathering.
ಎಲ್ಲರಿಗೂ ಶುಭ ಮುಂಜಾನೆ. ವೇದಿಕೆಯಲ್ಲಿ ಉಪಸ್ಥಿತರಿರುವಂತಹ ಈ ದಿವಸ ನಮ್ಮ ಮುಖ್ಯ ಅತಿಥಿಗಳಾದಂತಹ ಡಾಕ್ಟರ್ ವಿಜಯಲಕ್ಷ್ಮಿ ಅವರೇ, ಡಾಕ್ಟರ್ ದೀಪಕ್ ಹಳದಿಪುರ್ ಅವರೇ, ಹಾಗೂ ನಮ್ಮ ಇಂಡಿಯನ್ ಮೆಡಿಕಲ್ ಅಸೋಸಿಯೇಷನ್ನ ಅಧ್ಯಕ್ಷರಾದಂಥ ಡಾಕ್ಟರ್ ವೀಣಾರವರೇ, ಹಾಗೂ ಸೆಕ್ರೆಟರಿ ಆದಂಥ ಡಾಕ್ಟರ್ ರವಿಕಾಂತ್ರವರೇ ಹಾಗೂ ವೇದಿಕೆ ಮುಂಭಾಗದಲ್ಲಿರುವಂತಹ ಎಲ್ಲ ನಮ್ಮ ವೈದ್ಯಕೀಯ ಬಂಧುಗಳೇ ಹಾಗೂ ಇದರ ಸೆಕ್ರೆಟರಿ ಆಫ್ ಅಕಾಡೆಮಿ ಆಫ್ ಮೆಡಿಕಲ್ ಸ್ಪೆಷಾಲಿಟಿದು ಶ್ರುತಿ ರೈ ಅವರೇ, ಭಾಳ ಒಂದು ಉತ್ತಮ ಒಂದು ಕಾರ್ಯಕ್ರಮ ಈ ದಿವಸ ನಮ್ಮ ಇಂಡಿಯನ್ ಮೆಡಿಕಲ್ ಅಸೋಸಿಯೇಷನ್ ಸುಳ್ಯದವರು ಹಾಕ್ಕೊಂಡಿದ್ದಾರೆ. ಆಫ್ಟರ್ ಲಾಂಗ್ ಟೈಮ್, ಬಹುಶಃ ನಾನು ಇನ್ನು 90s I have conducted the state IMA conference for executive committee members of Indian Medical Association. ಆವಾಗ ಎಮಿನೆಂಟ್ ಸ್ಪೀಕರ್ಸ್ ಎಲ್ಲ ಆವಾಗ ಬಂದಿದ್ದರು. ಬಟ್ ಆವಾಗ ನೀವೆಲ್ಲ ಯಾರಿರಲಿಲ್ಲ, ಮೆಡಿಕಲ್ ಸ್ಟೂಡೆಂಟ್ಸ್ ಎಲ್ಲ ಯಾರಿರಲಿಲ್ಲ. ಐ ಹ್ಯಾಡ್ ಓನ್ಲಿ ಡೆಂಟಲ್ ಸ್ಟೂಡೆಂಟ್ಸ್. ಡೆಂಟಲ್ನಲ್ಲಿ ಅವರಿಗೆ ಮೆಡಿಕಲ್ ಆ್ಯಂಡ್ ಸರ್ಜರಿ ಸೆಕ್ಷನ್ ಇದೆ. ಐ ಯೂಸ್ ಟು ಮೇಕ್ ದೆಮ್ ಸಿಟ್ ದೇರ್ ಆ್ಯಂಡ್ ಕಂಡಕ್ಟ್ ದೀಸ್ ಪ್ರೋಗ್ರಾಮ್ಸ್. ಅದರ್ವೈಸ್ only few members were there in IMA Sullia. Though 40 life members, ಆ್ಯಕ್ಟಿವ್ ಆಗಿದ್ದದು ಒಂದು 25 ಜನ ಮಾತ್ರ. ಆದರೆ ಇವತ್ತು ಬರೋ 4 ಜನರು ಸಹ MBBS ಲೆವೆಲ್ನಲ್ಲಿ ಆ್ಯಕ್ಟಿವ್ ಆಗಿಲ್ಲ. ದಟ್ ಈಸ್ ದಿ ಟ್ರಾಜಿಡಿ ಆಫ್ ದಿ ಪ್ರೆಸೆಂಟ್ ಸಿಚುವೇಶನ್. ಆದರೆ ಈಗ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ಇರೋದ್ರಿಂದ ಆಲ್ ದಿ ಪೋಸ್ಟ್ ಗ್ರ್ಯಾಜುಯೇಟ್ಸ್ ಆರ್ ಬೇಸಿಕಲಿ MBBS ಆ್ಯಂಡ್ ದೇ ಆರ್ ಇಂಡಿಯನ್ ಮೆಡಿಕಲ್ ಅಸೋಸಿಯೇಷನ್ ಮೆಂಬರ್ಸ್. ಮತ್ತು ಅಸೋಸಿಯೇಟ್ ಮೆಂಬರ್ಸ್ MBBS ಲೆವೆಲ್ನಲ್ಲಿ ಆಗಲಿಕ್ಕೆ ಸಾಧ್ಯ ಇದೆ. ಅದರಿಂದಾಗಿ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮ ಈ ದಿವಸ ವಿತ್ ಸೂಪರ್ ಸ್ಪೆಷಾಲಿಟೀಸ್, ನಮ್ಮಲ್ಲಿ ಬೇಕಷ್ಟು ಮೆಡಿಕಲ್ ಟೀಚರ್ಸ್ ಇದ್ದಾರೆ, ಮೆಡಿಕಲ್ ಸ್ಪೆಷಾಲಿಟಿ ಸೆಕ್ಷನ್ ಇದೆ. ಆದರೆ ಇವುಗಳೆಲ್ಲ ಏನು ಮಾಡ್ತಾ ಇದ್ದಾರೆ ಅಂತೇಳಿ ಹೇಳುವಂಥದ್ದು ಈಗ ಬಡ್ಡಿಂಗ್ ಡಾಕ್ಟರ್ಸ್ಗಳಿಗೆ ಅರ್ಥ ಆಗಬೇಕು ಅಂತೇಳಿ ಹೇಳಿದರೆ, ಬಹುಶಃ ಇಂಥ ಸೂಪರ್ ಸ್ಪೆಷಲಿಸ್ಟ್ಸ್ ಬಂದು ನಿಮ್ಮ ಮನೆ ಬಾಗಿಲಿಗೆ ಬಂದು ನಿಮ್ಮನ್ನು ಅಡ್ರೆಸ್ ಮಾಡಲಿಕ್ಕೆ ಇರುವಂಥ ಇದು ವಿಶೇಷ ಅಂತೇಳಿ ಹೇಳ್ಬೋದು. ಇಂಡಿಯನ್ ಮೆಡಿಕಲ್ ಅಸೋಸಿಯೇಷನ್ ಸುಳ್ಯ ವೀಣಾ ಅವರ ಲೀಡರ್ಶಿಪ್ನಲ್ಲಿ ಅವರು 1 ತಿಂಗಳಿಂದ ಹೋರಾಡೋದನ್ನು ನೋಡಿದರೆ ನಮಗೆ, ನಾನು ನಿನ್ನೆ ಕೇಳಿದ್ದುಂಟು, ನಿಮಗೆ ಬಹುಶಃ ಈ ಡಾಕ್ಟರ್ ಚಿದಾನಂದ ಯಾಕೆ IMA ಸ್ಟಾರ್ಟ್ ಮಾಡಿದೆ ಅಂತೇಳಿ ಆಗಿರಬೇಕಲ್ವ ಅಂದೇಳಿದೆ. ನಾನು IMA ಇಲ್ಲಿ ಸ್ಟಾರ್ಟ್ ಮಾಡಿದ್ರಿಂದ ಇವತ್ತು ಇಷ್ಟೆಲ್ಲ ಪ್ರೋಗ್ರಾಮ್ಗಳು ಅದಿದ್ದು ಆಗಬೇಕಲ್ವ, ಆ ಜಾಗ ಯಾಕೆ ತೆಗೆದ್ರು ಅಂದೇಳಿ ಆಗ್ತದೆ ಅಂದೇಳಿ ಆಗಿರ್ಬೋದು ಅಂದೇಳಿ ಹೇಳಿದೆ. ಅವರು ಒಪ್ಪಿಕೊಂಡ್ರದಕ್ಕೆ. ಯಾಕೆಂದರೆ ನಾವು ಒಂದು ಪ್ರಾರಂಭ ಮಾಡೋದು ದೊಡ್ಡದಿಲ್ಲ, ಅದನ್ನು ಉತ್ತಮವಾಗಿ ನಡೆಸಿ ಅದರಿಂದ ಪ್ರಯೋಜನವನ್ನು ಪಡೆಯುವಂಥದ್ದು ಭಾಳ ಮುಖ್ಯವಾದ್ದು. ಆದರೆ ನಮ್ಮ ಇಂಡಿಯನ್ ಮೆಡಿಕಲ್ ಅಸೋಸಿಯೇಷನ್ ಸಿನ್ಸ್ ವಿ ಹ್ಯಾವ್ ಸ್ಟಾರ್ಟೆಡ್, ವಿ ಹ್ಯಾವ್ ಕಂಡಕ್ಟೆಡ್ ಸೋ ಮೆನಿ ಕ್ಯಾಂಪ್ಸ್. ನಾವು ಮೆಡಿಕಲ್ ಎಜುಕೇಷನ್ ಅಂದರೆ ಏನು ಅಂತೇಳಿ ಹೇಳುವಂಥದ್ದನ್ನು ಪಬ್ಲಿಕ್ಸಿಗೆ ಭಾಳಷ್ಟು ಹೇಳಿದ್ದೇವೆ ಮತ್ತು ಭಾಳಷ್ಟು ಸರ್ವಿಸ್ ಸಹ ಕೊಟ್ಟಿದ್ದೇವೆ. ನಮ್ಮ ಮೆಡಿಕಲ್ ಕಾಲೇಜಿನ ಒಂದು ಹಂತದಲ್ಲಿ ನಾವು ಭಾಳಷ್ಟು ಮಂದಿಗೆ ಉತ್ತಮ ರೀತಿಯ ಚಿಕಿತ್ಸೆಯನ್ನು ಕೊಡುವಂತೆ ಸಹ ಆಗಿದೆ. ಅದನ್ನೆಲ್ಲ ಈ ದಿವಸ ಬಹುಶಃ ನಿಮ್ಮ ಮುಖಾಂತರ, ಈಗ ನೀವೇನು ವೈದ್ಯರುಗಳಿದ್ದೀರಿ, ಪೋಸ್ಟ್ ಗ್ರ್ಯಾಜುಯೇಟ್ಸ್ ಇದ್ದೀರಿ, ನೀವೆಲ್ಲ ಸೇರಿಕೊಂಡು ಪ್ರತಿನಿತ್ಯವೂ ನಮ್ಮ ಪ್ರತಿ ತಿಂಗಳಲ್ಲಿ 1-2-3 ಕ್ಯಾಂಪ್ಗಳನ್ನಾದರೂ ಮಾಡ್ತಾ ಇದ್ದೀರಿ. ಅದನ್ನೆಲ್ಲ ಮಾಡುವಾಗ ಬಹುಶಃ ಯಾವ ರೀತಿಯಲ್ಲಿ ನಾವು ಕೆಲವು ಕಷ್ಟಕರವಾದಂಥ ಒಂದು ಚಿಕಿತ್ಸಾ ವಿಧಾನಗಳು ಬೇಕಿದ್ದರೆ ಅದನ್ನು ಯಾವ ರೀತಿ ಕೊಡಬೇಕು ಅಂತೇಳಿ ಹೇಳುವಂಥದ್ದು ಭಾಳ ಮುಖ್ಯ. ನಾವು ಪ್ರಾರಂಭ ಮಾಡಿದಾಗ ಬಹುಶಃ ಮೆಡಿಕಲ್ ಎಜುಕೇಷನ್ ಆಗಲಿ ನಮ್ಮ ಈ ಆರೋಗ್ಯದ ದೃಷ್ಟಿಯಲ್ಲಿ ಇಷ್ಟೊಂದು ಅಡ್ವಾನ್ಸ್ ಆಗಿರಲಿಲ್ಲ. ನಾವು ಓದುವಾಗ ಇರ್ಬೋದು, ಅಲ್ಟ್ರಾಸೌಂಡ್ ಇರಲಿಲ್ಲ, CT ಸ್ಕ್ಯಾನ್ ಇರಲಿಲ್ಲ, MRI ಇರಲಿಲ್ಲ, ಏನಿಲ್ಲ, ಒಂದು ಎಕ್ಸ್ರೇ ಇತ್ತು ಮತ್ತು ಫ್ಯೂ ಬ್ಲಡ್ ಎಕ್ಸಾಮಿನೇಷನ್. ಒಂದು GRBS ಮಾಡುವಷ್ಟು ಸಹ ಆವಾಗ ಯಾರಿಗೇನು ನಮ್ಮ ನಾನು ಓದಿದಂಥ ಮೈಸೂರು ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ನಲ್ಲೇ ಒಂದು ಬ್ಲಡ್ ಶುಗರ್ ಮಾಡಬೇಕಿದ್ರೆ ನಮಗೆ 18 hours to 20 hours ಬೇಕಾಗ್ತಿತ್ತು. ಆದರೆ ಇವತ್ತೆಲ್ಲ ಆಧುನಿಕತೆ ಬಂದದ್ರಿಂದ ಆಧುನಿಕತೆ ದೃಷ್ಟಿಯಲ್ಲಿ ನಾವು ಪ್ರತಿಯೊಂದು ವಿಚಾರಗಳನ್ನು ತಿಳಿದು ನಮ್ಮ ನಾಲೆಜನ್ನು ಸಹ ಆಧುನಿಕತೆಗೆ ಸರಿಯಾಗಿ ನಾವು ಅಷ್ಟೇ ವೇಗವಾಗಿ ಹೋಗಬೇಕಾಗಿದೆ. ಈಗ ಮೊನ್ನೆ ಒಂದೆರಡು ಪ್ರೋಗ್ರಾಮ್ ಮಾಡಿದರು ಆರ್ಟಿಫಿಷಿಯಲ್ ಇಂಟೆಲಿಜೆನ್ಸ್ ನಮ್ಮ ಈ ಚಿಕಿತ್ಸಾ ವಿಧಾನವನ್ನು ಇನ್ನೂ ಹೆಚ್ಚಿನ ವೇಗದಲ್ಲಿ ಮಾಡಲಿಕ್ಕಿರುವಂಥ ಹಲವಾರು ಒಂದು ಕಾರ್ಯಕ್ರಮಗಳಲ್ಲಿ ಅದು ಒಂದು. ಅದರಿಂದಾಗಿ ನಾವು ಆಧುನಿಕತೆಯಲ್ಲಿ ಯಾವ ರೀತಿ ಮುಂದುವರಿತಾ ಇದ್ದೇವೆ ಅದನ್ನೆಲ್ಲ ತಿಳ್ಕೊಂಡು ಮುಂದೆ ಹೋಗಬೇಕು ಅಂತ ಹೇಳಿದರೆ ಇಂಥ ಕೆಲವು CME ಪ್ರೋಗ್ರಾಮ್, ಕಂಟಿನ್ಯೂಡ್ ಮೆಡಿಕಲ್ ಎಜುಕೇಷನ್ ಪ್ರೋಗ್ರಾಮ್ ಮಾಡುವಂಥದ್ದು ಭಾಳ ಮುಖ್ಯವಾದ್ದು. ಇವತ್ತು ಎಮಿನೆಂಟ್ ಸ್ಪೀಕರ್ಸ್ ಈಗ ಬೆಳಗ್ಗೆಯಿಂದ ನಾವು ಕೇಳ್ತಾ ಇದ್ದೇನೆ, ಗೀತಾದಪ್ಪ ಅವರು HPV ವ್ಯಾಕ್ಸಿನೇಷನ್ ಹೇಳಿದರು. ಇದೊಂದು ಮೋಸ್ಟ್ ಇಂಪಾರ್ಟೆಂಟ್ ಥಿಂಗ್ ಇನ್ ಇಂಡಿಯಾ ದಿಸ್ ಪ್ರೋಗ್ರಾಮ್. ಯಾಕೆಂದರೆ ಭಾಳಷ್ಟು ಕ್ಯಾನ್ಸರ್ ಪೀಡಿತ ವ್ಯಕ್ತಿಗಳಿಗೆ, ಅಂದರೆ ಹೆಂಗಸರಿಗಾಗಿರ್ಬೋದು ಗಂಡಸರಿಗಾಗಿರ್ಬೋದು, ಎಸ್ಪೆಷಲಿ ಫಾರ್ ಸರ್ವೈಕಲ್ ಕ್ಯಾನ್ಸರ್ ಆ್ಯಂಡ್ ಅದರ್ ಕ್ಯಾನ್ಸರ್ಸ್, ಈ ಸ್ಕೂಲ್ ಆ್ಯಂಡ್ ಕಾಲೇಜ್ ಲೆವೆಲ್ನಲ್ಲಿ ಹೌ ಯು ಕ್ಯಾನ್ ವ್ಯಾಕ್ಸಿನೇಟ್ ಆ್ಯಂಡ್ ಪ್ರಿವೆಂಟ್ ಇಟ್ ಅಂತೇಳಿ ಹೇಳುವಂಥದ್ದು. ಇದನ್ನು ಬಹುಶಃ ಎಲ್ಲರಿಗೆ ಗೊತ್ತು ಮಾಡಬೇಕು ಅಂತೇಳಿ ಹೇಳಿದರೆ ಇಂಡಿಯನ್ ಮೆಡಿಕಲ್ ಅಸೋಸಿಯೇಷನ್ ಲೆವೆಲ್ನಲ್ಲಿ ನಾವು ಅಲ್ಲಲ್ಲಿ ಕ್ಯಾಂಪ್ಗಳನ್ನು ಮಾಡಿ ಇದರ ಬಗ್ಗೆ ಹೆಲ್ತ್ ಅವೇರ್ನೆಸ್ ಕೊಟ್ಟು ನಾವು ಹೆಚ್ಚಿನ ವಿಚಾರಗಳನ್ನು ತಿಳಿಸುವಂಥ ಪ್ರೋಗ್ರಾಮ್ ಆಗಬೇಕಿದೆ. ಸರ್ಕಾರಕ್ಕೆ ಈ ಒಂದು ವಿಚಾರವನ್ನು ಟೆಕ್ಸ್ಟ್ ಬುಕ್ನಲ್ಲಿ ಸಹ ಅಳವಡಿಸಿ ಪ್ರೈಮರಿ ಸ್ಕೂಲ್ ಲೆವೆಲ್ನಿಂದಲೇ ತಿಳಿಸುವಂಥ ಒಂದು ಪ್ರಿವೆಂಟಿವ್ ಮೆಥಡ್ಸನ್ನು ಹೇಳಬೇಕಾದಂಥ ಒಂದು ವ್ಯವಸ್ಥೆ ಆಗಬೇಕಾಗಿದೆ ಅಂತೇಳಿ ಕಾಣ್ತದೆ. ಅದು ಆದರೆ ಬಹುಶಃ ಈ HPV ವ್ಯಾಕ್ಸಿನೇಷನಿಗೆ ಒಳ್ಳೆ ರೀತಿಯ ರೆಸ್ಪಾನ್ಸ್ ಬರ್ಬೋದು. ಅದೇ ರೀತಿ ಅದು ಸ್ವಲ್ಪ ಕಾಸ್ಟ್ಲಿ ಇದೆ. ಅದನ್ನು ಗೌರ್ಮೆಂಟ್ ಈಗ ನಮ್ಮ ಪಬ್ಲಿಕ್ಸಿಗೆ ಫ್ರೀ ಆಫ್ ಕಾಸ್ಟ್ನಲ್ಲಿ ಕೊಡ್ತಾರೆ ಅಥವಾ ಸಬ್ಸಿಡೈಸ್ಡ್ ರೇಟ್ನಲ್ಲಿ ಮಾಡ್ತಾರೆ ಅಂತ ಹೇಳಿದರೆ ಬಹುಶಃ ಇಂಡಿಯಾದಲ್ಲಿ ಕ್ಯಾನ್ಸರ್ನ ಸಂಖ್ಯೆ, ಕ್ಯಾನ್ಸರಿಂದ ಆಗುವಂಥ ಡೆತ್ ತುಂಬ ಕಮ್ಮಿ ಆಗ್ಬೋದು ಅಂತೇಳಿ ಅನಿಸ್ತಾ ಇದೆ. ಇದು ಒಂದು ಒಳ್ಳೆಯ ಕಾರ್ಯಕ್ರಮ. ಅದೇ ರೀತಿ ಸರ್ಜಿಕಲ್ ಅಪ್ರೋಚ್ ಫಾರ್ ಸೋ ಮೆನಿ ಪ್ರಾಬ್ಲಮ್ಸ್ ಆಫ್ ಎಸ್ಪೆಷಲಿ ವಿಮೆನ್ ಆ್ಯಂಡ್ ಚಿಲ್ಡ್ರನ್, ದಟ್ ಈಸ್ ವೆರಿ ವೆರಿ ಇಂಪಾರ್ಟೆಂಟ್. ರವಿಕಾಂತ್ ಅವರು ಒಳ್ಳೆ ಒಂದು ಪ್ರೋಗ್ರಾಮನ್ನು ನಮ್ಮ ವೈದ್ಯಕೀಯ ರಂಗದಲ್ಲಿ ನಮ್ಮ ಡಾಕ್ಟ್ರುಗಳಿಗೆ ತಿಳಿಸಿದ್ದಾರೆ. ಲೇಟೆಸ್ಟ್ ಮೆಥಡ್ನಲ್ಲಿ ಯಾವ ರೀತಿ ಇಂಥ ಒಂದು ಪ್ರಾಬ್ಲಮ್ಸ್, ಇನ್ಕಾಂಟಿನೆನ್ಸ್ ಮತ್ತು ಇನ್ನಿತರ ಅವರ ಪರ್ಸನಲ್ ಪ್ರಾಬ್ಲಮ್ಸ್ಗಳಿರುವಂಥನ್ನು ಸಾಲ್ವ್ ಮಾಡುವ ಅಂತ ಹೇಳುವಂಥ ಉತ್ತಮ ರೀತಿಯಲ್ಲಿ ವಿತ್ ವಿಡಿಯೋಗ್ರಾಫ್ ಮುಖಾಂತರ ಅವರು ತೋರಿಸಿದ್ದಾರೆ. ಅದೇ ರೀತಿ ಹಳದಿಪುರ ಅವರು ENTಯಲ್ಲಿ ನಾವು ಮಾಡುತ್ತಿರುವಂಥ ತಪ್ಪುಗಳು, ಅದನ್ನು ಯಾವ ರೀತಿ ನಾವು ತಿದ್ದಿಕೊಳ್ಬೋದು, ಎಂಥ ಒಂದು ಸಿಂಪಲ್ ಟ್ರೀಟ್ಮೆಂಟನ್ನು ನಾವು ಎಷ್ಟು ಕಾಂಪ್ಲಿಕೇಟ್ ಮಾಡ್ತಾ ಇದ್ದೇವೆ, ಅದನ್ನೆಲ್ಲ ಹೌ ವಿ ಕ್ಯಾನ್ ಪ್ರಿವೆಂಟ್ ಆ್ಯಂಡ್ ಹೌ ವಿ ಕ್ಯಾನ್ ಕಾನ್ಸಂಟ್ರೇಟ್ ಆ್ಯಂಡ್ ಡೂ ಇಟ್ ಅಂತೇಳಿ ಹೇಳುವಂಥದ್ದು ನಿಮಗೆಲ್ಲ ತಿಳಿಸಿದ್ದಾರೆ. ಅದು ಸಹ ಒಂದು ಭಾಳ ಮುಖ್ಯವಾದಂಥ ವಿಚಾರ. ಇನ್ನೂ ಸಹ ನಮಗಿನ್ನು ನೆಕ್ಸ್ಟ್ ನಮಗೆ ಉತ್ತಮ ಕೆಲವು ಸಬ್ಜೆಕ್ಟ್ಸ್ ಎಲ್ಲ ಬರಲಿಕ್ಕಿದೆ. ನಮ್ಮ ಮೇಡಮ್ ಅವರು, ವಿಜಯಲಕ್ಷ್ಮಿ ಮೇಡಮ್ ಅವರು ಆಲ್ರೆಡಿ ನಮ್ಮ ಕಾನ್ವೊಕೇಷನಿಗೆ ಒಮ್ಮೆ ಬಂದಿದ್ದರು. ಆದ್ರೂ ಅವರ ಬಗ್ಗೆ ನಾವು ಹೆಚ್ಚಿಗೆ ಹೇಳಬೇಕಾಗಿಲ್ಲ. ಯಾಕೆಂದರೆ ಪೀಡಿಯಾಟ್ರಿಕ್ ಕಾರ್ಡಿಯಾಲಜಿಸ್ಟ್ ಅವರು ಅದರಲ್ಲಿ ಭಾಳ ಎಮಿನೆಂಟ್ ಪರ್ಸನಾಲಿಟಿ, ಇಂಟರ್ನ್ಯಾಷನಲ್ ಫಿಗರ್, ಉತ್ತಮ ವಾಗ್ಮಿಯೂ ಹೌದು, ಸಾಹಿತಿಯೂ ಹೌದು. ಪ್ರತಿಯೊಂದು ವಿಚಾರದಲ್ಲಿ ಸಹ ಭಾಳಷ್ಟು ಉತ್ತಮ ವಿಚಾರಗಳನ್ನು ನಮಗೆ ತಿಳಿಸಿಕೊಡ್ತಾ ಇದ್ದಾರೆ. ವೈದ್ಯಕೀಯ ರಂಗಕ್ಕೆ ಅವರ ಕೊಡುಗೆ ಭಾಳ ಅಪಾರವಾದದ್ದು. ಅದೇ ರೀತಿ ಇನ್ನು ಸತೀಶ್ ಭಟ್ರವರು ಮೆಡಿಕೋ-ಲೀಗಲ್ ಆಸ್ಪೆಕ್ಟನ್ನು ಹೇಳಲಿಕ್ಕಿದ್ದಾರೆ. ಮೆಡಿಕೋ-ಲೀಗಲ್ ಆಸ್ಪೆಕ್ಟ್ ಈಗಿನ ದಿವಸದಲ್ಲಿ ನಮ್ಮ ಪ್ರಾಕ್ಟೀಸ್ನಲ್ಲಿ ಭಾಳಷ್ಟು ತೊಂದರೆಗಳು ಬಂದಾಗ ವೈದ್ಯರುಗಳು ಯಾವುದೇ ರೀತಿಯ ಧೃತಿಗೆಡದೆ ಯಾವ ರೀತಿ ಅದನ್ನು ಫೇಸ್ ಮಾಡಬೇಕು ಮತ್ತು ಅದನ್ನು ಯಾವ ರೀತಿ ನಾವು ನಿಭಾಯಿಸಬೇಕು ಅಂತೇಳಿ ಹೇಳುವಂಥದ್ದು ಈಗ ನೆಕ್ಸ್ಟ್ ಅವರು ಹೇಳಲಿಕ್ಕಿದ್ದಾರೆ. ದಟ್ ಈಸ್ ವೆರಿ ಇಂಪಾರ್ಟೆಂಟ್ ಪ್ರೆಸೆಂಟ್ ಸಿಚುವೇಷನ್ನಲ್ಲಿ. ಪ್ರತಿಯೊಬ್ಬರು ಸಹ ಈ ಒಂದು ಮೆಡಿಕಲ್-ಲೀಗಲ್ ಆಸ್ಪೆಕ್ಟನ್ನು ಗೊತ್ತಿರಬೇಕು. ಯಾವುದೇ ರೀತಿಯಲ್ಲಿ ಹೆದರಬಾರ್ದು ಅಂತೇಳಿ ಹೇಳುವಂಥದ್ದು ಇಂಪಾರ್ಟೆಂಟ್. ಇಲ್ಲದ್ರೆ ಏನಾಗುತ್ತೆ ಅಂದರೆ ಪ್ರತಿ ಚಿಕಿತ್ಸೆಯನ್ನು ಅದನ್ನು ನೀವು ಅವ್ರ ಹತ್ರ ಹೋಗಿ ಇವ್ರ ಹತ್ರ ಹೋಗಿ ಅಂತೇಳಿ ಕಳಿಸುವಂಥದ್ದು ಜಾಸ್ತಿ ಆಗಿದೆ. ಕಾರಣ ಇಷ್ಟೇ, ಹೆದರಿಕೆ. ಅವರಿಗೆ ಚಿಕಿತ್ಸೆ ಕೊಡಲಿಕ್ಕೆ ಗೊತ್ತಿದ್ದರೂ ಹೆದರಿಕೆ. ಅದನ್ನು ಹೋಗಲಾಡಿಸಬೇಕು ಅಂತ ಹೇಳಿದರೆ ಮೆಡಿಕೋ-ಲೀಗಲ್ ಆಸ್ಪೆಕ್ಟಲ್ಲಿ ಇಫ್ ಯು ಆರ್ ವೆಲ್ ವರ್ಸ್ಡ್ ಆ್ಯಂಡ್ ಗುಡ್ ನಾಲೆಜ್ ನಿಮಗೆ ಇತ್ತು ಅಂದರೆ ಯಾವುದೇ ರೀತಿಯ ತೊಂದರೆ ಇಲ್ಲದೆ ಯು ಕ್ಯಾನ್ ಫೇಸ್ ದಿ ಪ್ರಾಬ್ಲಮ್. ಈಗ ನಮ್ಮ ಶ್ರೀರಾಮ್ ಭಟ್ ಅವರು ನಮ್ಮ ಎದುರೇ ಕೂತಿದ್ದಾರೆ. ನಾನು ನಮ್ಮ ವಿದ್ಯಾರ್ಥಿಗಳಿಗೆ ಕೇಳೋದಿತ್ತು, ನೀವು SRB ಅವರನ್ನು ನೋಡಿದ್ದೀರಾ ಅಂದೇಳಿ. ಯಾಕೆ ಅಂದರೆ ಇತ್ತೀಚೆಗೆ ಅವರು ನಮಗೆ ಎಕ್ಸಾಮ್ನರ್ ಆಗಿ ಬಂದಿದ್ದರು. ಅಟ್ಲೀಸ್ಟ್ ಆವಾಗಾದರೂ ನೋಡಿದ್ದೀರಾ ಅಂದೇಳಿ. ಕೆಲವರಿಗೆ ಗೊತ್ತುಂಟು, ಕೆಲವರಿಗೆ ಗೊತ್ತಿಲ್ಲ. ಆ ದಿವಸ ಇವತ್ತೀಗ ಇಲ್ಲಿರುವವರು ಅಟ್ಲೀಸ್ಟ್ ಯು ಕ್ಯಾನ್ ಸಿ ಹಿಮ್ ಹಿಯರ್. ಹಿ ಈಸ್ ಫ್ರಮ್ ಅವರ್ ಪ್ಲೇಸ್ ಓನ್ಲಿ. ಅವರ ತಂದೆಯವರು ನಮ್ಮ ಗುರುಗಳು ಹೌದು. ನನಗೆ ಹೈಸ್ಕೂಲ್ನ ಅವರ ತಂದೆಯವರು ನಮಗೆ ಗುರುಗಳಾಗಿದ್ದರು. ಇವರು ಸುಳ್ಯದಲ್ಲೇ ಹುಟ್ಟಿ ಬೆಳೆದೆಲ್ಲ ಅವರ ಒಂದು ಈ ವಿದ್ಯೆಯನ್ನು ಅವರು ಪಡೆದು ಉತ್ತಮ ರೀತಿಯಲ್ಲಿ ಅವರ ಟೆಕ್ಸ್ಟ್ ಬುಕ್ ಅಂತೇಳಿ ಹೇಳಿದರೆ ಬಹುಶಃ ಇಂಟರ್ನ್ಯಾಷನಲಿ ಫೇಮಸ್. ನೀವು ಅವರು ಡೆಲ್ಲಿಯಲ್ಲಿ ಹೋಗಿ ನೋಡಬೇಕು. ನೈಸರ್ಕ್ ಅಂತ ಹೇಳುವ ಜಾಗೆಯಲ್ಲಿ ಬುಕ್ಸ್ ಮಾರಾಟ ಆಗ್ತಾ ಇರ್ತದೆ. ಇಷ್ಟಿಷ್ಟು ಎತ್ತರ ಅಟ್ಟಿಗಳು ಇಟ್ಟುಕೊಂಡು ಹಾಟ್ ಕೇಕ್ನಾಗ ಮಾರ್ತಾ ಇರ್ತಾರೆ ಅಲ್ಲಿ. ಅದರಲ್ಲಿ ಯಾವುದು ಅವರ ಸರ್ಜರಿ ಬುಕ್ಸ್. ಅಂತಹ ಒಂದು ಎಮಿನೆಂಟ್ ಪರ್ಸನಾಲಿಟೀಸ್ ಇವತ್ತು ಬ್ಲಂಟ್ ಇಂಜುರಿ ಅಬ್ಡಮನ್ ಬಗ್ಗೆ ಚಿಕಿತ್ಸೆ ಇದು ಬಗ್ಗೆ ಟಾಕ್ ಕೊಡಲಿಕ್ಕಿದ್ದಾರೆ. ಅದೇ ಮತ್ತು ಎಮರ್ಜೆನ್ಸಿ ಬಗ್ಗೆ. ಈಗ ಕ್ಯಾಶುವಲ್ಟಿ ಅಂತೇಳಿ ಹೇಳುವಂಥದ್ದು ಹೋಗಿದೆ, ನೋ ಕ್ಯಾಶುವಲ್ಟಿ. ಈಗ ನಾವು ಡಿಪಾರ್ಟ್ಮೆಂಟ್ ಆಫ್ ಎಮರ್ಜೆನ್ಸಿ ಅಂತೇಳಿ ಹೇಳಿ ಪ್ರಾರಂಭ ಮಾಡಿರೋದು. ಬೋರ್ಡ್ಸ್ ಎಲ್ಲ ತೆಗೆದು ಕ್ಯಾಶುವಲ್ಟಿ ಅಂತ ತೆಗೆದು ಈಗ ಎಮರ್ಜೆನ್ಸಿ ಅಂತೇಳಿ ಹಾಕಿದ್ದೇವೆ. ಆದ್ದರಿಂದಾಗಿ ಎಮರ್ಜೆನ್ಸಿಯಲ್ಲಿ ಡಿಪಾರ್ಟ್ಮೆಂಟೇ ಬೇರೆ. ಅದಕ್ಕಾಗಿಯೇ ಪೋಸ್ಟ್ ಗ್ರ್ಯಾಜುಯೇಟ್ ಕೋರ್ಸಸ್ ಸ್ಟಾರ್ಟ್ ಮಾಡಲಿಕ್ಕೆ ನಮ್ಮ ನ್ಯಾಷನಲ್ ಮೆಡಿಕಲ್ ಕಮಿಷನ್ ಎಲ್ಲರಿಗೆ ಇನ್ಸಿಸ್ಟ್ ಮಾಡಿದೆ, ಮೆಡಿಕಲ್ ಕಾಲೇಜಿನವರಿಗೆ. ಅದೇ ರೀತಿ ನಾವು ಸಹ ಪ್ರಾರಂಭ ಮಾಡಿದ್ದೇವೆ. ಅಂಥ ಒಂದು ಕಂಡೀಷನ್ಲಿ ಅಪ್ರೋಚ್ ಟು ಐ ಎಮರ್ಜೆನ್ಸಿ ಸಹ ಇದೆ. ಅದೇ ರೀತಿ ಪ್ರತಿಯೊಂದು ಎಮರ್ಜೆನ್ಸಿಗೂ ಸಹ ಈಗ ನಾವು ಒತ್ತು ಕೊಟ್ಟು ಅದನ್ನು ಶಿವರಾಮ್ KV ಅವರು ಸಿರ್ಸಿ ಅವರು ಈ ದಿವಸ ನಮಗೆ ಹೇಳಲಿಕ್ಕಿದ್ದಾರೆ. ಅದೇ ರೀತಿ ಇಂಪ್ಯಾಕ್ಟ್ ಆಫ್ ಸ್ಟ್ರೆಸ್ ಆನ್ ಬಾಡಿ ಎಟ್ ಮಾಲಿಕ್ಯುಲರ್ ಲೆವೆಲ್, ದಟ್ ಈಸ್ ವೆರಿ ವೆರಿ ಇಂಪಾರ್ಟೆಂಟ್ ಫಾರ್ ಮಾಡರ್ನ್ ಪೀಪಲ್. ನಾವು ಬೇಸಿಕ್ ಲೈಫ್ ಸಪೋರ್ಟ್ಸ್ ಆಲ್ರೆಡಿ ನಾವು ಅದನ್ನು ECLS ಹೇಳಿ ಒಂದು ಪ್ರೋಗ್ರಾಮನ್ನು ನಮ್ಮ ರಾಜೀವ್ ಗಾಂಧಿ ಹೆಲ್ತ್ ಯೂನಿವರ್ಸಿಟಿ ಅವರು ಹಾಕಿದ ಪ್ರಕಾರ ಪ್ರತಿ ವೈದ್ಯಕೀಯ ವಿದ್ಯಾರ್ಥಿಗಳಿಗೆ, ನರ್ಸಿಂಗ್ ವಿದ್ಯಾರ್ಥಿಗಳಿಗೆ, ಪ್ರತಿಯೊಬ್ಬರಿಗೂ ಪ್ಯಾರಾಮೆಡಿಕಲ್ ಸ್ಟಾಫ್ ಆ್ಯಂಡ್ ಮೆಡಿಕಲ್ ಪೀಪಲ್ ಎಲ್ರಿಗೂ ಟ್ರೈನ್ ಅಪ್ ಮಾಡ್ತಾ ಇದ್ದೇವೆ. ಆ್ಯಂಡ್ ಇನ್ನು ರೆಗ್ಯುಲರ್ಲಿ ನಮಗೆ ಬೇಕಾದಂಥದ್ದು ಹೈಪರ್ ಟೆನ್ಷನ್ ಆ್ಯಂಡ್ ಡಯಾಬಿಟೀಸ್. ಇದರ ಬಗ್ಗೆ ಸಹ ಉತ್ತಮ ಟಾಕನ್ನು ಕೊಡಲಿಕ್ಕೆ ಇದ್ದಾರೆ ಡಾಕ್ಟರ್ ವೆಂಕಟಕೃಷ್ಣಯ್ಯ ಮತ್ತು ಅರ್ಜುನ್ ಅವರು. ಅದನ್ನೆಲ್ಲ ನಾವು ಇವತ್ತು ಈ ಒಂದು ದಿವಸ ಹಾಕಿಕೊಂಡು ನಮ್ಮ ಈ ಇಂಡಿಯನ್ ಮೆಡಿಕಲ್ ಅಸೋಸಿಯೇಷನ್ ಸುಳ್ಯದ ಮೆಡಿಕಲ್ ಸ್ಪೆಷಾಲಿಟಿ ಸೆಕ್ಷನ್, ಬಹುಶಃ ಡಾಕ್ಟರ್ ಸಾಯಿಗೀತಾ ಅವರು ಬರಬೇಕಿತ್ತು. ಬಿಕಾಸ್ ಆಫ್ ಸಮ್ ಟ್ರಾಮಾ ಟು ಹರ್ ಲೆಗ್, ಶಿ ಈಸ್ ನಾಟ್ ಏಬಲ್ ಟು ಅಟೆಂಡ್ ದಿ ಫಂಕ್ಷನ್. ಬಟ್ ಎನಿಹೌ, this program is going well and most of you are attending this. There is a great thing. ಯಾಕೆಂದರೆ ಇಷ್ಟೊಂದು ಅಟೆಂಡೆನ್ಸ್ ನಮ್ಮ ಇಂಡಿಯನ್ ಮೆಡಿಕಲ್ ಅಸೋಸಿಯೇಷನ್ನ ಮೀಟಿಂಗ್ನಲ್ಲಿ ಸುಳ್ಯದಲ್ಲಿ ಇದು ಫಸ್ಟ್ ಟೈಮ್ ಅಂತೇಳಿ ಹೇಳ್ಬೋದು. ಅದರಿಂದ ನಿಮಗೆಲ್ಲ ಐ ಕಂಗ್ರ್ಯಾಚುಲೇಟ್ ಆಲ್ ಆಫ್ ಯು ಫಾರ್ ಕಮಿಂಗ್ ಆ್ಯಂಡ್ ಅಟೆಂಡಿಂಗ್ ದಿಸ್ ಫಂಕ್ಷನ್. ಐ ವಿಶ್ ದಿಸ್ ಫಂಕ್ಷನ್ ಎ ಗ್ರೇಟ್ ಸಕ್ಸಸ್ ಆ್ಯಂಡ್ ಐ ವಿಶ್ ಆಲ್ ದಿ ಸ್ಪೀಕರ್ಸ್ ಟು ಗಿವ್ ಅಸ್ ಮೋರ್ ಆ್ಯಂಡ್ ಮೋರ್ ಇನ್ಫಾರ್ಮೇಷನ್ ಆ್ಯಂಡ್ ಇಟ್ ಈಸ್ ಯೂಸ್ಫುಲ್ ಫಾರ್ ಅವರ್ ಸ್ಟೂಡೆಂಟ್ ಆ್ಯಸ್ ವೆಲ್ ಆಸ್ ಟು ದಿಸ್ ಸುಳ್ಯ. ಅದರಿಂದಾಗಿ ಬಂದಂಥ ಎಲ್ಲ ಸ್ಪೆಷಾಲಿಟಿ ಡಾಕ್ಟರ್ಸಿಗೆ ನಮ್ಮ ಸುಳ್ಯದ ಪರವಾಗಿ, ಸುಳ್ಯ IMA ಪರವಾಗಿ ಹಾಗೂ KVG ಮೆಡಿಕಲ್ ಕಾಲೇಜಿನ ಮ್ಯಾನೇಜ್ಮೆಂಟ್ನ ಪರವಾಗಿ ಅಭಿನಂದನೆಗಳು ಹಾಗೂ ಕೃತಜ್ಞತೆಗಳನ್ನು ಸಲ್ಲಿಸುತ್ತಾ ನನ್ನ 2 ಮಾತನ್ನು ಮುಗಿಸ್ತೇನೆ. ಜೈ ಹಿಂದ್, ಜೈ ಕರ್ನಾಟಕ.
Thank you, sir. You are a living inspiration to many over here. Now we have come to the last part of our function, that is delivering the vote of thanks by our secretary, Dr. Ravikantji.
Good morning to all. It gives me a very immense pleasure and privilege to deliver vote of thanks for the state level CME, which is organized by IMA Sullia in association with the IMA AMS Sullia Association, which has the concept of Together in Medicine, Exploring Every Speciality. I wholeheartedly thank Dr. K.V. Chidananda sir, President AOLE, Medical Director of KVG Medical College and Hospital, and the founder president of IMA Sullia. Sir is always a strong support and guiding force in all our activities. Thank you, sir. I thank Deepak Aldipur, Director, Trustwell Hospital, Bangalore, for coming all the way and gracing our CME and giving inspiring and knowledge and sharing his experience and motivating all our students. Thank you, sir. I thank Dr. Vijay Lakshmi Madam, Professor Emeritus, Jayadeva Institute of Cardiovascular Science and Research. We thank you for enlightening words, Madam. I thank our President, Dr. Veena, for taking this initiative and organizing such a wonderful CME in our IMA Sullia branch. Thank you, Madam. I thank Chairman, Dr. Saigita, Dr. Shruti, the Secretary of IMA AMS Sullia, for helping in organizing this CME. I thank the speakers of today's functions, Dr. Sriram Bhatt, Dr. Satish Bhatt, Dr. Shivram, Dr. Arjun, who have come all the way to deliver their talk and share their experience with us. I thank you all. I thank our speakers of IMA Sullia, Dr. Geeta, Central Working Committee member, IMA Karnataka, and immediate past chairman of IMA State AMS, Dr. Venkatakrishna Bhatt, who is a master ceremony of today's function, Dr. Bhavya, who is also the resource person. I thank you all. I thank all the chairpersons of today's function, and I thank Dr. G.K. Bhatt sir, Dr. Mohan Appaji sir for gracing this occasion. Thank you, sir. I thank all the participants and members of IMA Sullia, past presidents of IMA Sullia, who are attending and making this event a grand success. I thank all the delegates, undergraduate students, postgraduate students, and all those persons who have helped us in conducting the CME and making a grand success. Thank you all. Long live IMA.
Thank you, everyone.
Hello. One last word. Madam Vijayalakshmi Bale Kundri is a storehouse of information. She could have spoken for 2 hours. She kept it so short. And all the speakers will tell you it is so difficult to keep your speech short. They say the KISS principle, keep it simple, stupid. So I think she was amazing.
ದೀಪಕ್ ಅವ್ರಿಗೆ ಸ್ಪೆಷಲ್ ಥ್ಯಾಂಕ್ಸು. ಇನ್ನೊಂದು ನಾನು ಹೇಳೋದನ್ನು ಮರ್ತಿದ್ದೆ, ಅದನ್ನ ಹೇಳ್ತೀನಿ. ಎಲ್ಲ ಕಾಯಿಲೆಗಳಿಗೆ ಮದ್ದಿದೆ, ಹೊಟ್ಟೆ ಕಿಚ್ಚಿಗೆ ಮದ್ದಿಲ್ಲ. ಡಾಕ್ಟರ್ಸ್ಗಳಲ್ಲಿ ಹೊಟ್ಟೆ ಕಿಚ್ಚು ಇರಬಾರ್ದಂದ್ರೆ ಚಪ್ಪಾಳೆ ತಟ್ಟೋದನ್ನು ಕಲಿಬೇಕು. ಪ್ಲೀಸ್ ಗಿವ್ ಅ ಬಿಗ್ ಹ್ಯಾಂಡ್ ಟು ವೀಣಾ ಆ್ಯಂಡ್ ದ ಹೋಲ್ ಟೀಮ್. ಯಾಕೆಂದರೆ ಕೈಯಲ್ಲಿ 39 ಅಕ್ಯುಪ್ರೆಷರ್ ಪಾಯಿಂಟ್ಗಳಿದೆ. ಎಷ್ಟು ಜೋರಾಗಿ ಚಪ್ಪಾಳೆ ತಟ್ತೀರೋ ಅಷ್ಟು 39 ಅವಯವಗಳಿಗೆ ಪ್ರಾಣವಾಯು ಪೋಷಣೆ ಮುಟ್ಟುತ್ತೆ. ನಿಮ್ಮ ಬ್ಲಡ್ ಪ್ರೆಷರ್ ಕಡಿಮೆ ಆಗುತ್ತೆ, ಬ್ಲಡ್ ಶುಗರ್ ಕಡಿಮೆ ಆಗುತ್ತೆ, ಹೃದಯ ಮಿಡಿಯುತ್ತೆ, ಮುಖ ಅರಳುತ್ತೆ, ಫೀಲ್ ಗುಡ್ ಹಾರ್ಮೋನ್ಸ್ ಬರುತ್ತೆ. ಯು ಗೆಟ್ ಇನ್ಸ್ಪೈರ್ಡ್ ಆ್ಯಂಡ್ ದೇ ಗೆಟ್ ದ ಇನ್ಸ್ಪಿರೇಷನ್ ಟು ಡೂ ಬೆಟರ್. ಸೊ ಲಾಂಗ್ ಲಿವ್ IMA Sullia.
So let us adjourn for the tea break. We'll come back by 11:30 with the master class by our Master of Surgery, Dr. Sriram Bhatt Kodapal.
ಪ್ರಕಟಣೆ. ಹಾಲಿನ ಹಿಂಭಾಗದಲ್ಲಿ ಮಳಿಗೆಗಳನ್ನು ತೆರೆಯಲಾಗಿದೆ. There is a stall. 3 companies are supporting CME. One is Serum Institute of India, one is Mayors, and TMS. We extend our gratitude from IMA Sullia to 3 companies, and Kannada Vaidya Barahagarara Sangha. We have a bi-monthly book coming from Kannada Vaidya Barahagarara Samiti. There is a Vidyarthi Loka in that. If anybody writing in Kannada, we will be publishing stories, poems, or whatever you write in Kannada. We will be publishing that. Samples of book is kept there in the stall. Please visit the stall in between the sessions, not during the sessions. And after the SRB sir's talk, we have a short quiz conducted by winners will get prize. I don't know it's attractive or not. So we request all the students to participate in the quiz also and visit the stalls.
Dr. Shriram Bhatt sir is going to deliver a talk on blunt injury abdomen. I would like to call upon Dr. Roshan sir and Dr. Bhavani Shankar sir to chair the session. I would call upon Dr. Raghunarayan Bhatt to give intro about our speaker.
Hello. Very warm good morning to one and all present here. So, Professor Dr. Shriram Bhatt sir, born on June 1st, 1964, hails from a family deeply rooted in education and values. He is the son of late Mr. Krishna Bhatt M, a dedicated teacher at Junior College, Sullia, and late Mrs. Devaki, who instilled in him a strong foundation of discipline and perseverance. We are also proud to inform that Dr. Shriram Bhatt sir pursued his early education in Sullia, completing his PUC at Junior College, Sullia in 1980. He then embarked on his medical journey, earning his MBBS in 1986 and MS in General Surgery 1990 from Kasturba Medical College, Mangalore. His relentless pursuit of surgical excellence led him to achieve the prestigious FRCS from Glasgow in 2020. A distinguished academician and surgeon, Dr. Shriram Bhatt sir served as the head of the Department of Surgery at KMC Mangalore and currently holds the position of Professor and Unit Head in the Department of Surgery at KMC Mangalore. Sir also extends his expertise to Government District Venlock Hospital, Mangalore, playing a vital role in patient care and surgical training. As a renowned author, Sir has significantly contributed to medical literature through widely acclaimed textbooks, including SRB's Manual of Surgery, Methods in Clinical Surgery, Bedside Clinics in Surgery, Operative Surgery, Textbook and Atlas, Atlas in Tissue Approximation, Surgery Textbook for Dental Students and Nursing Students. With an unwavering commitment to surgery, education and research, Dr. Shriram Bhatt sir continues to inspire students, colleagues and the broader medical fraternity. I would like to call upon Dr. Shriram Bhatt sir to proceed with this session. I would also like to call upon Dr. Roshan sir and Dr. Bhavani Shankar sir to moderate this session.
Good morning, everybody. First of all, I thank President IMA, Dr. Veena Madam, for having invited me for this probably honorable guest lecture because I am from this place. I had my earlier education born and brought up here till PUC. Then eventually went on to settle in Mangalore in the district center. I know Dr. Chidanand since childhood. Sir, I know him since childhood, so I know him in different ways because he does also MS surgery. We are in the same surgical site. I thank Secretary Ravikant. I thank Soumya, Dr. Soumya. Thank chairpersons, Dr. G.K. Bhatt, sir, I know him since long time. Satish Bhatt is there, my good friend. Himakar, Dr. Himakar, I know him since long time because he did this MD in KMC Mangalore in Venlock, so I've been meeting him. And Dr. Sri Krishna and many others. Dr. Vijayalakshmi Madam, I met her today, Madam, very nice of you. And all senior respected consultants, my colleagues, young dear students. Topic today is rather a big topic because in surgical side, many times we discuss abdomen trauma for one day CME. So I have to concise it for 20 minutes. That's what Madam has asked for. So within that, I will discuss blunt injury of the abdomen. So abdomen trauma is a very, very vast subject. Often it is difficult to manage. Often it is missed. That is the more dangerous thing. So what are the different types of abdominal trauma? There are only 3 types. Grossly you look into that. Penetrating trauma. That's what I am not interested. I was told to talk about something else, but it is quite common. So blunt trauma, this is what I am going to discuss briefly, or rather highlight for clinicians and in general and students in special. So different, it is easily missed. It is common in rural areas. So that's why it is more important because many times it is life-threatening and it is multi-organ, multi-system injuries can occur. Associated injuries also often missed. And abdominal wall injuries, again I am not going to. So the 3 categories of abdomen injuries. What we is interested is the central one, blunt trauma, often missed. Now you can see that stab injury there, and you can see here blunt injury, just abrasions are there. He had hemiperitoneum, we had to explore him. He had a mesenteric tear, he had a aortic injury also. So we had to clamp. So this is something, so many things sometimes missed. If you don't look at these things, last thing, if you miss, because you concentrate on other things. And mechanism, all of you know, either crush injury, especially in the RTA, and sharing injuries are, this is very important because you know that small bowel is very mobile, duodenum is fixed, ileocecal junction is mobile but not as mobile as a small intestine, either jejunum or ileum. So there is a sharing force like between the duodenum and the ileum. So the sharing force causes explosion of the junction and causes the bowel injury, even though there is no external injuries. So that is quite common, that causes peritonitis and eventually sepsis and so on. Penetration, not penetrating trauma from the outside. Many times chest injuries, lower rib fracture occurs, that fractured sharp rib injures during the phases of the inspiration or respiration, injures the spleen, and it is often kept unnoticed, and eventually they sanguinate, and unless you intervene, unless you treat with identification, you may lose the patient. So that's why that is very important because it is not the outside penetration. It is the mainly example rib fracture. And organ which is enlarged as such is more prone, like tropical diseases, malaria, where splenomegaly is quite common. Such enlarged palpable spleens are more prone for blunt injury. And organs are part involved. Again, most common abdominal wall, I am not discussing. Solid organs, spleen, liver, kidney, pancreas. In the spleen is the commonest one, most common involved, so causes hemiperitoneum, hollow viscous, stomach, small, large intestine, urinary bladder, ureter. Mainly urinary bladder injury occurs when there is a full bladder. It can cause intraperitoneal rupture. If it is not full bladder, it may cause extraperitoneal rupture. Vascular system, that is many times rather unnoticed, maybe mesenteric vessels, maybe sometimes major branches of the aorta. They really sanguinate, but their CT or evaluation, fast, whatever it is, say organs are normal. So requires a immediate intervention without any delay to save the life of the patient. So these are the different organs which are involved. So spleen is the commonest organ involved. So it's very common. Actually in Venlock, maybe every month, in our unit at least 2-3 spleens we are removing it. In other units of course same, maybe 5 spleens even now. Even though many times there are conservative or non-operative management, the amount of injury, there are grades, are grade 3, 4, such situations. If they are hemodynamically unstable, you won't be able to salvage the spleen. You need to go ahead and do the splenectomy. Remember, it is not uncommon. We are regularly doing splenectomy in a blunt trauma. That is the commonest organ involved, and you need to think whether to save the spleen, treat conservatively, or whether you are going to go in and do the splenectomy. So this is exactly incidence-wise. Spleen is the commonest one. Next comes the liver. Next comes the kidney. Next comes the pancreas. So hollow viscous, duodenojejunal or proximal jejunal is the commonest one. Ileocolic junction, distended cecum. When it is there, it may rupture. And retroperitoneal organs also, kidney, pancreas, urinary bladder, already told. Of course, with the pelvic injuries, they will have a fracture pelvis. So more often they will have a renal system injuries, especially ureter, bladder, and so on. So what is to be remembered again is there are two ways. Patient becomes unconscious, we concentrate on the head injury, but there is a silent, dangerous hemiperitoneum which needs immediate attention, which may be missed. Another way, patient may be having abdomen injury, thoracic injury and head injury may be missed, or fractures may be missed. So 4 systems you have to always examine, evaluate: head, chest, abdomen fractures. This is immediately should come. Any trauma patient come to the casualty, ask the patient name, patient is conscious, alert, probably head is okay. Then breathing, check the respiratory rate, saturation. Then something problem, then look at the respiratory system. Abdomen, look at the abdomen, tense, guarding is there, rigidity is there if patient is conscious. Then mobility abdomen. Ask the patient to move the limb and check for the spine injuries also, it may be missed. So these are the 4 systems you have to always check. Injury may be masked in the unconscious patient. That's very, very important. You keep on thinking why it is head injury or something else. So you will forget the abdomen part and you may lose the patient. So management, initial assessment, all of you know, A, B, C, D, E. I'm not going to detail it. What is important is chin lift, jaw thrust. That is how exactly you make the patient to breathe. That is the most important thing. So other things, of course. Again important thing is oxygen. If patient is getting desaturated, first thing is give oxygen. Not less than 15 liters per minute. Sometimes in the casualty they give 2 liters, 3 liters. Straight away give 15 liters. There is a recommended flow, not lesser than that in an acute trauma. And after that you can titrate later one patient becomes. So 15 liters is the standard thing, not lesser than that in any trauma. This is again, there is a mistake. We tend to give less oxygen in casualty, in emergencies. And circulation, again, heart rate, BP, this is hypovolemia, hemorrhagic shock, all these features are there. IV cannula, number 14 actually, number 14 cannula, 2-bore IV cannula, immediately first place, then start fluid, normal saline or ringer lactate. Pick up the BP, make the heart rate better. Meantime, start evaluate. It's a resuscitation, assessment, further decision should go hand in hand. You take organized people, call for help, start passing cannula with the sisters, supporting people. Immediately, as early as possible, no time to think. Meantime, pass catheter, if needed, gastric tube. It should come automatically. When you see a patient, it comes just automatically. These are the things comes automatically. So this is exactly what to manage. And disability level, after that, of course, Glasgow Coma scale, all those scales, whatever that you can utilize and say how severe is the conscious level, and exposure, and of course, then F is the passing Foley's catheter and other things. And assessment, now you got now different regions. So where is the injury? This time once you resuscitated the patient, ask the history, either with the patient if patient is conscious, or patient's attender or somebody brought the patient, where exactly accident, what exactly accident happened. So you can have a fair idea how severe is the injury, how much systems have involved. Severity, systems. These are the 2 things very, very important. And examination, again, mainly whether patient is hemodynamically stable or unstable. That is very, very important. In a stable patient, all of you know that triage, primary survey, secondary survey, severity score, all those things I am not going to detail it, you know that, or you can always read, but it comes part of it actually. And stable or unstable, this point is very, very clear, should not have any confusion. Unstable patient should get a priority, and if you have to take a decision, whether you will treat conservatively after resuscitation, or whether you are going to intervene surgically. I am not telling you intervene surgically. So what intervention, whether you do a damage control surgery or later you do a definite surgery, or definitive surgery to begin with as such, depending on the situation, depending on the organs involved, depending on the setup and backup, mainly blood. In these patients, blood and blood products availability is the most crucial thing. You can't replace anything else for blood loss, only blood has to be blood, FFP, platelet. So availability of the blood makes a lot of difference to save the life of the patient. So all these things are seatbelt injury, Cullen sign, Great Turner sign, London sign is a person's name, remember, not the place name. And it says that there is some intra-abdominal injury, maybe bowel, maybe organ injury, maybe hemoperitoneum and so on. So I'm not going to detail it, but you know that. So management strategies, quick assessment, simultaneous resuscitation, that's very, very important. Your thinking process will be multifocal. Everything you have to think, everything you have to order, you lead, you guide, you dictate. you get involved. That is the only way to save the life of the patient. No shortcomings. It's the you yourself get involved with the patient. Otherwise, you will lose the patient. And quick evaluation method, decision making, whether you treat conservatively, like now all of you know that gradings are there, liver injury, spleen injury, grade 1, 2, you can treat conservatively, but proper monitoring. We should have a proper setup, good critical care unit, and availability of the blood, and monitoring the patient. Do ultrasound now, do CT scan, tomorrow repeat the ultrasound. What is the status of the hemoperitoneum, or what is happening inside the abdomen. Additionally, clinically examine the patient. That is most important. Repetitive examination of the patient. That is not once you examine and keep quiet. Repetitive examine the patient every second hourly. Makes a lot of difference. Your decision which you thought initially will treat differently will change eventually after 2 to 4 hours, because clinical pattern may change, severity may alter. Then we need to go in and do laparotomy without much delay. Of course, in the backup, keep ready for laparotomy anytime when you decide. And how quick this should be done, that's important. Those who have experience in the surgical side, we know that we organize everything together. We order everybody, we get everything, pass cannulas, catheter, everything. It takes time. But you be there, organize everything, arrange everything together. So that is the request, a lot of organization skill, lot of thinking process. Everything should go simultaneously, not one by one. That is the point which you have to remember. Monitor, manpower, organizing, leading skill. You as a consultant, you have to lead, because you don't know whether postgraduates' ability to identify the problem, or juniors to ability to manage the problem. You yourself be there, take a call, direct them, and make patient all right. If there is a need for surgery, go yourself be there and do the surgery. That is exactly, so leading skill is most important to save the life of the patient. And evaluation, I told all these things. 4-quadrant tapping we used to do when ultrasound is not available, or only one machine is there, which cannot be shifted to the casualty. Now current guideline or standard is every emergency area in the casualty itself we should have ultrasound. That is a requirement, NMC wise or hospital requirement or legally also. So such things are still not available in most of the setups, at least in this country. So in such a situation, what we are doing earlier is 4-quadrant tapping. Diagnostic peritoneal lavage is quite useful, but needs some sort of skill, needs some time, because you have to make an incision in the below the umbilicus. You have to pass a catheter there, fine catheter, not Foley's catheter, venous catheter or any catheters. Then infuse normal saline. Then aspirate 1 liter, whatever you infuse, and analyze the content. So that is the diagnostic peritoneal lavage. And abdominal ultrasound fast, all of you know now, focus the assessment with sonography in trauma. E-fast, all of you know, is the extended one. You assess thorax and pleural cavity, that's E-fast. Fast is xipiternum, right upper quadrant, left upper quadrant, supraphobic. E-fast is add-on to thorax, both sides, mid-axillary, anterior axillary, left side. So that is E-fast, extended fast. So that should be available in all hospitals in the emergency. That is the idea of requirement. Of course, CT is the final assessment. When it is available in the hospital, you can shift the patient. You can always do a CT chest, abdomen. It also gives some idea about the spine also. So you yourself should be able to read the CT. That is the most important thing in trauma. You can't wait radiologist to give the report. They will give a report after 24 hours. There is no time for that. Basic reading of the CT picture as a consultant, as a surgical consultant, you should learn, especially abdomen and chest. And so that you can assess if there's a liver injury, what grade it is, spleen injury, what grade it is. Again, remember, most tricky situation is the diaphragmatic injury. If a diaphragm is injured, always surgery is the treatment. You never wait, you have to suture the diaphragm. Diaphragm is identified only by CT scan. Ultrasound will not be able to pick up. So CT is the ideal investigation if it is available in the hospital. But you have to see whether a patient is hemodynamically stable or unstable. Unstable patient is difficult to shift the patient to CT place. That is the drawback. So Doppler assessment of the major vessel, especially injury to IVC, major mesenteric vessels, in such a situation, good Doppler will definitely say IVC collapsed, bleeding, IVC wall disruption, they'll be able to pick up. All these situations requires immediate intervention. You can't wait. Go in, use a vascular clamp, and identify which vessel is bleeding, suture it. So angiogram, in a small bleeding, or eventually if you want to do, you can do angiogram. We can also do in such a, along with that, angioembolization you can do. There is an advantage of that, but it's only in the stable patient. So this is the diastematic peritoneal lavage. So you inject in the subumbilical area, saline you inject 1 liter, then change the position of the patient, then aspirate 1 liter, then assess the content, what are the things are there. Sorry. So these are the different things. Diastolic peritoneal lavage criteria. I am not going to detail it, how much it is, all those things are given in the book. But you assess this lavage fluid actually. So these are the different comparison of DPL, EFAST, CT scan. Ideally is CT scan, but it takes time. EFAST is quick initial assessment. DPL again needs some skill. So the different problems with that. Now treatment is identify the injuries quickly, decide for the approach, when and how quickly you are doing, that's important. And arranging, I already told, auto transition is another thing which we regularly use it. Your same gauze, you can place 10, 12 gauze and patient's blood. Now only thing is bowel injury should not be there. It is contaminated, you can't do. If it is organ injury, you can take the blood, filter it, add heparin, retransfuse it. We are doing it regularly. Anesthetic will help. And lot of blood is replaced by patient's own. And until you get an adequate number of blood, really makes up the whatever lost blood, at least 50% wake up you can do with that. So filtering is with gauze, simple way you can do that in the regular OT as such. Central line, call for anesthetic, critical care, everything should be organized in a very fashioned way to save the life of the patient. ABCD, I am not going to, critical time window, that's very, very important. Take a decision, what you are going to do. There is no time to call somebody on that. Your patient, your brain, your approach, your treatment. You should be very, very clear about these things, individual patient-based, patient-wise. And non-operative management in a good setup, otherwise go in and do surgery. Early total care in a stable patient, you can go in, if there is a bowel injury, suture it. If there is splenic injury, remove the spleen. But if patient is really unstable, what is called as damage control surgery. All these things are the criteria. I am not going to detail it. Hypothermia, serum lactate, coagulopathy, blood pressure, all those things. Blood transfusion near 15 minutes. And in such a patient, we can't do a total care, early total care, where do a definitive procedure to begin with. Open, identify the bleeder, clamp whatever it is, suture IVC, major vessels. If there is a liver injury, put a mop, 3, 4, 5 mops. Control the bleeding, and you can use a zip or loose sutures over the abdomen, put a binder, come out. Once patient is stabilized after 48 hours, go in and do a definitive procedure. So damage control surgery is definitely helpful in this patient. Of course, you start antibiotic, meantime you can arrange whatever required thing, you can take help from vascular surgeon and so on to do a definitive procedure once patient becomes stable. So many times we do that, we do repetitive procedure, we go in and do, once I have opened, patient had a celiac trunk bleeding, then put a clamp above, then put the suture, put a mop and came out after 48 hours, called vascular surgeon, then did the repair. Such things definitely happen, so you need to be, these things are identified only after opening. What is exactly there, what exactly trauma, major injuries are there, you will identify only after opening. And of course, non-operative management, when patient is normal sensorium, remember, if there is a bowel injury, no scope for non-operative management. They will go for peritonitis. You have to open, you have to do a definitive procedure. Jejunum means suture it, ileum may have to do a stoma. All those decisions, depending on the amount of contamination, stability of the patient and do a stoma, ileostomy and so on. So should be done in a proper ICU care, available surgical team, available transfusion products. Repeated assessment is important, hematocrit, electrolytes, clinical assessment, repeat fast, sometimes repeat CT scan also after 48 hours to have an exact contrast CT you can do, to have exact injury. Again remember, unconscious patient, you will concentrate on the head injury, you will miss major injury in the abdomen, especially vascular injury, abdomen injuries, and that will kill the patient. It is not the brain injury which kills most of the time. It is other injuries which kill the patient. That point you have to remember. So examine not only head, chest, abdomen fractures. The 4 things in emergency ward, casualty, these 4 things you should assess. That is very important. And blunt trauma in the children, again very challenging. We won't be knowing what exactly it is. There is no proper history also. Clinical assessment goes wrong, and they need rather early intervention also. Otherwise, that blood volume is rather less, maybe 2.5 to 3 liters. There is no time it will be sanguinated. You will lose the child unless you intervene and arrange these things as quickly as possible. Quickness comes here, real priority when you manage such patient. And laparotomy indications, frank hemoperitoneum, diagnostic peritoneum is positive, hemodynamic, unstable patient, you can't keep on trial, give blood, how much blood you can give, 10, 15, 20. Many times you have given blood, 30, 40, 50, 60 blots of blood you have given and saved the patient. So such a patient requires somewhere in the line laparotomy and control the bleeding. At the end of the day, source has to be controlled. You can't keep on pushing blood. There is no end for that. That is the point you have to remember. And repeated assessment is important. Lengthy midline incision is the important. The extensions as you need. It is the life of the patient. There is no cosmetics in that. Extension right side, left side, whatever way you want. Our hands, both hands should go. Our hands, surgeon's hand, assistant's hands should go inside the abdomen easily without any resistance. That is the point. Lengthy midline incision, if required, side extension. Both surgeons and assistants' hands should go inside the abdomen without any resistance. That is the point. Explore properly, mesentery, bowel, organ, diaphragm, I told. You need to operate. There is no conservative treatment for diaphragmatic injury. And other approaches, angioembolization, if other things are okay, liver injury, splenic injury. The splenic injury mainly when tear occurs in the hilum, they go for a pseudoaneurysm eventually. And such a pseudoaneurysm may rupture and suddenly they may die. Once you identify that one, usually by contrast CT, angioembolization most of the time sufficient because intervention radiologists are doing good job. And if they fail, then we need to go in and do a splenectomy. Individual organ management, I am not going to discuss. Each is different. Each has got its own grading. Clamping is different. Suturing is different. Needles are different. All those things are the technical decision making on table by the surgeons based on the experience and knowledge. And antibiotics, of course, has to be covered. Don't compromise in that. You can't have whether to give antibiotics. The life of the patient. Give best antibiotic. There is no time to think. We'll upgrade the antibiotic, all those things. Before you think we may lose the patient by septic shock. Don't allow that to happen. Hemodynamically, they are hypovolemic shock. You add sepsis in that, septic shock. Both shocks will kill the patient. At least control the septic shock. Straight away push higher antibiotic. No debate in that. It's the life of the patient between you and patient. And metabolic arrangement, again, electrolyte imbalance, acidosis, uremia occurs, acute kidney injury, liver cell dysfunction. In no time, 48 hours, the enzymes will increase drastically in the patient. Maybe due to blood transfusion, maybe due to sepsis, maybe due to hemodynamic instability. Everything is connected. Liver, kidney, lungs, brain, all these 4 organs are connected physiologically and metabolically. Remember, it is not the one organ injury, it's the 4 organ injuries always. And monitoring for complications, of course, sepsis, respiratory failure, acute kidney injury, all those things, bowel leak, compartment syndrome, everything happens in patients. Remember, we see all these complications in our day-to-day surgical life when the patient comes with the trauma. As and when it happens, Our job is to identify it, respond to that, treat accordingly. If you miss these complications, you will lose the patient. There is not much time to go ahead and do something, think. There is nothing to time to think. Once you identify it, treat it. Otherwise you lose the patient. So protocol, this is the protocol. I'm not going to detail it. It's a standard protocol. CT will do unstable. Now what is important is whether patient is unstable or not. Whether patient is stable makes a lot of difference in managing. Stable patient will be able to save. Unstable patient, we should be very quick. You should be there with the patient, beside the patient, monitor, required, intervene. That is the most crucial area. Decision is important. Whether patient is unstable or stable makes a lot of difference. So this is the protocol, of course. It is individualizer, finally, individual patient, depending on that point of time, what situation, how bad patient, how exactly they present with, availability, backup, everything counts in these patients. Again, peritonitis, fast, laparotomy. I'm not going to detail it, whatever I've told. This is again another protocol. So finally, organ injury, bowel injury, diaphragmatic injury, bladder injury, associated injuries, chest, brain, fractures. These are the four things, and metabolic problem. It is at the end of the day, physiological, metabolical impairment, which you have to identify, we have to correct it, you have to monitor it daily as such. So this is the bad hemoperitoneum. So we had to open and we had to do splenectomy in this patient. With the bowel injury, multiple places we have sutured. And the splenic injury again, grade 4 plus 4 injury. You can see that it's a blunt injury actually. You got a fracture rib. So the reconstructed CT image, you could see the fracture rib. This rib was abutting over the spleen and it was causing the splenic injury. And I'm just going to that. It is the surgeon's decision making, clarity, approach. That was said, great surgeon Guido Lamprunci told. Your decision making, concentration, dedication, be with the patient makes a lot of difference in managing blunt trauma abdomen. So conclusions are, so identify blunt abdominal trauma, often it is missed. Think of associated injuries, ABCD I already told. Arrange and organize, that is also highlighted clearly. Decision making, finally it's the decision making. You should be very, very clear and clarity at your approach as such. Damage control surgery or early total surgery, take a call. If unstable patient, do damage control surgery, then definitive surgery maybe after 48 hours. Most crucial is post-operative surgery. Once you do surgery, it is not over. You got a lengthy post-operative period many times. They may be in the ICU for 2 weeks, 3 weeks, 1 month, 2 months. Many times patient will be in the 3 months like that. They will be really catabolic. So nutrition is very important. Managing electrolytes is very important. Urine output getting hourly is important. Respiratory system is every system you have to concentrate and manage as and when needed. Otherwise, any time of your treatment period for 1 month or so, you may lose the patient. Patient recovered well, you are happy. After 2-3 weeks, suddenly sepsis occurs. Before you realize what happens, hypertension, cardiac arrest, death. We have seen that. It's happening. Unless you monitor daily until you discharge, your concentration should be proper. You can't ignore patient. Suddenly they die. That is the most important thing. Your job is not over by doing surgery. This is very, very crucial post-operative care. Of course, shift to higher center if things are not available, especially blood. If blood is not available, put it in a good ambulance, shift to the higher center. Blood product are essential. You got only 5 liters of blood. It hardly takes much time to bleed and exsanguinate them. Unless you have got blood to replace, you will lose the patient. This availability is very important. Golden period, as early as possible, as quick as possible. That is the blunt trauma. You have to be very, very clear. You have to be very, very clinically sensible. You have to very clinically assess the patient and intervene, take a decision to make them all right, to save the life of the patient. So just for the people who change after change will survive. People who change with the change will succeed. People who cause the change will lead. Like Satish is leader of us for all these things, for our medical-legal aspect. So you lead, surgeons should lead. Remember, general surgeons are not just general. They are still doing very, very good job in this country. Most of the surgeons in this country are still general surgeons. So I call them as a generals of surgery. They are not just general surgeons. They are real generals of surgery in this country. Remember, 80% of the surgical work is still done by, managed by, properly by general surgeons, remember. And this is just for undergraduates. Qualities of surgeon: lion's heart, lady's finger, horse's leg, eagle's eye, camel's bell. To become a surgeon, you should have all these things. You can start a long time. You should be very, very observant. You should have very good ladies' fingers. Ladies' fingers are very fine, unlike gents. Remember, gents have got a fine trimmer. Ladies have got less trimmer. It is a hormonal, actually, genetical. And so it should be very fine. And lion's heart is very, very strong, because today you do a good job, patient is okay. Tomorrow you lose a patient. So you should have a balance between a good and bad. So morning you are happy with the good patient. Evening you lose a patient, will be depressed. You should have very, very balanced spirit in managing the patient. Otherwise you will really upset psychologically. So balance your spirit, actually, good, bad, accept it. Until you feel that you have done a good job, your conscience is not guilty in managing this patient, should not be worried, because half of these patients, especially trauma, you tend to lose them in spite of your day and night proper energetic effort. You should be ready for that. So balance your mind for good or bad. That's the important thing. And this is my book. I got a surgical website, free it is. Daily lectures are there. And for undergraduates, once in 2 weeks, I conduct a live lecture, case presentation for undergraduates for 1.5 hours. Whoever students, you can subscribe my this one, join live session. It will be very, very helpful. You can present also. You can communicate me, you can present. I will organize that. 1.5 hour, like any hernia, all other things. And daily, 8 to 10 minutes, one lecture will be there. Always it comes. Daily lectures with the 2 MCQs there in that lecture. It will be very, very helpful to learn surgery, to update surgery in a short, not in lengthy lectures, 5 to 8 minutes lectures. That is my free website. Please, you can subscribe this one. Definitely very, very helpful. Thank you very much. I am always dedicated to my college and my hospital. Thank you.
Sir, thank you for that lucid talk. So I know you could concise a vast topic into a nutshell so that it's easily digestible to all of us. I know how difficult it is to concise it, because yesterday I was just taking a class on pelvic fractures for UGs, and I was struggling to put the points. And I think you have taken through the trauma protocol, you've taken us through the ATLS protocol, and the teamwork is very important in a trauma scenario. The fastness is important, and the teamwork is important. Thank you, sir.
Thank you, thank you. Thank you, sir. Thank you.
With your permission, one comment. Thank you very much for your very lucid and impressive presentation. To highlight what he has said, our echocardiographer, her son was engaged and he was going on a motorbike to meet his fiancée. He hit the divider, fell down, had a laceration of the liver and died. And she almost became mad. That is the one side. The other side is, one boy had come with the ischemic limb, no pulse, the limb was cold, right lower limb, 7 years old child. And then the child, when we saw that it was a blunt injury. He had fallen from a bullock cart, and the tip of the aorta, there were 2 vents, and there was a huge aneurysm compressing on the right common iliac artery, causing the ischemic limb. So the vascular surgeon, they discussed, they said the landing zone is not there. Any stent the covered stent cannot cover the tip of the aorta. Then it was complex for the surgeon. I did not lose heart. You said intervention. Intervention is coming between the disease and the death. So what I did is, I went from the left side where the vent were, I put the 2 ADO2 devices in 2 holes and closed it, and then the aneurysm organized, then the limb became warm, and the child became all right. When I presented this in Chicago, the inventor of Amplatzer device, which I had used, I showed it to him thinking he'll feel very happy. He did not ask me how I did, what I did. He asked, "VJ, what is bullock cart?" He never knew that any injury can go and hit the tip of the aorta. So he was wondering, what is this bullock cart? Like a bullet it has gone and hit, That is the way, And jokes apart, in the 2013, the top 20 publication, this was also one of them. My topping was coronary AV fistula, but this was the second one. So we have to think out of the box and sometimes give the best so that we can save literally the patient. Thank you very much, sir. Congratulations.
Thank you very much. Thank you.
Thank you, sir. I would like to, the chairperson to honor our Master of Surgery. I call Dr. Sudhakar Bhatt sir to honor our chairperson.
Now, to keep the learning interactive and engaging, we move on to an exciting part of our CME, the quiz. It's my pleasure to invite our quiz master, Dr. Ravikant sir, to take over and lead us.
There are few questions based on each topic. Those questions are very simple, just to excite you that whatever we taught is useful to real scenario. Please join using this code, or you can join on slido.com and enter this code. Last benches, if you don't get it, you can join through the slido.com and enter the code. It is better to keep your name clear so that if you get a prize, we can call you. 3 more we can join. Okay. So now we shall continue giving I think we can start now. No, still people are joining. Answer this question. A 45-year-old multiparous woman presents with a complaints of involuntary leakage of urine while coughing, sneezing, and during physical activities for the past 6 months. She has no symptoms of urgency or nocturia. A positive cough test confirms she is stress urinary incontinence. She has failed conservative management, including pelvic floor surgery. Which of the following is the most appropriate surgical management for her condition? Retropubic medullary sling, sacral neural modulation, intermittent catheterization, anterior colporrhaphy. So 94% have given a right answer. It's a simple question, I think. A 60-year-old woman with history of previous pelvic surgery presents with a stress urinary incontinence. Urodynamic study confirms the diagnosis and conservative measures have not proved relief. During evaluation, she is found to have significant urethral hypermobility. Which surgical procedure would be most suitable for the patient? Bulking agents, Bush Colpo suspension, pubovaginal sling, urethral dilatation. Bush Colpo suspension was the better answer. A 55-year-old woman with intrinsic sphincter deficiency presents with stress urinary incontinence. Her urodynamic study shows a low Valsalva weak point pressure of less than 60 centimeter of water, mid-urethral mobility. Which of the following preferable surgical management for this patient? Transobturator tape, bulking agents, anterior colporrhaphy, Kegel's exercise. So many opted for TOT. We'll see what is the answer. Bulking agent, intrinsic sphincter deficiency, bulking agent is the better answer. At what age is HPV vaccination routinely recommended for both boys and girls? 6 to 8, 9 to 14, 15 to 18, 20 to 25. So 9 to 14, many have responded. So that's the right answer. Which of the following HPV type are most commonly associated with cervical cancer? 6, 11, 16, 18, 31, 33, 45, 52. 16 and 18, 85%. So that's the right answer. How many doses of HPV vaccination are recommended for individual starting vaccination series by 9 to 14 years? 1 dose, 2 dose, 3 and 4 dose. So very many have answered right, 91%. Which is the medication that can be given prolonged duration in case of vertigo? Cinnarizine, meclizine, prochlorperazine, beta-histamine. So there is a mixed response. Beta histamine is the right response. Best drug for management of acute laryngitis: antibiotics, antivirals, gargles, steroids. So many have answered right. 90%, very good. Which medicine on prolonged usage causes rebound nasal congestion? Nasal spray, steroid, xylomethazine, steroids with antihistaminics. Again here a mixed response. Xylomethazone and oxymetrazone. Which is the medication that can be given for prolonged duration in case of vertigo? Cinnarizine, meclizine, prochlorperazine, beta histamine. Beta histamine. So that's the right response. Best drug, I think it is repeated. Yes, yes. Defamation. I think these topics are not done. Yes. Ronak Shetty. Prize yarige madam iga. Ronak Shetty can come forward. Who is UK? And third is Spandana. Please come forward. Three people are coming.
Thank you, sir.
Thank you for participation.
Now I would like to call up our next speaker, Dr. I.P. Vijayalakshmi. Ma'am is going to deliver a talk on topic Pediatric Cardiology Practical Approach. I would like to call upon Dr. Sri Krishna Bhatt. Dr. Dr. Suleka and Dr. Purushottam Diasar to chair the session. I'd like to call upon Dr. Grishma to give a small intro about our speaker.
Good afternoon, everyone. It is an immense privilege and honor to introduce an extraordinary luminary in the field of cardiology, a pioneer and a scholar and an inspiration for countless medical professionals, Professor Emeritus Dr. I.B. Vijayalakshmi. She is a name which is synonymous with excellence in pediatric cardiology. She holds an impressive array of qualifications and esteemed fellowships from esteemed institutions. And she is the first lady cardiologist in the state of Karnataka, but also the visionary who established the first pediatric cardiology department in the state. Her academic achievements are nothing short of phenomenal. She is a gold medalist in her MD with an outstanding 39 gold medals and 3 silver medals throughout her career. Her brilliance extends beyond academics into groundbreaking research where she has made pioneering contributions to acute rheumatic fever, introducing the widely recognized Vijaya's eco criteria. She has also been instrumental in advancing Amplatzer device closure, transforming the landscape of congenital heart defect management. She has been the former professor and head of pediatric cardiology at Sri Jayadeva Institute of Cardiovascular Sciences and Research at Bangalore, a premium institution in cardiovascular care. Her contributions to medical literature are profound. She has authored Step by Step to Eco in Congenital Heart Disease, a widely respected textbook with a foreword by Dr. Naveen C. Nanda, and has also edited 3 major textbooks, including a comprehensive approach to congenital heart disease, which was reviewed by Dr. Crystal Bonixon from the Mayo Clinic and published in the European Heart Journal. Her impact on cardiology has been recognized globally, and she has had the honor of delivering 29 prestigious orations across the national and international platforms. Her research and expertise have earned her 68 prestigious awards, including the Rajyotsava Award and the Lifetime Achievement Award presented by 2 of India's most respected figures, Bharat Ratna Dr. APJ Abdul Kalam and former President Srimati Pratibha Patil. She has also been awarded Best Papers 7 times at renowned cardiology conferences worldwide. She currently serves as the President at the Indian Academy of Echocardiography, leading advancements in cardiac imaging and pediatric cardiology. Despite her vast accomplishments, she remains deeply committed to mentoring and inspiring the next generation of cardiologists and medical professionals.
Thank you very much for your kind words. May I have the first slide, please? This is called as starting problems or hiccups. So the more difficulties you have, the greater you think. So never shy off of the challenges. The more challenges come, you can do better. And I'll show you how it can be done. Okay. Thank you very much. So I'm going to talk about in nutshell about the pediatric cardiology. The congenital heart disease, the word congenital has come, con together, genitus means born. So this is the Latin word. So a child which is born with the congenital heart disease right from the beginning. But this abnormality starts in the first 3 months of pregnancy, and that's how we know it can be caused by the abnormality in the cardiovascular structure or caused by the prenatal developmental defects or modified both the postnatal hemodynamic diagnosis. The heart is the most amazing structure in the world, and that's why in the Narayana Sukta before the Vedas, it is called as the abode of Paramatma. Paramatmana Avasa Sthana Antare. And that is the reason it beats at 1,25,000 per day, and then you can imagine it pumps about 5,000 gallons of blood per day, and that is like going around the world 1.5 times every time it beats. So 60,000 miles of blood vessels, and that when it beats every time it has to pass through that. And that's why when I told this in the ISRO Hassan Center, they told me I'm standing on the wires which are 5 lakhs. That means more than what the heart. So the satellites, are connected all over. It is very simple. It has got 4 hearts and the 4 valves and the 1 cover, and the myocardium acts as a syncytium. All are non-phenomena. Either all the myocardium contracts or they don't. And when they fail, all of them will fail, and that's why you see so many youngsters dying suddenly because of the cardiac arrest, and that is because all the muscles, they either contract or they don't contract. And that's how it is very important to know about the heart. The heart is the most harmonious structure in the world, because the same amount of blood that comes from the right side goes to the lungs, gets oxidized, and then it comes back to the left side, and that is pumped. Oxygenated blood is pumped into the aorta and goes to the 60 trillion cells in the body. So every second there is a 60 trillion chemical reactions are occurring. For that, the blood is very important. And that's why any defect in the structure, as you can see that in the interventricular septum, when there is a problem, the right to left shunt occurs, and that will cause the cyanosis. And this is how it is very important to know the structure. So this is Joseph Perloff. We used to read his textbook, The Clinical Recognition of Congenital Heart Disease, and his book was like a gospel, and 3 times I had read, and I had almost by-hearted every one, and then I took his autograph when I was a postgraduate in 1990. But then later on, when I wrote a comprehensive approach to congenital heart disease, he wrote the preface to my book, and he recommended this book. And today, almost all the postgraduates are reading that. So here it is so important that congenital heart diseases have to be understood. Everybody thinks it is very difficult, but the magnitude of problem in India is 2 lakh children are born with congenital heart disease every year. And at least 60,000 of them, need treatment. Otherwise, without treatment, they die without celebrating the first birthday. And only 5,000 get the treatment, and that is the pity. And that's how from the adult cardiology, I took up the pediatric cardiology when I was 48 years, and so that I can save the precious lives. And then after that, I have never looked back in my life. William Osler in 1925 said, inspection, palpation, auscultation, contemplation. That is the 4 compass for the students to make the diagnosis. But today we have ECG, X-ray, echo, catheterization, CT, MRI, whatnot, and still we make the diagnosis because we do not listen to the patient and hear them. So the factors are genetic, radiation, drugs ingestion during the pregnancy, that too for the 3 months, and then infection in the intrauterine life, rheumatic heart disease, patient taking the anticoagulation can have the coagulopathy, and then the lifestyle changes leading to obesity. Today, this has become a big problem. Many youngsters and the women, they are becoming obese and they become diabetic, and then cardiometabolic disorder, that is going to be transmitted to the children, and the children are being born with the congenital heart disease. And here, this is how abnormal pathophysiology makes. Once upon a time when the child was born like this, they used to say it is something apashakuna or something like that, the bad omen. But no, this can be detected in the intrauterine life with the fetal echocardiography, and that can be diagnosed. So here the most important thing is the alcohol abuse. Once upon a time it was only in the men. Today women are using the alcohol, and as a result fetal alcoholic syndrome can occur. The child is born with the facies, abnormal facies, the head will be small. More than that, the child will have 50% of them will have the ventricular septal defect, atrial septal defect, tetralogy of Fallot, coarctation of aorta. Of course, we can treat all of them, but at what cost? And apart from that, the maternal diseases like the diabetes, and if they have other diseases, and genetically they can be transmitted. So here I would like to tell, the moment the doctors they start using alcohol, whether it is men or the women. When I presented in one of the places, they said, what about the men taking alcohol? The child will be born with the ventricular septic, but more than that, the the motility will be less and the sperm count will be less, and they become sterile. And that's how we know if you want to produce good children without any defect, think that it is very important to have the good habits. So formerly when the religion was strong and the science was weak, the men mistook magic for the medicine. But today, when the science is strong and the religion is weak, men mistake medicine as the magic. But remember, sheer, sincere hard work, and that is what is important to make. So whenever we used to hear the story that Krishna was telling about the Chakravyuha and the fetus was saying yes, you may think that it is wrong. But today, the fetus can, when we do the fetal echo, we can tell the child what abnormality is there, whether to be terminated or not, the decision can be made. And here, no, the first intervention starts in the first 3 months, and the folic acid, vitamin B3 and niacin can prevent the congenital heart disease. So the people, those who are likely to become pregnant, they must start in time so that this is reduced. So once upon a time they used to say, oh, it is our bad luck. Today it is no more. Once we get the AV canal defect in the echocardiography, we do the blood karyotyping, and if there is a genetic defect, we tell the parents this is how the child is going to be born. Even if we treat the heart disease, the child will not be normal mentally. So we leave the decision to the parents whether to continue with the pregnancy or not. So this is how the Down syndrome looks, and you might have seen the Down children. They are excellent and they are very good. In fact, we used to terminate Down syndrome children. Once a child came with the Down syndrome, and then he said, Doctor Saab, Amma ko bahar bhejo. Then the mother I sent outside, and then he said, our hut is burnt and she is burnt, and if you tell her that I have got the heart disease, she will be heartbroken. मेरे अम्मा को कुछ नहीं बताइए, मुझे बताइए. So that is how the Down children are down to earth, very good human children. So we have to take the decision. Now history taking, examination, radiography, ECG, echocardiography, catheterization, CT, MRI, all are there, but then you should be humane and listen to the mother. What is the problem? And that is how we know the mother gets confidence in you and you can do the best. So there we have the repeated respiratory infection in the child if it comes. That shows that they have got the left to right shunt, and that's how you can treat them. And if the child has got easy fatigability, the child is not able to play like others, that means the cardiac output is reduced either due to the LVOT obstruction or the RVOT obstruction. So that has to be taken care of. If the child has got chest pain, that means there is a coronary problem, Kawasaki's disease or aortic stenosis or supra-aortic stenosis. Never neglect. Just in the last 1 month, the 3 children, the school-going children, they dropped dead, and I was called for the TV interviews from all the TV channels. And this is because the ignorance is there. So you must remember that it can happen, the sudden cardiac death can occur if the child has got a syncope, or if they don't think that the child has not eaten and that's why it has fallen. Try to evaluate the child and then make the decision. And there are markers, extra cardiac features. If you see all these things, no confusion. Immediately you know that the child has got the congenital heart disease. You have to look for them. And this is how the high arch palate or the malocclusion and all these things can be made out. And you can see that if there is a chest retraction, it indicates that there is a LV dysfunction. And that's how we know any child coming. In fact, one of the child was brought to me because a lady Aya who was giving the bath, she recognized that the chest was abnormal. And that's how the mother brought. And this is how we know we have to keep our eyes open and look at the child and what the problems are. And then inspection, palpations, all are very important that you learn. And this is the Williams syndrome. In the West, they were giving lots of vitamin D to the mothers, and then they realized that overdose of the vitamin D can cause the supra-aortic stenosis, and this is how the child looks like. And then apart from that, when you have the severe aortic stenosis, then we have to make the diagnosis, otherwise this child while running to the bus or playing, it will fall dead. And this is how the aortic stenosis is very important. And Noonan syndrome is the one where there is a pulmonary stenosis. Many of these children have the genetic problem, and the pulmonary stenosis is so important that this child, 2.5 kilos it was, and you can literally see that it's a pinpoint pulmonary stenosis. No flow is there in the lungs, totally empty. First I opened with 1.5 millimeter, then 2.5, and then 6 millimeter. Today this girl is a model, a beautiful girl. So this is how we know literally dying child can be saved with the treatment. And this is the Down syndrome, and you can see that the Down syndrome children can be operated in time and they can be made all right. And this is how the abnormalities, syndactyly, polydactyly, all of them, they are the marker. If you see that, these things immediately send the child to the patient. So coming to the AST or the atrial septal defect, this is the one which is very important. In the fossa ovalis, what we call as the ostium secundum AST, that can be closed with the device. And this is how we know this device closure has brought the child, given a new lease of life. So the first child I did the device closure in 1998. Then later on she sent a letter, she came to meet me. She had scored 96.8, and then she said God has got the followers, devotees, and the great people have got the following the footsteps. And today she is a doctor after reading in Mysore Medical College, and that's how we know we do the device closure. And this is the Kurt Amplatz that I was telling. He's the inventor of the device that we use, and then the totally normal, absolutely no chest scar, no operation, just 2 millimeter thick, and the child is normal for the whole life. And that's how we can do the thing. So this is how we can treat the left to right shunts. VST also we can close with the device. And then when the first VST closure I did, the child now it is an engineer. And when we had all women, the conclave in the Indore, Mary Combe was invited to be the chief guest, and at that time she said, my child had a hole in the heart and the surgeons operated, and surgeons are the gods. Then when she came down, I said, Madam, if you have to bring your child without scar, without operation, I would have closed the VST, and your child, even if the child had to wear a bikini, nobody could have made out. And she was looking, is it so? And the bodyguard was pushing me away. At that time, the other ladies who are inspired and become the pediatric cardiologist said, Madam, छोड़िए ना उसके साथ क्या बात करना, आप तो हमारे Mary Combe है. So this is how we know you have to inspire the people, and the PDA we can close. The VST AR goes for surgery, and all these things, rupture of sinus of Valsalva, all these things can be treated. Coronary AV fistula is the one where I have started closing with the devices, and today they are all. So the coarctation of aorta used to be missed. I always tell the students, be Indian, touch the feet, you'll never miss the diagnosis. Once you feel the pulse in the lower limb, you'll make the diagnosis. And this is how we know the first aortoplasty done in our state, Karnataka, in 1992. He was a gardener whom I had picked up, and today his son has become a doctor in Calcutta Medical College, and now he is practicing. This is how we know this child had a pulmonary edema, and then it was diagnosed as a rheumatic fever. So remember that in our country, congenital and the acquired can be coexisting. So the child had a mitral stenosis, atrial fibrillation, pulmonary edema, plus the pinpoint coarctation. So we opened up. And this is how the Shone's complex, the most complex ones also can be treated. The Marfan's disease, these are the children who can have the dissection, and that these dissections can be operated today, or we can put the vascular, covered stents and make them. So Dr. Shivram is there, the ophthalmologist, there is a subluxation. The moment there is a subluxation of the lens, try to look for the Marfan's syndrome, and this is how the flap in the aorta can be made out. Friends, any hole can be closed. Any obstruction can be opened with the balloon. But once they go for Eisenmenger's, the thing can be done. This is how the most beautiful actress Madhubala, She had a ventricular septal defect. She developed Eisenmenger's and then she died. Had we treated, she would have survived. So moving on to the cyanotic, where the lips, the tongue, oral mucosa and the tips and the conjunctiva all will have the cyanosis. So this cyanosis, tetralogy is the commonest condition and this can be operated. And here not only we can operate, we can see that the child is better. So the triology of fallow is pulmonary stenosis with the right to left shunt at the aortic level, and that also can be treated. So I'll quickly move on to the TGA, the total anomalous pulmonary venous connections. These can be operated, Epstein's anomaly, and this is like a money bag appearance, and the P waves are big, and Madam Helen Tossing called as the Himalayan P waves, and these are the diagnosis, the tricuspid atresia, single ventricle, corrected transposition of great arteries, and we have enormous, and here one thing that you must remember, that we have to learn from each other, stop blaming each other. Everybody pinpoints, though parents are ignorant, they didn't come in time. So who has to train the parents? It is we who have to give the public lecture, write and teach them, and radio talks and bring the awareness. And so today we have to look at each other, learn from each other, and that's what the IMA is meant for. As small as 2 millimeter hole can be diagnosed, but once they go for Eisenmenger's, nothing can be done. And hence the best physician is the one who knows what is possible, what is not possible. So 65% of the congenital heart disease can be completely cured with the devices alone, and the remaining can be operated upon. So the diagnosis of congenital heart disease is complex. If anatomic and physiological principles are understood, you can make a near perfect diagnosis, and today echo has become handy. And next week itself I'm going to talk about the world in the global meet about the 4D echo, how we can give, actually literally looking into the heart, we get the 4D picture, like how surgeon looks into that, and that's how we have made amazing strides. And remember, saving the precious life of a child, the whole family will be happy, and I wish all the best, and thank you very much for your kind and the patient hearing. Thank you very much.
Thank you ma'am.
I started with only 8 beds in 1998, and today Jaydeva is the world class.
Vijayalakshmi Balekundri madam can mentor the next generation of doctors, not only through her knowledge about cardiology, but through her knowledge about life and spirituality too. Now floor is open for questions.
Thank you, madam. You have given valuable insight and with the wonderful coverage of congenital heart disease. Thank you very much.
Madam, greetings from Kodagu Institute of Medical Science, Madikeri. I have a question, madam. Since we are in a government college, we are in a government setup, so it's very difficult for us to kind of have a comprehensive treatment management of cardiac cases. So almost in a month, 1 or 2 cases we are referring either to Bangalore or to Venlock Hospital or to Mysore. So from Jaydeva Institute, any ABRK schemes are there so that we can refer the cases, ABRK schemes, Ayushman Bharat Arogya Karnataka schemes are there so that we can refer those cases to your centers, madam.
I think he has asked the question to the wrong person, because every time, when the person in the private sector, they come, they ask this question, I'm in the government service. Sir, I have humbly put in 46 years of government service. I have treated the poorest of the poor. Never say in the government sector we cannot do. Everything can be done in the government sector, and you can make the diagnosis and send to Jaydeva either in Mysore or in Kalburgi or in Bangalore, anywhere, and it can be done. More than that, now Satya Sai is having the best centers. I have gone even to the Fiji island. Totally free treatment is given to any child with the heart disease. So please use the facilities. Never say that I'm a government servant. Government servants are the one who are treating the real poor people, needy people. So be proud of yourself. Thank you.
Thank you, madam.
I just want to tell one sentence. I had an opportunity to work with Madam in Jayadeva. When I had entered her room, I saw words written in her chamber. I have repeated those words in many public lectures. She had written, 100 years from now, it won't matter what type of sari I wore today, how much of bank money I had today, which type of bungalow I lived, how much of amount I had in my bank account, but world will be better because I was important in the life of a child. Madam, world will definitely remember you because you have touched the lives of many people through children and their parents, ma'am. Thank you.
Thank you. Now I request our chairpersons to honor our speaker, Dr. Vijay Lakshmi ma'am. I request Dr. Geeta Doppa ma'am to honor our chairpersons. Thank you. Now I would like to call upon Dr. Satish Bhatt sir, who is going to deliver a talk on medico-legal approach. I would like to call upon Dr. J.P. Paris sir and Dr. Nandakumar sir to chair the session, and Dr. Advait to give a small introduction about our speaker.
Good afternoon, everyone. It is my honor to introduce our distinguished guest speaker, Dr. Satish Bhatt. Dr. Satish Bhatt is an accomplished consultant plastic surgeon and the director of Linea Cosmetic and Vein Clinic, Mangalore. With an impressive academic background, he has made a remarkable contribution in the field of plastic surgery. A recipient of prestigious Kilner Award from Association of Plastic Surgeons of India for original research in 2012, and R.N. Sinha Award for Best Publication in the Indian Journal of Plastic Surgery in 2013. Dr. Bhatt has been the forefront of innovation and academic excellence. Beyond the clinical expertise, he is a founding member of AMC Mangalore, where he played a key role in drafting its constitution. He also serves as a convener of Medico-legal cell at AMC Mangalore and a co-founder and managing director of VIDOCTO, an online platform for medical CMEs. Dr. Bhatt is a strong advocate for ethical and evidence-based medicine practice, patient safety, and doctors' rights. His dedication extends beyond the medicine. He is a qualified advanced mountaineer from Nehru Mountaineering Institute, Uttarkashi, embodying both resilience and determination. Today we have the privilege of hearing from him, and I have no doubt that his insights will be invaluable. Please join me in welcoming Dr. Satish Bhatt.
Respected chairpersons, it's my honor to be here and share my experiences with all senior members and the audience. I'm particularly grateful to IMA Puttur President Veena Madam and Secretary Dr. Ravikant, who have invited me and made me part of this academic feast. I have the not so enviable job of trying to keep you engaged after two wonderful talks by my elder brother Dr. Sriram Bhatt and Madam Vijay Lakshmi. Let me see how much justice I can do. So I can see that most of the people in the audience are youngsters. I believe they are all MBBS students, and sooner or later all of you will be joining some PG course and you will be a resident doctor. So my question to all of you residents, I think you are aware that doctors can be pulled up in court for medical negligence. So assuming all of you, each of you is a postgraduate doctor in doing a recognized postgraduate course, is it possible that you can receive a notice for medical negligence, a legal notice, while for some patient you have treated under the supervision of your unit seniors while working as a PG? How many of you think that it is not possible? Please raise your hands. Okay, how many of you think it is possible? Please raise your hands. Please raise all the way to the top. I hope by the end of this lecture, everyone would raise their hands for the same question, because the fact is that you are liable. What should be done is that the moment you join a postgraduate course, in fact, ideally the day you finish your internship and you get your permanent medical registration, you should have a valid medical indemnity. It is same like having a driver's license if you want to take the vehicle on the road. As good as that. Till the time we are 18, for short distances we drive our vehicles, parents, friends and so on. But the day you are eligible, please do that. Practicing without medical license is like driving a vehicle without having a driving license. And there's go for group indemnity, something like what the IMA Professional Protection Scheme has. Become a member of IMA. With this background, I will go further. See, though I have been asked to speak about approach, but what I will do is I will just use one area of the medico-legal matters or legal medicine to illustrate how either fuzzy things are, but despite that how we can have a systematic approach. So I have taken this scenario of defamation where doctors get abused through various platforms, either individually or collectively. And I will just show you how this can be addressed by individuals, by an association and an organization, and how you can benefit from it. So defamation, I'm sure you all understand from the word, it means to say something that harms an individual's reputation. Okay. Now I've just tried to group it into different types because what I am going to say is not mentioned in any books. This is based on my own experience over the last 15 years. We are a group of doctors who based in Mangalore. We have an organization, all of whom are IMA members, but basically consultant doctors. So just sharing our experience. So I'll give you various scenarios to explain each situation. Now, defamation on social media. I think you would be aware of this incident that is playing out in Puttur, where a gynecologist is being royally roasted by the media through social media. Unfortunately, he has been caught in a situation where there was a mob that remained. In fact, the situation gets so twisted. I was just discussing this with my wife. She is not a doctor. She says, can you please use some word besides mob? The reason why. She says, whenever any non-medical people, they hear the word mob, they only think of the sweeping mop which is used on the... So how the hell can this get retained in someone's abdomen? So this is the extent to which we have to think from the perspective of society. And this is an example of a situation that falls under the category of indefensible error. there is no way to defend this. Unfortunately, it is a situation that can happen anytime despite the best standard of care. Okay, it's called an indefensible error, and unfortunately there is no way to defend. But there are other situations where there are complications, and the patients, the doctor unfortunately has to face the heat. This is an example of a scenario that happened in Udupi many years ago. The senior doctors may perhaps remember, where a lady basically passed away due to PPH. Okay, they tried an obstetric hysterectomy done by a senior gynecologist in a well-equipped hospital in Udupi. Unfortunately, when she was still continued to deteriorate, they referred her to KMC Manipal, and despite the best effort, she passed away. Now, if you see this social media post highlighted, the number of lakh views, okay, that this one post, and you can see from the description, nerve, blood, nerve, there is no such structure, but this is the way people understand. So this created so much of a commotion. Initially, of course, the security, safety of the hospital and the doctor were ensured, and the matter was dealt as per law regarding the allegation against the doctor. But then regarding this defamation, we tried taking it up. Unfortunately, the doctor was under so much pressure. See, this was a situation which definitely was not negligence, because the doctor had performed her duty as per due standard of care. We cannot assure 100% successful outcomes in every situation despite the best of our efforts, and that is what basically is the criteria to decide whether negligence has happened or not happened. And in this case it had not, but because of the pressure that under which she was for a couple of days, a very leading doctor who was seeing almost close to 100 patients a day, just imagine, all of a sudden there's virtually 1 or 2 patients in their OPD, the mental shock that they end up in. So she was not willing to pursue this matter legally, but this is what happens. This is a scenario of a pediatrician and a pediatric surgeon. So these are the kind of messages that get circulated in social media. So there is something called emotional, just like IQ, intelligence quotient, there's also a EQ, emotional quotient. So people are able to relate to emotions more than facts and logic. So whenever there is any information, message or news, whatever is emotionally charged up in that is what attracts their attention and stays in their mind. And unfortunately, negative emotions, they stay longer as compared to positive. This is another type of defamation where media either deliberately, now I'm talking of the mainstream media, not social media. So basically online news portals or even print newspapers, okay, they publish wrong information either knowingly or unknowingly. Now this was a scenario again that happened in Udupi, where a very senior physician, he had advised a patient who unfortunately for certain precautions who had consulted him for IHD, ischemic heart disease. And he was a political leader. He believed that he knows more than a doctor. He didn't follow the advice. He collapsed a couple of hours after consulting the doctor. Actually, doctor had asked him to go to a hospital, get admitted for further evaluation. He decided he knows better, and he went home. He collapsed. He couldn't be revived, and he passed away. Now, just because he had seen a MD physician a couple of hours before this, they decided someone has to be held responsible. Okay, so they created a commotion, and this is what the media reports, saying, fake cardiologist. Come on, I mean, MD cardiology as a course, it started, madam would know better. So it started only, I think, sometime in the 60s or 70s. And even now there are so many cities. Now, for example, I don't think Sullia has a regular round-the-clock DM cardiology. Okay, but there are senior MD physicians who will do a good job. And they know their limitations. They will do the basic things. They may not do the advanced things which only a qualified cardiologist can do. But imagine to call such a senior MD physician as a fake cardiologist. There can be nothing, more that will hurt the doctor. So what we as an association did is to counter this. It needs to be said in one line. You know, it could have been stronger, but then the media, they have their own minds. But we at least got them to point blank rebut the news. And fortunately, the same newspaper, they published this just with 2 days interval. Now this was another scenario where a lady who was in 32 weeks pregnancy with a premature labor. Okay, so there was some commotion. She was, she went into premature labor, and I think there was an incomplete abortion. So incomplete abortion needs to be completed surgically, otherwise it is a threat to the mother's life. And this was called illegal. Can you imagine? And in the same news report, they further also mentioned that, you know, it is 7 months. So beyond 20, now probably 24 weeks, there's no way an abortion can be done. And this was in a teaching hospital of a teaching, medical college set up in Bangalore. So if you read different parts of the same report, you realize how self-contradictory they are. So these are various scenarios to show you how doctors individually and as a community, they get targeted. Most of us, when we are driving, we listen to FM radio. So one of us, one day I was driving, and while listening to FM, I was shocked to hear a small incident where they had a guest, a random person from the public, who ended up saying, if you have a grievance against the doctor, lodge a complaint. So we decided to do something. We went and we went to the office of this FM channel in Bangalore, and we told them we want to lodge a complaint against you. Okay. And why? Because you are instigating people when there is no issue. Then of course they realized what mistake they have done, and we were able to get them to agree. See, you can't just go on firing all cylinders and use attack just because something wrong has to be done. You have to have some sensible approach. So we decided to use their own platform to counter the wrong news with the right news. So basically we got them to give us a session, and we did a program explaining how the simple point that every complication is not negligence, just one line. In fact, I'll explain further. Every unfortunate incident is not a complication. There is an entity called as medical accident. And in fact, this is an example of this. See, a senior neurologist in Bangalore, he was fined by the Consumer Forum to pay compensation because one of the children he had prescribed Eptoin, they developed Stevens-Johnson syndrome. Now, Eptoin is a first-line drug for epilepsy. It's a wonderful drug. I believe it is still used. Okay. Despite all this, there is a chance, maybe 1 in 1 lakh or maybe 1 in few lakhs, that they have a skin eruption that is called as a Stevens-Johnson syndrome. And this, there's no test to predict this. All that they do is, if there is any chance that you find a complication or any fever or any issue after the medication is begun, please report immediately. Now this was documented, explained and told. Unfortunately, when the child developed this problem, they ignored it, and it led to severe problems. And eventually the Consumer Forum, can you believe, they said that the senior neurologist is negligent. And Stevens-Johnson syndrome, just for you to understand, if it becomes very severe, it is like grade 4 burns, where the person can have all the manifestations of a burn, toxic shock. This condition is actually called as a medical accident. Unfortunately, this is not an accepted legal entity in India. Abroad, this is an accepted kind of situation. What a medical accident simply means, it is an unfavorable outcome, also called as an injury, medical injury, which simply cannot be predicted despite the best standard of care that is followed. It can happen even again. All we can do is keep improving our standard of care. Fortunately, they have appealed, and we are hoping for a favorable judgment. Random comments by the authorities, political leaders. Okay. Now, a few years back, the DC in Mangalore, so he, during some interaction or some meeting where media people were present, he made a statement, you know, in hospitals which have maternal deaths, register an FIR under 307. IPC 307 is bloody murder. I mean, we are not waiting in the hospital saying, you know, the next person who is going to come, I am going to kill them for some sadistic pleasure. But that is what it means. This, unfortunately, message that goes without any correction, it sends a wrong idea to society. Unfortunately, we couldn't do much in this scenario. And this is, of course, a politician in Bihar. He says, who said that, you know, doctors are worse than hangmen. Kasai se bhi battar hai. Unfortunately, such comments are even passed by responsible people in who are working as, you know, judges in the High Court and Supreme Court. There was this Chief Justice of the Bombay High Court who, on one hand, she said, you know, if you are afraid to work because of violence, then, you know, you sit at home. And the same High Court judges, when they feel the threat of violence, they say that, you know, you give us security because otherwise we cannot do our job properly. Unfortunately, this is the, you know, double standards that society applies. We have to live with it. So, in these various scenarios, what are the options that we have? These are, of course, the various technical provisions, but the larger message I would like to say is, you know, do not succumb to the pressure. Do your duty. If you have done things honestly, with, you know, your integrity, take help, contact people, don't succumb to pressure. I am saying this repeatedly because even senior doctors, when under the heat, under the pressure, despite meeting them, giving them advice, they are unable to, you know, stand up to the pressure. They have paid money and then things go out of hand. You know what happens? They pay money off the record. That same money given is claimed later by the patient's family that they have tried to pay this to silence us. Okay, that we are entitled to much higher negligence. And when this happens, you know, the matter goes to court. So initially the question is, was there any negligence? Once the fact that they have paid, it goes on record. Now there is no doubt that negligence has happened or not. It is assumed that, you know, negligence has happened. Now the question that only remains is, what is the gravity of the offense? What is the appropriate question? What is the appropriate compensation? So this one reckless act, of course, a person is under pressure. Maybe calling reckless is not a good idea. But this one act of trying to get away the easy way, finding shortcuts, can lead to disaster, and things can go out of control. People can be punished for defamation on social media. The police, if they make up their minds, they can do a wonderful job. This is one example where, you know, after I think almost 15 years, an SP in Ernakulam, Kochi, so he, a married lady had an affair, she got pregnant, the twins and the mother were found killed 2 weeks after birth. They couldn't do anything. Eventually what happened is that they used AI. They found some connections he took it upon himself, some new SP, almost 13-14 years. This case, by the way, got solved in January 2 months ago. He took it upon himself to try and identify the culprits. They were actually people who were armies or soldiers who had come on leave. After committing this crime, they deserted the army, then they changed their identity, they were living elsewhere. But somehow using AI, they managed to trace them through social media, and eventually they were arrested. This was another example, but I'll just skip it. Can you shift to the next slide? Yeah. So how can we prevent this? See, one thing to need is to try and understand how the media works. Whenever there is an incident or even before, it is preferable that every hospital has someone as a PRO who is willing to interact and give the media people the correct information and picture. One more important thing is never, never, ever speak poorly of your colleague. This is called as medical jousting. Jousting need not be through words, spoken or written. It can be through subtle, just body language. For example, a patient has, a few years later, you will be senior doctors, and there is a patient who has come in after being handled by, say, a MBBS general practitioner or even just a MS surgeon, and you may be, MCH or DM. And after seeing this thing, X-ray or the reports, even if you look at it in a very odd manner, that is sufficient to give a hint. In fact, patient and attenders will deliberately ask, Doctor, munchin doctor ಮಾಡಿದ್ರಲ್ಲಿ ಏನಾರು ಹೆಚ್ಚು ಕಡಿಮೆ ಆಯ್ತಾ? Was there any issue in the treatment given? Is a standard question. If you don't answer that promptly, if there is some hesitation in your voice, they will say, okay, they will get the message, okay, something was wrong and this doctor is not, that is the reason he is hesitating. So please don't give the other side an opportunity to do something that is going to harm your colleagues. If there is something genuinely wrong, there are always official ways to take it up. So this is what I was explaining earlier, what is called as a medical accident, where Stevens-Johnson syndrome is a classic example of this. So as I conclude, I will just like to drive home this matter. Whenever there is a medical injury or an unfavorable outcome, what is commonly called as a complication, implying there is some lapse in the treatment, please change your thinking as to whether there was a negligence at all or was it something that was perhaps inevitable. Okay. This is just an example of how seriously other people in other walks of life take defamation. Okay, so there was this one judge of a Supreme Court. His photograph was wrongly shown by this national news broadcaster because when Arnab was actually explaining, or rather he was delivering the news regarding some gangster who had got arrested or something, by mistake this retired Supreme Court judge who had the exact same name, his image got flashed for half a minute or so, and this is how seriously he took for this incident. And now compare that to what we as doctors do. One more concluding important point. Why is it important to take this defamation seriously? Because if you ignore it, it is just the precursor of violence. Defamation is a way where they vent out their anger. They are perhaps at that point of time unable to do something bigger. But if you keep quiet at this, either they or the people with them, violence is the next inevitable step. So if you want to preempt violence, please fight defamation. And these are the examples of violence. Don't believe it can just stop at getting assaulted, pushed, slapped, some injuries. So doctor is actually shot dead. Another example, and this is what can happen if people are wrongly convicted. PCPNDT is what is called as a draconian act. The doctor, he was convicted in sessions court and he was to be physically taken to jail, and he couldn't come to terms with this mental trauma and he kills himself in the courtroom. So these are actual examples. One more example. I think with this I would conclude. Basically, as I mentioned in my initial slide, please follow an ethical evidence-based practice, and that is perhaps the best way to stay safe. Join IMA, become members, take indemnity protection, get a medical insurance, a practice insurance. With this I conclude. Thank you.
Thank you, sir. Thank you for your, Dr. Satish Bhatt, for your valuable and wonderful, so many papers and media outputs regarding defamation cases and medical accidents and assault on duty doctors. Thank you, sir. So one conclusion, and for upcoming doctors, it's better to have a good format in the MLC cases regarding whatever the hospital, private hospitals or primary health centers, community health centers, taluka hospital, district hospital, and as well as medical colleges also. Emergency cases, all of a sudden, day and 24 hours, 24 into 7. When the cases comes means by taking good information regarding the age of the patient, Aadhaar card based or informant and identification mark, and brought by whom. So better way to document all those records. It will be helpful for in the cases of audit, case audit. It will come as well. The district commissioner of the district, he will be the president or adhyaksha for all the cases regarding the feticide or abortion or maternal death, as well accidents, medical accidents in the hospitals. Thank you, sir. Any questions?
Thank you, sir. It was a wonderful presentation. Now I request our chairperson to honor our loudspeaker. Now I request our Dr. Rangnath to honor our chairperson, Dr. Nandakumar and Dr. J.P. Pal. Thank you, sir.
Thank you, sir. Now I would like to call upon Dr. Shirom KV, sir, who is going to deliver a talk on approach to eye emergencies. I'd like to call upon Dr. Mahesh Babu, sir, and Dr. Archana GS, ma'am, to chair the session. I'd like to call upon Dr. Nikita Pandey to give a small introduction about our speaker.
Good afternoon, everyone. It is a privilege for me to get a chance to introduce, sir. It is my privilege to introduce a distinguished leader in the field of ophthalmology, a visionary, Dr. Shivaram KV, sir. Dr. Shivaram KV, sir, is the founder and medical director of Ganesh Nethralaya, serving the regions of Sirsi, Sagar, Bhatkal. With over 3 decades of experience, he has made remarkable contributions in the field of eye care. Currently, he is the president-elect of Karnataka Ophthalmic Society and has held several prestigious positions, including president and assistant governor of Rotary Club, president of Uttara Kannada Ophthalmic Society. He has also served as the secretary and president of IMA Sullia. His contributions have been widely recognized with numerous awards, including the Vocational Excellence Award by Rotary International in 2015, the Kadamba Seva Ratna Award in 2011, Lifetime Achievement Award by IMA KSB in 2020, Community Service Award by KOS in 2020, Lions International Award for his outstanding work in Side First activities, Exemplary Service Award by Dr. M.M. Joshi Eye Institute. Beyond his clinical practice, Dr. Shivaram sir is the founder and chief trustee of Nayana Foundation, which manages the Lions Nayana Eye Bank and Nayana IMA ROP project, providing crucial services for eye care. His foundation also promotes arts and literature through Nayana Sambhangana Auditorium at Ganesh Nethralaya, a regular speaker and panelist at various esteemed platforms, including KOS, Rotary and IMA. Dr. Shivaram sir continues to inspire young ophthalmologists and healthcare professionals. We are truly honored to have you, sir. Please, I welcome you, sir.
Thank you for the introduction. Just start, please. I am aware that I am standing between you and the lunch, so I like to shortcut as much as possible. though my talk requested is on ocular emergencies, I would like to talk few slides on importance of ophthalmology in general practice. See, we are all blessed. We can see the world, beautiful world with our eyes. But 37 millions of people in the world are blind because of various reasons, including cataract, corneal scar, diabetic retinopathy, AMD, etc. As a general practitioner or the other specialty other than the ophthalmology, what can we do? What common things we face in our practice or with our relatives and friends is management of acute red eye, the commonest symptoms. And then eye examination in systemic diseases. Which are the systemic diseases we need to refer or do the importance of eye examination. And ocular emergencies, some myths and facts, if time permits, some recent advances. Acute red eye, commonest reasons are conjunctivitis, as all of you know. The second one is foreign bodies, either in conjunctiva or cornea, iritis, iridocyclitis, episcleritis, corneal ulcer or aberration, subconjunctival hemorrhage, pinguicular pterygium, there are some inflamed. These are few of the common causes. What we need to see, I am not talking about slit lamp or microscope, just on torchlight, what a general practitioner can see is whether it is uniocular or binocular. That gives a lot of information. And second is discharge is present or adnexia, like in eyelids or the lacrimal gland area, is there any swelling, inflammation, stye, or these things are there. And the site of redness, where exactly is the redness, whether it is near to cornea or away from the cornea or towards the conjunctiva. And the vision, if we are just as before the redness and after the redness, whether vision has decreased or it is same. And photophobia, it's whether they are avoiding light or difficulty in seeing light, and pupillary reaction. These are the simple things which can be picked in the torchlight. These are some of the common things. It's an inflamed pterygium, that's an overgrowth of conjunctiva. That's a pinguicula, subconjunctival tissue which is inflamed. And this one, anyone can answer? First one, students. First one, corneal foreign body, it's inflamed and there is a pus inside. That's hypopyon, what we say. The other one, it's a not just a cataract, it's a hypermature cataract with lens-induced glaucoma. It's hypermature, it has burst and the eye pressure has increased, wherein pupillary reaction is also not be there. It's a sudden onset. And first one, subconjunctival hemorrhage. It's a very common thing. Painless. Most of the time, they won't even recognize. Family members or others will say, there is some redness in the eye. So they will run up. The most common condition is hypertension, uncontrolled, or trivial injuries. And there are other conditions. It's a self-limiting one. Other thing, left one, is chemical injuries. It's a very common one. If we take the history, sometimes that side is an inflamed corneal scar, and this is a rare condition where we get nematodes also. And which conditions in the systemic diseases where the ophthalmic examination is necessary? In hypertension can cause subconjunctival hemorrhage, vitreous hemorrhage, central retinal vein occlusion, artery occlusion, even papilledema. Sometimes exaggerated hypertension can cause papilledema, that is the swelling in the optic nerve head. And TIA, transient ischemic attack, is also uncontrolled hypertension can get. And in diabetes mellitus, most important, adnexial infection, frequent change in the glasses, and early age cataracts, and most important is retinopathy. And collagen vascular diseases like scleritis, episcleritis and uveitis can cause. An infectious disease like leprosy and tuberculosis I just want to say a few more words on diabetic retinopathy. Most of you general practitioners and other practitioners can prevent this blindness, because in the global wise, this is now the leading cause of blindness, and in India, it is almost nearing to cataract. After the cataract, now it is second. Just 10 years before, it was the fourth or fifth, now it is second, because the diabetics are surviving for longer time. Even they survive for 10 years, 20 years, 30 years, the complications of diabetes like retinopathy, nephropathy, all these pathies will, neuropathies will start. So early detection is most important. This is with macular edema, that's a florid diabetic neovascularization is there. This is a normal fundus, how it looks, and this is the angiogram. So it is recommended that all diabetics at the time of the diagnosis, once comprehensive eye examination, and then later 1 yearly for first 5 years of diabetes, and after 5 years of diabetes, 6 monthly to check up the eyes. Not with the opticians. Many of the small places, they think checking for refraction in an optical shop itself is an eye checkup. We come across many patients. So that with the ophthalmologist, intraocular pressure, dilated retinal examination is a must regular checkup for all the diabetics. And some of the general condition can be picked from the eye examinations, like anemia and jaundice. As you know, neurological diseases like 3rd, 4th, 6th nerve palsies, intracranial space occupied lesions, and pituitary tumors. With these, where we need to do field test, fundus examination to rule out papilledema or optic atrophy, all these conditions, and in the evaluation of headache. And headache, many of the patients will have refractive errors, ocular motor disorders, or glaucoma, computer vision syndrome, some of the conditions where we need to see. Some of the myths are regarding refractive errors. Many of, with the spectacles prescribed, in the younger age, they need to use it for regular use, not for reading, only for distance, only for near, no. Only presbyopic glasses after 40 years, they can use only for the near. Otherwise, the spectacles has to be used for regular use. And cataract, I don't want to go in detail about it. And the maturity is not necessary. Now with the advanced technology, even in the early stage, where once the cataract disturbs their day-to-day life or professional life, the surgery can be done even in the early stage. And time of treatment of squint, many misconceptions, even in the pediatricians, even in the doctors, they advise, no, it has to be matured after 18 years, after 12 years, no. It has to be done as early as possible. Not just the surgery, any management of squint. Sometimes it will be treated with glasses, sometimes with the medicine, sometimes with the surgeries. Because binocular vision will not be there if we treat in the later stage. As early as possible treatment is very important. So please refer. Even if they don't complain, they come to you, children, with some other problem, you find squint, refer to ophthalmologist at the earliest. And coming to ophthalmic injuries, mainly, I come to my topic now, mainly there are mechanical injuries or non-mechanical injuries. From the mechanical injuries, extraocular foreign bodies, blunt trauma, perforating injuries, intraocular foreign bodies, and penetrating. These are the common things which we find. And non-mechanical injuries like chemical burns, electrical injury, thermal injuries, especially when they do the electrical work and welding work. They come with this radiation injuries more. And chemical injuries are the really true ocular emergencies. Every minute, every second counts to prevent blindness. Most chemical injuries are two types, alkali and the acid. See, alkalis are the ones which are most dangerous. What we get the most alkali injuries is suna, this lime injuries. So once they put it in the, see, lime comes in small pockets. Once they want to just open the pocket, it just, when they press and they enter the eyes. This is the commonest injury we get, chemical injuries. In this, severe damage occurs because of saponification and denaturation of the collagen in the conjunctiva and cornea. So every minute is important. So extent of injury depends on the strength of the chemical agent, concentration, volume, and duration of exposure also. Acid doesn't cause much damage except some epithelial defects. And it's on clinical examination, we see the gradings. How much is the extent of injury depends upon the cornea and scleral involvement, limbal ischemia. But most important thing to take home message is, if you find, if any patient comes with lime injury in your practice, please don't refer the patient to ophthalmologist straight away. Do the immediate treatment of washing, cleaning with the topical, you can use topical anesthetic agents, or if you don't have topical anesthetic agents, you can use even the simple lignocaine injections also. You can put for a few drops and copiously wash, and if you see any particles and the materials, remove that and then wash it thoroughly. Thorough washing is simple, is any IV fluid, you have normal saline, a ringer lactate, anything, you put it on the in the IV stand and IV this tube, and then continuously irrigate the eye at least for 15 to 20 minutes. This immediate what you do will save the vision. We can do the rest of the treatment can be done by ophthalmologist later. By the time he reaches the ophthalmologist, will be hours together and they're waiting and all those things. No, they can lose the vision permanently. So most important take-home message is to do irrigation, copious irrigation, wash and remove the debris as early as possible, and please sensitize your staff also, the receptionist or the staff, not to make them wait in the waiting hall, because it has to be done rushed as early as possible. And other treatments like topical steroids, or depending upon the severity, we will take care. I don't want to go into the details, the severe ones, what we do. And the surgical treatments are also there, like amniotic membrane grafts in severe cases, temporary torsorrhaphy, and if there is a perforation, there's a tectonic graft or sinocleric git can be used. And in the later period, once the complication happens, symblepharon, that's the adhesions in the conjunctiva, can be released, and correction of lid deformities, and all these are done in the later stages by the specialist. But most important is to do cleaning, washing as early as possible. Coming to mechanical injuries, the common mechanical injuries what we see is lid injuries, and many especially children who play, and then accidents, two-wheeler accidents also it's common. See, very important thing in this is, once it is not like any other area of skin. There are few things to be considered while suturing or doing the primary, this thing is, in this general principles stands like cleaning and cleaning the debris and all, careful handling of the tissues. Most important is anatomical alignment of structures of lid, margins, very important. If we do sutures little irregularly also, if ectropion or entropion happens, eyelashes touches the cornea, it will cause permanent problem in the cornea, like the recurrent corneal ulcers, corneal abrasions and other problems. And also when the injury, skin injury is to the medial side, medial nasal side of the lid, we have to remember that there is a lacrimal tubes, lacrimal cannulas pass through the medial part, and that has to be taken care while suturing. It needs a specialist care to do that. And very important is cosmetic also. It is on the face. If it is irregularly and not properly treated in the initial sutures or the repair, and permanent scars can happen. So it needs a proper understanding of the anatomy and do it. And one point I want, and then superficial lacerations is treated by or sutured by 50 or 60 sutures, and lid margins are to be carefully sutured, just like what is shown in the picture. And here it is shown lacrimal canicular repair, how it is done, and by locating it, and silicone tubings are done, first put, and then the suturing and other procedures are done, and the silicone tubing has to be left for 3 to 6 weeks depending upon the wound. Now next comes the penetrating injuries. There can be full thickness injuries caused by sharp objects. It's a globe injuries like corneal laceration, corneoscleral laceration, and scleral lacerations. Most important thing in this is what not to do. I know you cannot handle others and they have to refer to the ophthalmologist. But thing is, what not to do is more important here. Please don't flush the eye if there is already breakage in the epithelium or it is an open wound in the eye. Don't remove any object inside. Like it can look like foreign body, it may be a part of lens, part of iris. Don't try to open or remove anything. Don't put pressure. Pressure may immediately cause expulsion of the tissues, which are very important. And do not don't put any ointment or drops. You can just patch or close and then send them as early as possible to the doctor. So these are some of the injuries which you can see. We come across many times a small corneal aberration from open wound cornea, and iris part has come. Many times in the torchlight looks like a foreign body. Somebody wants to remove it, and you end up pulling the whole iris, or along with that lens or vitreous. So it is half attached. So that, and the wound with inside hyphema. All these are very important. Please, more important is what not to do rather than what to do in this. So the management principles are mainly to maintain the normal contour of the cornea. Usually corneal sutures are done with the 10-0 nylon and from the center, and it is done under microscope, and the 75 to 90% of the depth of the cornea has to be taken for proper apposition and to close the wound so that infections will not happen, and to lesser astigmatism. Once the cornea is scarred up, it is cause astigmatism or astigmatism, or we can say cylindrical power will come. So because of irregular cornea, if properly closed, it will be minimum, and sutures need to be buried properly because the foreign body sensations will be there, because cornea is the most sensitive organ, and the other scleral, perforating injuries are scleral lacerations. And the principles are same. And then the blunt trauma. Blunt trauma is the one, it's a forced compression with sudden increase in the pressure in the eye. In the blunt trauma, most commonly we come across with hyphema. Hyphema is blood in the anterior chamber. If it is very less than 1/3 with eye pressure is normal, it can be treated with 1/3 to half, can be treated with medications, anti-glaucoma medication plus steroids and anti-inflammatory drugs. But once if it is more than 1/3 or staining the cornea, we may need to remove the blood as early as possible, and AC paracentesis what we call. And coming to this is how the blunt trauma can cause the damages in the eye. And most important is to recognize the floor fracture. So even though eye looks fine, they complain of diplopia or double vision. So only small, they come with the diplopia or double vision, but they give later history of fall or some blunt trauma. Sometimes with that there may be fracture in the floor that has to be surgically repaired. I don't want to go into the detail of the surgeries. This is how it looks, the surgery. And if time is there, I would like to, this is about my topic on injuries which can be picked up by torchlight examination and what to do and what not to do for the others. This is not for ophthalmologists. I have not gone into details of this. And some of the recent advances in ophthalmology is in the field of cataract, micro-incision cataract surgeries with advancement of no stitch, no injection, and early recovery with multifocal or EDOF toric IOLs, these implants. It has really, cataract surgery is not just a cataract surgery now, it's a refractive surgery to minimize the dependency on glasses also. And in the glaucoma, as earlier days we used to say, they are going to go blind. Now it is not like that. If we detect early, manage properly, we can save millions of eyes. And then refractive error, LASIK laser, ICL, implantable contact lens, all these have come for our help to treat the refractive error. And the ideal cataract surgery, because it is the most commonly done surgery, I would like to say a few points. It's an early visual recovery. The ideal cataract surgery is minimum pain and discomfort and quick healing and early routine activities and minimum chance of infection and complication with least dependency on spectacles. And most important advancements which have been done recently is optical biometry, optical coherence tomography. Optical biometry is to know the exact IOL power which has to be put. OCT is the machine, just like CT or MRI gives the exact the retinal conditions, how it is the anatomy. Pentacam for cornea and specular microscope to know the endothelial count. And related to the operative room, modular operation theaters, microsurgical instrument and coaxial illuminated microscope, modern microscope and modern phacoemulsification machines and vitrectomies and IOL technologies. This is the simple thing is once we remove the anterior capsule, the whole nucleus is emulsified or cut into small pieces, removed and the foldable lens is put. And this is the ultrasonic biometry, that is a optical biometry, advanced one. And this is a B scan to know when mature cataract, whether the retinal condition is normal or not. That's about OCT scan. And this is a pentacam, and that is a fundus camera. These are the phaco machines and modern microscope. And for preventing infection, CSSD, and almost we can achieve zero infection without antibiotics also. And to manage complications, YAG lasers and vitrectomies when there are problems. And the newer intraocular lenses, gadgets from monofocal to bifocal, trifocals, and extended focus, toric, and all these things have come to our help to manage this. This is a toric lens. When there is astigmatism, how we do the toric marking and do the toric lens so that spectacle dependency is reduced. Almost 15 to 20% of people who need cataract surgery may need toric lenses. And it's ophthalmology is not a one-man show. It's a teamwork with surgeon, optometrist, biometrist, ocularist, OT personnel, and housekeeping staff, store manager, record keeping, and all people are microbiologists, anesthetists, all are necessary. So I thank all of them for giving me opportunity to do this service in this field. Thanks the organization, especially Veena Madam, Dr. Mahesh Babu, our good friend, and for patients listening, all of you, and Vijayalakshmi Madam for being with me today. Thank you. Thank you all.
Thank you very much, sir. That was very insightful, crisp but still comprehensive on general ophthalmology as well as ocular emergencies. And the take-home message is what to do and what not to do as a non-ophthalmologist. And I wanted to open the session for questions, but since we know that delayed lunch-induced hypoglycemia, I don't think anybody would come up with any questions. I think we could be closing the session. Thank you very much, sir.
It was a nice presentation. Now I ask our chairpersons to hand over the token of gratitude or honor to the beloved speaker.
See, one thing is better to protect our eyes with the glasses when doing any surgery. One. So even if it is blood is entered the eye, see, we know that intact epithelium, HIV virus cannot enter. Even HB, this. So intact epithelium it cannot enter. The best thing is wash. With a normal saline or even a potable water is sufficient. Frequent washing for 5 to 10 minutes is more than sufficient to prevent the HIV infection. Okay. Huh?
Thank you.
No, doxycycline is not just used as an antibiotic. There are some immunomodulator component in the doxycycline, so it is used in some chemical injuries and certain conditions. It is not as an antibiotic. It is as an immunomodulator it is used, not as an antibiotic. Surely. It is for longer period, 3 to 4 weeks. As an immunomodulator, not as an antibiotic.
Thank you, sir. Now I request our chairperson to honor our speaker. Thank you. Now I request Dr. Indira Dodabalapur to honor our chairpersons. Dr. Mahesh Babu, sir. As well, Dr. Archana ji. Thank you.
Lunch is now ready. We kindly request you to return by 2:30 p.m. so we can resume the next session on time. Enjoy your meal. To take over.
मैं तेनू समझावां कि ना तेरे बिना लगदा जी मैं तेनू समझावां कि ना तेरे बिना लगदा जी तू की जाने प्यार मेरा मैं करूं इंतजार तेरा तू दिल तू यो जान मेरी मैं तेनू समझावां कि ना तेरे बिना लगदा जी तू की जाने प्यार
Call your friends inside the hall. Call everyone, come inside the hall. We'll start one next session. Before going the final session of the today, we shall have one small quiz. I request everyone come inside the hall. We'll start the next session. You can scan the QR code or you can go to slide.com and enter the code. Try to put the full name so that there is no confusion when you win the prize. If similar names are there, you may have to share the prize. We can start now. Anybody wants to join? Okay, if there are no more, we'll start. So now there are less participants, so more chances of winning. Congenital heart disease starts when the fetus is in mother's womb, occurs at birth or soon after birth. So everybody has taken a right answer. When do you call blue babies? Blue discoloration of fingers and toes tips, blue coloration of tongue, lips and conjunctiva, none of the above, all of the above. So most have answered all of the above. Let's see. Yeah, that is the right answer. How can congenital heart disease be treated? By heart surgery alone, by interventions, by both, by medicine alone? Quite straightforward questions. So by both. may be the right answer. Yes. Defamation means damaging the good reputation of someone by which of the below: spoken words, written words as in news article published, by broadcasting through social media or online platforms, all of the above, none of the above. Again, straightforward question. It will 100% they have taken the answer. So all are right. Medical accident needs the following components except unwanted injury to the patient, due standard of care is maintained, has happened in the hands of treating doctor, precise cause of injury unknown, incident may repeat in future. So their varied responses are there. Almost every answers have been taken, I think. Has happened in the hands of the treating doctor. What is the most common cause of enucleation? Glaucoma, retinoblastoma, severe trauma, eye donation. Again, there are varied responses. Let us see what is the right answer. I think right answer has got less responses. Eye donation. Which medicine should not be used in case of corneal foreign body or abrasion? Artificial tears, corticosteroids, antibiotic ointments, antihistamines. Again, varied response. Corticosteroids is the right answer. What is the second most common cause of blindness in the world and the fastest growing, which can be prevented timely referral by physician or general practitioners? Diabetic retinopathy, glaucoma, age-related macular degeneration, cataracts. So many have taken diabetic retinopathy. So that's the right answer. Likita, please come forward. Samuel Nikshep. Give them a big round of applause, please. Thank you everyone for participation.
Now I would like to call upon our next speaker, Dr. Bhavya. She is going to speak on a topic, basic life supports. I call upon Dr. Tara and Dr. Rangna sir to chair the session. And I would like to call upon Dr. Kirtana to introduce our speaker.
Good afternoon, everyone. Dr. Bhavya is a dedicated medical professional specializing in OBG. She completed her MBBS from Mysore Medical College and pursued her MS in OBG from prestigious Lady Hardinge Medical College, New Delhi. Currently, she serves as a professor in the Department of OBG at KVG Sullia. In addition to her academic and clinical expertise, Dr. Bhavya is a certified ECLS trainer and has a keen interest in scientific research. Her commitment to medical education, patient care, and advancing knowledge in the field of OBG makes her a valuable contributor to the medical community. Over to you, ma'am.
Thank you, Dr. Kirtana, for that brief introduction. Good afternoon, everyone, for this session. See, ours is a profession where the seconds means a difference between the life and death. So that's why we are here for this session, basic life support. It's a skill that can save the life of a patient before the advanced support which arrives. So it's very essential to know the basic life support. So can I ask a question? So what do you understand by medical emergency? What is the emergency? Yes? Can anyone answer from the students? Yeah. What is an emergency? A medical emergency? Anyone? What is it? What is an emergency situation in terms of medical? What is it? Anything which is dangerous to the life, right? Anything which is dangerous to the life of a patient. So medical emergency, there are various causes, infectious or any danger to the vital organs or road traffic accident, poisonous, many things. One such medical emergency is a cardiac arrest. Yeah. So you can see the situation here. And yeah. So what is it? The patient has collapsed, right? So the collapse can happen like anywhere, right? It's not just that it happens in the hospital settings. It can happen anywhere at your home or when you are in the shopping mall or the roadside, any functions, anywhere. This emergencies you can come across, the patient collapse. So one more question to you. What you will do when the patient collapses in front of you? What do you feel when the person in front of you collapses suddenly? Will you become panic? Will you run away from the situation? No? Right. So you should be confident enough to give at least a basic life support or the first initial treatment or the resuscitation you should be able to do, right? So you may hesitate to do because you might not be knowing what is the right way of doing it, right? I hope after this session, at least you will have the confidence to give an initial resuscitation with the confidence when you come across such situations. With that, my objectives were there, make you understand what is cardiac arrest and what are the priorities in the treatment of cardiac arrest and correct steps to follow the treatment and mainly the principles of high performance CPR and early defibrillation. Yes. So what is the first thing you should do when a patient collapses in front of you? So making the scene safety. Scene safety in the sense, first you should be safe. You should see that you are safe. There is no harmful structure which can harm you and you will be the next person to lie on the next to the patient who is already unconscious. So the first thing you have to do is the scene safety. Okay. So the once you have made that you are safe and your surrounding scene is safe and where the person who is collapsed in front of you, you should make sure that you bring him to the safe place. You can see here the two pics. So you can see, tell that which one has followed the scene safety, first one or the second one. Obviously the one with the, on the right hand side, right, where in a road traffic accident where the person has been pushed to the roadside and they are resuscitating. Whereas if you see in the other side, the patient is in the middle of the road where the vehicles are coming and going. It will be harmful to the person who is going to help them also. So it's always better to have a first scene safety is the first thing. Once you have made sure that you have brought the patient to a safer scene, then what is the next thing you have to do? Assessment. That is primary assessment, that is to assess the level of consciousness. How we can assess the level of consciousness? Using a scale, AVPU. So if the patient is alert, he will be talking to you. If he doesn't, you can talk. If you talk to him, if he is responding, then he is responding to verbal stimuli. If he doesn't respond, you can give a painful stimulus and see if he responds or not. If he doesn't respond to your painful stimuli also, then the patient is called unresponsive. What you will do when the patient becomes unresponsive? These are the three things you have to do. You should look for the chest movements, okay, and listen for the breathing sounds, whether the patient is breathing or not, and feel for the carotid pulse. Look, listen and feel. This is the first thing you should do when you find that the patient is unresponsive. Once you feel that there is no chest movement and there is no carotid pulse, then you should think that the patient is having cardiac arrest. Once you diagnose that the patient is having cardiac arrest, what is the first thing you should do? Call for help. You should call for help and immediately begin chest compression. That is the utmost important. First call for help, then start with the chest compressions, and if defibrillator is available, early defibrillation and early referral to the hospital. That is the most important thing you should do. Then coming to the cardiac resuscitation, two most important aspects are you have to give effective chest compression and early defibrillation. The two important points in cardiac resuscitation is effective chest compressions and early use of defibrillator. To make your chest compressions effective, so the patient should be on the flat firm surface and the compression should be on the up to 1/3 of the chest wall should go inwards, and there has to be complete recoil, and the chest compression should be continuous without interruption for a duration of 2 minutes. Okay, so each minute at least 100 to 120 compressions per minute. It has to be uninterrupted chest compressions. You might have heard that there is a 30:2 ratio of ventilation. That is 30 compression with 2 ventilations. That is the standard which has been taught by the advanced care life science, ACLS and all. But the thing is that uninterrupted chest compression is very important. So rather than giving more importance to the ventilation, when you do chest compressions, what happens when you are compressing, the lungs will collapse. During the recoil, automatically the air will enter because of the negative pressure. So here the most importance will be given to the chest compression rather than ventilation. So it is uninterrupted continuous chest compression for 2 minutes is very important. Once you have given 2 minutes of chest compression, what you should do? Again reassess the patient. Reassess for less than 10 seconds. You should not take more time to reassess. What you are going to reassess? Again, whether the patient is breathing, carotid pulse is there or not. Okay. So if there is no pulse, then no chest raise, again start with the compression till the help arrives. Okay. So it's a small video. So what happens when there is when you give a chest compressions? Mainly what happens if there is no blood supply to the brain for a period of at least how many? 4 minutes. What will happen? Brain dead, right? So we have to pump the blood to the brain at least. So when you give chest compressions, the blood will be pushed to the vital organs, and when it is given with the form like 2 inches of, when it goes, it will squeeze the heart and it will help to pump the blood more into the vital organs, and it has to be continuous without any interruption. So as I told, how to give the compression, proper positioning is also very important. Okay, so when you are giving the compression, so your dominant hand, heel of the dominant hand should be placed on the lower half of the sternum, and with the other hand you should lock, and your arms should be kept straight and the elbows locked. And that has to be your perpendicular. So your shoulders should be aligning with the midline of the patient. So, and a back should be extended, as you can see there. Okay, so, and when you are alone, suppose the patient collapses and you are alone, what you should do first? One is the first thing you have to do is the scene safety, primary assessment, then call for help, immediately start with the chest compression for a period of 2 minutes and then reassess. Suppose you have a help, one more person is there with you, what you should do? One person should start with the scene safety, assessment and start CPR, start giving chest compression. The other person should call for the help and he should come to help the person who is already doing chest compression. That is called a swapping. So one person alone, he may not be able to give continuous chest compressions. So swapping can be done with the second person and that person should continue for a period of 2 minutes chest compression. Yeah, so this is a short video showing how you have to assess because the audio is not coming. So first thing, as I told, is the scene safety. Wherever you are, when a patient collapses, first thing you should make sure is scene safety and then assess for the level of consciousness. So by giving a painful stimuli, if he is not responding, then you diagnose it as a chest cardiac arrest, no breathing. Yeah. So how to look for whether the patient is breathing? You have to bend down as if you are searching something under the chair. And then you should listen to the breath sounds and you should look for any raise in the chest movement.
To see if the victim's chest is rising and falling. This is the look, listen, and feel approach. Checking for breathing should take no more than 10 seconds. Breathing is considered normal if the victim takes at least 2 normal breaths within 10 seconds. If the victim is not breathing and there is another rescuer,
so if your support is there, as I told, you should ask the other person to call for help, call for the ambulance. Then you should start doing a CPR.
resuscitation, place the victim in a supine or face-up position.
And as I told, patient should be on a flat, firm surface when you are giving a chest compressions.
Then interlace your fingers. Place the heel of your hand in the center of the victim's chest.
So lower half of the chest and heel of your dominant hand should be placed and elbows should be locked, and for a depth of 5 to 6 centimeter deep, the compression should be there, and it has to be continuous without any interruption for a period of 2 minutes at a rate of 100 to 120 compressions per minute. Yeah, this is what they follow, but it is better to go for a continuous chest compression without any interruption. Okay, and one more important aspect, as I told, is the early defibrillation. Now we have automated external defibrillators which will be available in various public places like theaters, cinema theaters, or the function halls, shopping malls, everywhere it will be there. Whenever such a situation happens, it will be readily available to help such patients. So mainly for the ventricular arrhythmias, and early defibrillation can increase the chances of survival, because even a minute of delay in doing a chest compression or early defibrillation can decrease the chances of survival by up to 10%. So it's very important to follow these 2 steps. Yeah. So this is one thing. When you have to stop the chest compressions, there are only 4 situations where you will stop for the stop doing chest compression. That is, after every 2 minutes of giving continuous chest compressions, to look for the pulse and the chest movements, and when the defibrillator is assessing the rhythm, when your defibrillator pads are attached and when that will be assessing the rhythm, you have to stop doing chest compression, and when the shock is delivered, at that time you have to stop doing chest compression. Or if the patient becomes awake or the pulse is palpable, the patient is resuscitated, then you have to stop giving the chest compressions. Only in these 4 situations you are going to stop chest compression, otherwise you have to be giving continuous uninterrupted chest compression. So this is how the AED has to be used. This is a flow chart. We will be demonstrating you how to use the automated external defibrillators. There will be a chest pads which has to be attached, and there will be a start button, and it will give the commands. So when it is assessing the rhythm, it will tell not to touch the patient, and when the shock, whether it will assess the rhythm and it will tell whether it is a shockable rhythm or not. Then it will give you the command to deliver the shock, and then once you have delivered the shock, immediately you should restart the chest compression for a period of 2 minutes. So that's how it is. As I told, every minute of delay can decrease the chance of survival. So it is very important to remember the 2 points, that is effective chest compression without interruption and early defibrillation. These are the 2 things which can save the life of a patient. And once you have resuscitated, stabilized, or as soon as the help arrives, safe transfer of the patient is also at most important. You can keep the leads attached to the with the AED machine, and the person who is trained in giving a chest compression should be accompanying the patient till the patient reaches the hospital safely. Because suppose again the patient can go into cardiac arrest, there should be a person to resuscitate. So with this, the key takeaways, as I told, early action will save the lives. So don't wait. Whenever you see the patient is collapsed, start doing compressions. High quality chest compressions is very effective. Then AED. So availability of the automated defibrillators is also very important. And this, you don't require a doctor to do this. Anyone can do this if they know the proper techniques. Yes. With that, I'll end my session. Thank you. We'll have a 5 minutes demo just of how to manage a patient when the collapse. Our interns will be showing you now. They are making sure that the scene is safe, and once the patient has been brought to the scene safety, he is assessing. He is looking for the chest movements and looking for the carotid pulse.
ಹಲೋ, ಇದು ಆಂಬ್ಯುಲೆನ್ಸ್ ಡ್ರೈವರ್ ಅಲ್ಲ?
ಹೌದು, ಹೇಳಿ.
ಇಲ್ಲಿ ಸದರ್ನ್ ರೆಸಿಡೆನ್ಸಿ ಹತ್ರ ಒಂದು ವ್ಯಕ್ತಿ ಬಿದ್ದಿದ್ದಾರೆ. ಇಲ್ಲಿ ಅವರಿಗೆ ಕಾರ್ಡಿಯಕ್ ಅರೆಸ್ಟ್ ಆದಾಗಿದೆ. ನಾವೀಗ CPR ಮಾಡ್ತಿದ್ದೇವೆ. ನೀವು ಆಗೋಷ್ಟು ಬೇಗ ಬರ್ಬೋದಾ ಇಲ್ಲಿ?
ಬರ್ತೇನೆ 5 ಮಿನಿಟ್ಸ್ ಆಗ್ಬೋದು. ಏನಾದರೂ ತರಬೇಕಾ ಜೊತೆಗೆ?
ಬರುವಾಗ ಒಂದು AED ತಗೊಂಡು ಬನ್ನಿ.
ಸರಿ,
ಆಗೋಷ್ಟು ಬೇಗ ಬನ್ನಿ.
ಓಕೆ ಓಕೆ.
So 2 minutes of chest compression over. He is again reassessing for the pulse. So the another person has arrived for his help. So they will be swapping. So meanwhile the help has arrived, and the team leader is going to attach the AED. Keep the mic. Give it to me. So it will give the command AED. Once you have press the start button and the leads are attached, it will tell you that it is analyzing the rhythm. That time you should stop doing the chest compression. So it will give a command. Yeah. So you should make sure that nobody is in contact with the patient. So once the shock is delivered, you should again immediately start doing chest compression for a period of 2 minutes. So and after 2 minutes again reassess. If the pulse has come, then yeah, so if they have resuscitated the patient, the pulse is there, chest movements are there, then you can immediately shift the patient, transfer the patient to a hospital. Suppose the patient doesn't recover with this, maybe another shock needs to be delivered and the chest compression has to be continued till the patient reaches the hospital. So with that we'll be ending the session. Thank you.
Thank you, madam. It was a very right and appropriate presentation along with a practical demonstration. I think that has helped most of our students because many a times we don't get this time. We will not be able to react immediately, but it has to be done as you told, as early as possible without wasting any time. So the more they practice among themselves, I think they'll be much more perfect. Yes. So thank you for that presentation. Any questions from the house? I think all of them have understood, ma'am.
Now I request our chairpersons to honor our speaker as a token of our appreciation. I request Dr. Mahesh Babu sir to honor our chairpersons. Now I would like to call upon next speaker, Dr. Venkata Krishna Bhatt S. He is going to deliver a talk on updates in antihypertensive drugs. I would like to call upon Dr. Himakar K. sir to chair the session. I request Dr. Sujwal to introduce our guest.
So, good afternoon everyone. It's my honor to introduce Dr. Venkata Krishna Bhatt, a renowned consultant physician with a passion for delivering exceptional patient care. Sir holds an impressive academic record, having completed his MBBS from JJMC Davangere, followed by MD General Medicine from the prestigious BMC. He further honed his skills by obtaining his DNB from National Board of Examination, New Delhi. Throughout his illustrious career, Dr. VK Bhatt has demonstrated a commitment to excellence, earning numerous accolades and awards. He is the proud winner of the Toronto Young Scholar Award in the South Zone and a national level runner-up. His expertise has been recognized throughout various quizzes and competition, where he has consistently demonstrated his exceptional knowledge and skills. As a testament to his dedication to medical research, Dr. Bhatt has received the Best Original Paper Research Award from API and IDCON. He has also been recognized for the outstanding contribution to the medical literature, receiving Best Paper Award at API, IDCON and IMA NATCON. Sir's expertise extends beyond his clinical practice. He is currently serving as Assistant Professor at Srinivasa Institute of Medical Science and Research Institute, Mangalore, inspiring the next generation of medical professionals. He has also been involved in various pharmacological trials, including the EMPA heart failure and azatanavir-based regimens in heart therapy. So everyone please join me in welcoming Dr. VK Bhatt sir to deliver his speech. Thank you.
Good afternoon, everyone. I think what topic was assigned to me is something on antihypertensive drugs. And as we know, hypertension is one of the most common problem which we come across in our day-to-day practice. If you see the whoever who are practicing, whichever may be the specialty, it is around 40% of the population what we treat is hypertensive, except I think pediatrics. So all we treat hypertension in our day-to-day practice. So most of us aware of what drugs we use. So my talk is much on what updates, what we have on our day-to-day practice, what new guidelines have come, and what are the new drugs available in the market. So moving on, so when to start treating hypertensive patients. So this is sometime it is diagnostic dilemma, whom to refer and with which is the level or what is the level where we can treat hypertension. So as we have IMA, we have IMA AMS, we have something called IMA W, women's wing, so on. So treat hypertension, we have so many associations and it is always difficult whom to refer and whom to oblige for the treatment. Say if you go with something like American Clinical Cardiology or American Heart Association guidelines, the cutoff to start treatment is 130/80. Anything more than 130/80 or equals, we need to start treating. So what happens is, according to European Society of Hypertension, the hypertensive, if the BP is more than 140/90, we need to treat. So whom to follow? This is what always a problem. I think if you go with American Heart Association or Clinical Cardiology, you are specifying Donald Trump or the pharma company because the cutoff is 130/80. So if you make, say, if you treat more than 150/80 or 90, you are specifying your patient. They're very happy that my doctor is not prescribing me the pills. He's talking much about his cutoff is a little higher. So whom to refer or when to start treating? So we are ruled by British. So I think what is good for us is European Society of Hypertension guidelines, and also Indian Society of Hypertension also give the cutoff of anything more than 140/90 is the time where we need to act. So there are so many queries. What is the optimum target? So most of the time it is less than 140/90 except in few complications or in something like a CKD, or in elderly we can go slow. I think we can target up to 150/90. So how you manage hypertension? This is what a beautiful algorithm which is not given from me. It is given in European Society of Hypertension, something called Master Plan for Hypertension Management. So what stands for what YAM stands is for measure, BP and diagnose. This is where we commit a lot of mistake, because there is something called masked hypertension, there is something called, all we aware of, white coat hypertension. This is where we need to focus on. We have something called ambulatory BP monitoring and something we have home-based BP monitoring. This is very, very important because many a times we overdiagnose people to have hypertension. So what else? Assess the patient. It is not just label everybody as essential hypertension or the primary hypertension. There are so many people who have secondary hypertension too. So you need to do proper evaluation. And what else? Select the therapy. This is where we need to put our we have to improve our knowledge, because there is a lot many drugs on the market, and even we also get confused many times, new drugs coming into the market. What else? Evaluate the response. It is not just you treat hypertension, things are done. You have to look how he or she is responding. So what changes been happened? So as all you know that we have something like line of therapy. We have first line, second line, third line and fourth line. So what has changed? As all you I think aware of, the first line therapy is your all AC inhibitor or ARB, something you AC inhibitor, something like a ramipril, what we commonly use, ARB, what we commonly use, telmisartan, CCBs, good old drug, amlodipine, what we commonly use, and diuretics. These are the first line therapy. What is changed now is when we are student, beta blocker was the first line therapy. When I was a postgraduate, it has gone down to fourth line, but now again the beta blockers are coming to the first line therapy. Why? We are going to discuss in further slides. So always when you are starting, when someone is diagnosed hypertension, you need to start dual combination. Remember, monotherapy is not that favoring the in outcome. You need to start dual therapy, that is maybe a combination of ARB with CCB or ARBs or ACE with the diuretics. So when you can use monotherapy, when you are dealing with maybe uncontrolled hypertension, resistant hypertension in only few cases. So what you need to start is dual therapy, increase the drug dosage up to its maximum level. Say telmisartan, give up to 80 mg, not stop at 40, add on some drugs, go to the maximum extent of its dose so that you can get the better response. So why you want newer drugs? This is where, because till 2007 there is a lot many drugs on the market, but after 2007 to 2017 there was a less progress in the pharmacological research. Why? Because we thought we have wonderful market on the market. We think secondary hypertension or resistant hypertension is less than 3% in our general population. Because of the surge of all the causes of secondary hypertension, we need to have new molecule in our practice. So as you all know, so whenever you think, the school of thought is whenever you come across people with hypertension at age less than 40, you need to evaluate for secondary hypertension causes. Now you need to evaluate even sometime in elderly patient too, when they are not responding to your regular drugs. So the list I need not discuss, I hope, because this is what we commonly come across. Why it is so important? Because nowadays you have more secondary hypertension causes like obstructive sleep apnea. You have so many patients come with hypertension secondary to renal causes, adrenal causes. Only thing, you should have eyes and you should have brains and you should have a good lab to evaluate for it. So what are the newer drugs we have in our pipelines? Because most of us aware of, most commonly everybody prescribes drugs, and what is the most common newer drugs which have come into market? So something I just want to highlight upon is Finrenon. This is one of the newer molecule which is there in the market since last 5 years. Indian market also be available. So this is something all you heard of, spironolactone. Most of us, I hope everybody aware of it. That is something steroidal mineralocorticoid receptor antagonist. This is something we have is non-steroidal MRA. What are the advantage and whom you select these drugs? So basically the advantage is now the hypertension is like, diabetes and hypertension are siblings. So most of the diabetic, as Sir told in the previous discussion, that it has become the second most common cause for the vision loss. So diabetes in surge, macro and microvascular complications are in surge. So we see a lot many CKDs. These are the candidates where we need to use this drug. The outcome is very, very good. It reduces your systole by around 10 to 15 and diastole by 5 to 8 millimeter of mercury. And what are the disadvantages? As it increases your potash, only thing you need to monitor your electrolyte. which can be sometimes fatal to the patients. What else? India, cost, yes. The cost is little on the higher side. Currently we have only one molecule. What I am aware of, what I am using is from Zydus, something called Carendia, which is available. The cost is around maybe 80 to 95 rupees per tablet. Only thing is cost. So whom you can select? What is my experience on Fenrenon is, no doubt, it is which set of patient I am using. People who are diagnosed to have pheochromocytoma, people who are diagnosed to have adrenal causes of hypertension, and people who have combined diabetes and CKD. Results are very good. I am using it for more than 1.5 years now. Only thing is cost, and I think now pharmacy people also helping out with the patient. So what else? Something we have Eplerenone, so which you may feel new name, but all this are there in the market since more than 5 years in Indian market too. What I'm discussing is not in Western population. What I'm talking is what is there in India. So because everybody aware of losartan, everybody aware of telmisartan, something else we need to know. So this is something like a mimicker of spironolactone. It reduces heart failure, which was used for basically heart failure with something called reduced ejection fraction. Also, it is used for it reduces the arterial stiffness. What are the disadvantages? As you know, this also causes bad hyperglycemia and causes gynecomastia and sometimes loss of libido and impotence. So which is no doubt better than your spironolactone, but way inferior to the Fenrenon. But the cost is okay. You get it around 20 to 25 rupees. Still it is worth using. What else? So something we have aprocitentan. So all you may hear something coming somewhere. So you may heard of something called bosentan, which was used for pulmonary arterial hypertension. The same class of drug, but it blocks both the endothelial receptor A and B. It is one of the molecule which is going to crack next 15 days. This is like something like you predict the stock market. This is what going to the beautiful molecule which is not available in India, but is going to come another 3 to 5 years. The trials, something very famous trial called Precise trial, which is so rewarding. It reduces the hypertension, the systolic BP by 10 to 15 millimeter of mercury and diastole by 8 to 10 millimeter of mercury. So it is so rewarding. Only problem is it might cause ankle edema. That is the only thing which we have come across with this drug. So that's about aprocitentan, and the trials are so rewarding. So what else is beta blockers? So all we were talking, it was a first line, gone to fourth line, and now again to first line. Why? Because now the hypertension is one of the most common hypotheses which they put forth is over-sympathetic activity. So these are the drugs, especially beta blockers, are the choice for treatment. But what we need to select? Bisoprolol, nebivolol, maybe carvedilol. Say no to atenolol. Please say no to atenolol. People who are there on atenolol, I know they are well controlled, but all the studies are discouraging. There is no encouraging data that it is of it reduces the BP, but it is of no use. So why bisoprolol? Why you want to select bisoprolol? Say is highest beta-1 selectivity. It has minimal effect on the lungs. It won't cause much bradycardia when you compare to atenolol. It has minimal effects on the sexual function, and it has longest half-life so that you can use once daily. See, these are the advantage take over because all maybe general practitioners are fond of writing atenolol. Please say this is the times to say no to atenolol. And what else? This is one class of drug everybody is aware of. This is what I start, like whenever what hypertensive drug I know is amlodipine, right? So most of us are aware of. So what else has come beyond amlodipine? Now most of them are aware of something called cilnidipine. So what else has come? So we have something called cilnidipine, which is there in Indian market. It available in 8 and 16 mg. We have something called benidipine, which is also available in the market. So how is it is whether superior or inferior to the the classical drug what we were using like amlodipine or the cilnidipine? So most of the trials have concluded that it is non-inferior to the old drugs, but only it is inferior in terms of cost. So most of us say, I think it is still there is a role for amlodipine if you rule out the pedal edema and the headache which is caused by amlodipine. Still, amlodipine is one of the very good drug on the market. Cilnidipine still is a good drug when you compare cilnidipine and benidipine, because it reduces it won't reduces BP as much as what other drugs are causing. Cardiac and renal safety, all the trials are not that rewarding. Maybe cost not under drug price control, you can go for it. So what else? This is one molecule, is the molecule of our century or our generation, I can say, which is being used left and right for all sort of diseases, now I can say. Something called sodium glucose transporter 2 inhibitors. This I think we should be all aware of. This is one drug which started for diabetes management. Then later on it boomed its market because of its wonderful efficacy on heart failure with reduced ejection fraction. Now we use even heart failure without reduced ejection fraction. We use it for many metabolic diseases, and it has come add-on drugs to the list in latest guidelines is DAPA, the SGLT2 inhibitors. What my experience, I think most of us are use DAPA nowadays because it has become very cheap, because only thing is compliance what matters for Indian scenario. You cannot write all the drugs so that patient won't take it for life. So DAPA is wonderful molecule. All our experience, I think Dr. Himakar also aware of it. We use it for most of the patient and results are so rewarding. Sometimes it reduced, especially in diabetic spectrum, reduce the intake of insulin so that most of them are off insulin many times. So I was part of EMPA trial, so I know in and out of EMPA because it is one of the wonderful molecule, but only thing is cost was little on the higher side. Now it also has come under drug price control, and no doubt it has many advantage except for the UTI which is caused by this. And most of the time gynecologists get these kind of patient when we start on female patient and put them on SGLT2 inhibitor. They land up with the lower urinary tract infection, land up with the gynecologist. Please look into this. This is what most common cause. What are the advantage is it has a beautiful action on the preventive action on cardia as well on the kidney. You can use anything, if you are in a resource limited setup, you can use it on any patient. You need not monitor much on the creatinine level. If your GFR is quite good, you can use. There are say less than 30 you need to modify, but most of the studies are not recommending. You can use invariably in all sort of patient. Only thing is you need to tell them you may develop UTI. Only thing is you need to stop. Otherwise, this is one of the wonderful drug. How it works, it causes something called, how it works on hypertension, it causes diuresis, it causes weight loss, because obesity is one of the major cause now for secondary hypertension. It reduces the weight, hence reduces the BP, improves arterial stiffness. This is what the good sign. You can use it in elderly, and also modify something called renin-angiotensin system as well on sympathetic nervous system. The cost is very cheap, multiple benefit. This is what, and our personal experience, no doubt cardia is very good. BP long run 1 to 2 years of using SGLT inhibitor, no doubt systolic is reduces by 6 to 8 millimeter of mercury. So that's all about. There are so many drugs on pipeline, and what we need to choose is what is important for us, because it's end of the day selecting the right patient, right drug, and get the best outcome of it. Thank you.
Thank you. That was a very good presentation of the updated newer anti-hypertensive drugs. Many of the drugs, so many of them may not be knowing, because still everybody treats the hypertension. Even Ayurvedic doctors, everybody they treat with the atenolol, amlodipine, everything. But these are the newer drugs. Why should we use it? Usually this hypertension is complicated with the cardiovascular diseases. So we have to think of the cardiovascular disease, and we have to choose the right drugs. Thank you so much for the nice presentation.
I request Dr. Himakar sir to give a moment to our speaker.
See, atenolol is the first beta blocker into the market, and which is something grabbed the market for more than 3 decades. And now latest trials, and when you have on the beta blocker, what maximum trials we have is on atenolol compared to other drugs. But the complication rate, the benefit rate is way lesser than the other beta blockers. And it's not that, because it also has selectivity for both beta 1 and beta 2 receptor. It causes bradycardia. Sometimes if you are not asked good history, many times patient land up with the pacemaker, and many times elderly present to us with the syncope because of the heart blocks. Also, it is not very safe people who are having COPD or any respiratory illness, or these are the most common drawback which we come across in terms of atenolol. So we have better version of it, because it is, yes, it reduces systole by around 10 to 12 millimeter of mercury, but diastolic not much, and it has more disadvantage than what better molecule we have in the market. And we have now beta blockers. If you think of cost also, so many times what happens in general practice is cost is the factor. So we have now these drugs also come as for cheaper rate. You get it for the almost same price, and which has more benefit. So we need to choose right drug for the right patient so that it will benefit. And so regarding the rate control part of atenolol, this is also not that rewarding. It reduces so badly so that it worsens the cardiac complications than benefits it.
I would like to call upon our next speaker, Dr. Arjun MB, who is going to deliver on topic diabetes reversal, myth versus reality. I'd like to request Dr. Himakar sir to chair the session, and Dr. Veena ma'am. I'd like to call upon Dr. Nazim to give introduction about a speaker.
Good afternoon, everyone. I would like to welcome our guest, Dr. Arjun MB, sir, to enlighten us about diabetes reversal, whether it is a myth or reality. Diabetes, as we all know, it is ever-growing disease in our Indian scenario, mainly because of sedentary lifestyle. And another good thing is because of better outreach of our healthcare system, we are able to diagnose diabetes early. But there are multiple etiologies, most of them are modifiable. So we will like to wait and hear sir's topic, whether this reversal of diabetes, it is myth versus reality. Dr. Arjun MB, sir, after completing his MBBS degree in Devrajur's Medical College, Kolar in 2012, went to Delhi for higher studies, and after securing one of the highest rank in NEET PG, he pursued his PG in RML Hospital, New Delhi, where he was trained directly by Dr. Atul Goyal, sir, who is current DGS and physician to our Prime Minister of India. A specialist in diabetes management with rich experience of over 10 years, he is currently working in Manipal Hospital, Doddaballapur. He has handled numerous complex medical cases and is known for his attention to detail and accurate diagnosis and treating the patients with utmost empathy. He holds numerous certificates of training in various medical specialties like diabetology, cardiology, echocardiography, and biomedical research and palliative care. He is also certified by Indian Association of Palliative Care in pain management. Dr. Arjun sir has immense experience in treating cardiac disorders. His expertise in reading ECG has made him one of the most sought physicians in the locality of the cardiac patients. He is also an active member of American Heart Association and European Society of Cardiology. I would like to welcome sir.
Good afternoon, everyone. Thank you very much, IMA Sullia branch, for giving me this opportunity. Thank you very much for the kind introduction, sir. So today I'll be talking about a very sensitive topic in today's world, that is diabetes reversal. We have a lot of online platforms which are endorsing diabetes reversal. We have a lot of celebrities coming out and telling diabetes can be cured overnight. None of you should take any medicine. Diabetes is a medical mafia. Doctors are behind money. Whole system is behind money. They want to hook you on medications and make money out of your diabetes. We can cure diabetes. There is twin diabetes. There is Dr. Pramod Tripathi reversal. There is Sugar Fit. There is Fitafly. N number of corporate companies are coming out and telling we will reverse your diabetes. So is it really possible to reverse diabetes? Let us go through the evidence which has been generated so far. So as we all know, India is home to 77 million diabetic population, and this is just the tip of iceberg. India is also called the diabetic capital of the world. Then, of course, the data says South Indians are more prone to diabetes than the North Indians. Why? I'll tell you in the next few slides. The range of blood sugar in diabetes could be somewhere between 140 to 2,656. This is the highest recorded blood sugar according to the literature as of today. So, what causes diabetes as per the patient? It's like when we talk to the patient, ask them, the moment I tell you're diabetic, they tell, mother ke father ge ittu sir adike nange banbidtu. So they want to blame their parents immediately. Next, stress. No sir, recently I have lot of stress. That is why I got diabetes now. Then eating too many sweets. They say, sir, monne ella habba ittu sir, al sweet tinda diabetes banbidtu nange. Then not eating on time, injections, sir, ನೀವು ಒಂದು ಇಂಜೆಕ್ಷನ್ ಕೊಟ್ರಿ ಲಾಸ್ಟ್ ಟೈಮು ಕೊರೋನಾಗೆ ಅಂತ ಒಂದು ಬಾಟಲ್ ಹಾಕ್ಸ್ಕೊಂಡೆ ಶುಗರ್ ಬಂದ್ಬಿಡುತ್ತೆ ನನಗೆ. ಸೊ ದೇ ವಾಂಟ್ ಟು ಪುಟ್ ದ ಬ್ಲೇಮ್ ಕಾನ್ಸ್ಟೆಂಟ್ಲಿ ಆನ್ ಅದರ್ಸ್ ಫಾರ್ ದೇರ್ ಡಯಾಬಿಟಿಸ್. ಸೊ ಸಮ್ ಸರ್ಜರಿ ಸರ್ ಸರ್ಜರಿಗೆ ಅಂತ ಅಡ್ಮಿಟ್ ಆಗಿದೆ, ಅವಾಗ ಅಟ್ಯಾಕ್ ಆಗೋದು ಶುಗರ್ ನನಗೆ. ದೇ ವುಡ್ ಹವ್ ಬೀನ್ ಡಯಾಗ್ನೋಸ್ಡ್ ಅಟ್ ದಟ್ ಪರ್ಟಿಕ್ಯುಲರ್ ಪಾಯಿಂಟ್, ಬಟ್ ದೇ ಬ್ಲೇಮ್ ದ ಸರ್ಜರಿ ಫಾರ್ ಇಟ್. So drinking ORS, COVID vaccines, I have a lot of patients who come to me and tell, after corona vaccine, we got diabetes. And ultimately they will blame us. That is the last cause. This should be on the top actually. So what actually causes diabetes? I'm pretty sure we're all aware of it. Number one, lifestyle. Number two, lifestyle. Here, let's restrict our discussion to type 2 diabetes. Lifestyle. 3 causes are lifestyle. Fourth one is food, physical activity, exercise, sleep, stress, family history, chronic illnesses, micronutrient deficiency, gut microbiota deficiency, obesity, pregnancy. So these all contribute to insulin resistance. So diabetes is a metabolic disorder. So it's not merely a elevation of blood sugar. So metabolism is the way our body handles sugar, protein, water, etc. So it is the inability of the body to metabolize and absorb the sugar which is already in the blood. So type 2 diabetes is not due to deficiency of insulin, it is due to insulin resistance. So this is just a small diagram where we know that blood sugar in the blood is being taken into the cells by the action of insulin. In type 2 diabetes, yes, there is insulin resistance. So whatever sugar is in the blood is going to remain in the blood. So food habits, yes, 99% of South Indians rely on this. So nobody accepts that we eat high carbohydrate diet. Yes, all our idli, dosa, pongal, pulao, everything has rice in it, and rice has a very, very high glycemic index. So approximately by the age of 50, we are eating 50,000 meals against nature, and when we ask why we get diabetes, we blame our parents. So remember, phenotype is always genotype into environment. If we do not provide the necessary environment, the genes may not express throughout the life. So we cannot change our genotype. We can definitely change our environment. So habits like alcoholism, smoking, junk food, carbonated drinks, everything again. So this is taken from the website of Government of India. This is the prevalence of diabetes. See the red zones. We're all proud to be men in red, RCB. So everywhere, entire South India is a red zone because of our high carbohydrate diet. And look at Rajasthan, and wherever wheat is a staple food, definitely the relative incidence of diabetes is on the lower side. So physical activity and exercise, yes, lot of patients tell, sir, ನಾನು ಬೆಳಿಗ್ಗೆ ಹೋದ್ರೆ ಸಾಯಂಕಾಲದವರೆಗೂ ದುಡಿತೀನಿ ಸರ್, ನನಗೆ ಯಾಕೆ ಬರುತ್ತೆ ಶುಗರು? And farmers especially, sir, ನಾವು ವ್ಯವಸಾಯ ಮಾಡೋರು, we do agriculture, why do we get diabetes? Your mission is wrong. So that's what they tell. So most of them confuse physical activity for exercise. So physical activity is defined as any bodily movement produced by skeletal muscles that results in expenditure. But exercise is a series of planned, structured, repetitive movements which is done to improve one's fitness. So other risk factors, sleep, stress, chronic illnesses, obesity, micronutrient deficiency, gut microbiome, excess antibiotic use. So these are all some of the risk factors, and more than 50% of the patients who get diagnosed would have developed some complication in the form of neuropathy, nephropathy, and nobody wants to get checked until these symptoms develop. So they don't believe in prevention. Only when they have some unbearable symptoms, they come to us. And nobody wants to accept that they have diabetes. They are more comfortable with the word borderline. Oh, just sir, borderline alittu, they told nothing to worry. So they want to stay in that borderline forever. And excess of heat, sir, urine infection, very heat agide sir, sugar alla illa sir. So they don't want to accept it. Food control, sir, only food control, sir. Exercise ಮಾಡ್ಬಿಡ್ತೀನಿ. So exercise control, yoga control, these are some of the things they believe can help them with their diabetes. So coming to the reversal, what is the evidence that has been generated so far? In 2019, actually the research on diabetes reversal started in 2009. After 10 extensive years of research, Roy Taylor published his paper in 2019 that restoring normal glycemia by use of very low calorie diet. And this was published in 2019. Frankly speaking, even American Diabetes Association accepted. After going through these two trials, they said, okay, maybe diabetes may be reversible with the lifestyle. So what happened is the follow-up was for 10 years. When they started, everybody stick down to the low calorie diet. For 3 to 4 years, there was absolutely normal. Sugars went on well. But human brain is not so easily controllable. Once a patient knows he does not have sugar anymore, he won't stop. Then what happened? Same thing was followed up. So when they got to know that whoever had gone down on HbA1c came back with diabetes, American Diabetes Association changed their stance. In 2019, ADA acknowledged diabetes cannot be reversed, but it can be remitted. So diabetes remission is possible through lifestyle modification, and of course diet and exercise, and by reversing all those factors like I told you, gut microbiome and micronutrient deficiency. If we take care of all that and bring down the insulin resistance, diabetes remission is definitely possible, but it is not a disease which can be cured. So this is one of the trial which was done in 2017, direct trial, weight loss, like how weight loss helps in diabetes reversal. Like people who 46% of the patients who lost more than 20% of the body weight had a significant lower HbA1c level. So the next trial was Stampede trial. This was done on patients who are undergoing bariatric surgery. So bariatric surgery, like whoever is a diabetic and they undergo bariatric surgery for obesity, most of them came down on their HbA1c level. So they thought bariatric surgery is the answer. Then we had a Look Ahead trial. This was for Action for Health in Diabetes. Here again, extensive lifestyle modification. Actually, this was a game changer where a lot of these companies started coming up. We are going to help you with your lifestyle modifications. Like we put you on a low calorie diet, we put you on a good exercise regimen. Definitely you can come down on your HbA1c. So this is being proven beyond doubt that diabetes can be remitted even without any medication. Let's say patients who already are on medications, yes, they can be taken off medications. This is quoted on even American Diabetes Association website. Like a person, now the newest definition says that a person who was off the diabetic medications for more than 6 months and his HbA1c is less than 5.7 for the 6 months without any medications is told to be in remission of diabetes. So my personal opinion, looking at all these trials, diabetes remission is not possible with drugs. It needs extreme cooperation from a patient in the terms of diet, exercise, lifestyle, and a subordinance to nature rather than eating just whatever suits our palate or whatever suits our society or whatever suits our profession. So sustenance of remission is totally individualistic. A lot of patients who achieve remission in our clinical practice ask us, how long do you need to continue this diet after reversal? So the answer is forever. Unless you are on it forever, your diabetes is going to come back and haunt you. This is what I tell them. So diabetes remission, diabetes is not a disease to be cured, but it is a condition. It is a metabolic disorder which has to be maintained continuously every single day with every single meal. So basic steps, a balanced diet plan as per individual needs. Again, we should tell our parents not to depend on YouTube, online videos, Facebook dietitians. A lot of people have lost their kidneys because of this keto diet and paleo diet and all those things. Prominent movie star is endorsing a supposed anti-diabetic drink on television. I'm sure all of you know about Herbalife. Many of our patients go and drink those shakes. And who is endorsing it? A movie star who also has a doctorate apparently, not in medicine. So that's how today's world is. So is there a universally ideal diet or a potion or a powder which can reverse diabetes? No. So all of us are different, we look different, we have different metabolism, so we need a different diet plan. So dietary requirements also change in the same person from different time to time. So recommendations for exercise, again taken from American Diabetes Association, 30 minutes per day, 5 days a week. Approximately 150 minutes per week of aerobic exercise, that is walking, cycling, swimming or jogging. Resistance training 2 to 3 times per week, non-consecutive days. This is shown to improve insulin resistance, especially the peripheral insulin resistance where our GLUT4 transporter is enhanced, pushing the sugar into the muscle fibers. So balance and flexibility exercises also depend on upper limits of patient fatigability. More than 7,000 steps per day is a recommended daily activity, not exercise. This is the minimum recommended daily activity for any person who's a diabetic. So some example of my clinical practice, how we have achieved remission with the help of good dietitian and an exercise plan. Like this one particular patient, 20th March came with HbA1c of 12.7. So within 4 months he could achieve a HbA1c of 6.5, and I'm proud to say that he's not on any medication now. So now his recent HbA1c was 5.3. So but he is sticking on to the diet from last 4 years. So this is some other experience. This particular patient was on SGLT2 inhibitor, like Dr. Venkatesh Krishna sir rightly told, SGLT2 inhibitors are a real game changer in today's world. So they act at a molecular level and they reverse insulin resistance to a certain extent. So this particular patient could achieve a very good diabetes control and she was on insulin, but now she's only on SGLT2 and a combination of metformin. So this is another patient with knee replacement. See, this particular patient, why? Because after knee replacement, the exercise capacity will be very limited. Still, with extensive diet and a combination of sitagliptin and metformin, we could achieve a good remission. Not complete remission though. So not just diabetes, even cholesterol, as we know, it is a metabolic disorder. It's the way our body handles fat. And why is that impaired? Because of the insulin resistance also plays a role there. So this is one such patient where cholesterol levels also dropped when we targeted his lifestyle, just with lifestyle intervention. So as Sri Swami Vivekananda told, you are the creator of your own destiny. We are the creators of our own metabolic disorders. It's high time that we stop blaming our genetics and factors which are beyond our control. It's time to take charge and tell, yes, we are responsible. Only then we realize we only can find the solution for it. So we can cure ourselves if we go according to the laws of nature, digestion and metabolism, eat good, sleep better and exercise your best. Take home message, type 2 diabetes is a disorder and not a disease. It cannot be reversed or cured, but remission is possible. Diet, lifestyle and exercise form the cornerstone of treatment. Individualized approach, not everyone will experience remission and treatment should be personalized. Ongoing lifestyle management forever is the key. Thank you.
It was a wonderful presentation because that is everybody thinks they don't want to blame, diagnosed as a diabetes and they want from the doctor it can be cured. And again, it is a remission or a reversal. It is an ongoing idea like in the medical field also. And every day, every meal, it is a very difficult thing, even the diabetic or a not diabetic. And as we heard, Uta Ballavanige Rogavilla.
Yes.
So we don't know from when we have to know what to eat. That is the problem. Yeah, it was a wonderful presentation. Any questions from the audience? Yeah.
Yes, madam. Madam, intermittent fasting has garnered a lot of attention in the last few years. Why? Because there is a thing called 3:4 fasting. 3 days a week you fast and 4 days you eat. 18, yes madam, 16-hour window, 8-hour window you eat, 16-hour window you fast. In April 2024, there was an article published on American Heart Association that 91% of the patients who have practiced intermittent fasting are at risk of a cardiovascular disease. So the risk of cardiovascular disease increases by 91% if a person has gone on intermittent fasting, madam. This is there on the website. So I strongly discourage patients to do that, madam. What I believe is a balanced diet plan, like I showed in one of my slides. Fiber is the main thing which we are missing in our diet. Like earlier, like when we attend diabetes conferences about nutrition, earlier they used to say 40% carbs, 20% protein, 20% fiber, 20% water, vitamins and minerals. Now the dictum has changed. It has come to 40% fiber. They tell that start with your meal with fiber. Fill your stomach with fiber. Then proceed to protein. Then go to carbs. By the time you go to carbs, you're almost half full. So you cut down on carbs, number one. And fibers, they are the game changers in the diabetes management, madam. So I always prefer a balanced diet rather than intermittent fasting, madam. So it is strongly discouraged as per the available evidence now.
What about vitamin?
Yes.
What
Yes,
about
madam.
vitamin D and this gut microbiota, which can be used, I think, now for every sort of disease. Every disease you ask, this is something like a thesis topic. You do everything it works. What your experience, what your take on, because all articles are rewarding, we know how it rewards, and what's your take? And one more thing, as a general public, I'm asking, because I do a practicing physician. So, Herbalife, people taking, their diabetes is well controlled. How you convince them? Because people taking, say I'm branding just Herbalife, there are so many. People who are taking, who are on high doses of drugs, they're they're off with the Herbalife. But outcome, we don't know. But so many people of us, they check, they come back. That's a different scenario. And what is the general message to the gathering?
So based on Herbalife, sir, I've had 2 patients even now who are on dialysis, who've been addicted to Herbalife from last 4 years. So what they do is, there have been no studies which have actually been conducted on that, but there have been several case reports linking Herbalife to decompensated acute liver failure that we all know. But this weight loss and diabetes, see, what they do is they cause drastic weight loss within 3 to 4 months. As far as I have seen, what happens is they have some sort of diuretic action. They take out all the water content of your blood. They take out all the water content of your body and achieve rapid weight loss. And of course, with reduction in weight, there will be some improvement in insulin resistance and the sugar levels start dropping. And they don't know that, they continue that, they'll land up in acute tubular necrosis and then land up in CGN. And I have 2 patients who I've seen personally have landed up on dialysis. So this is one example which I give my patients, and there have been a lot of case reports linking Herbalife to liver disease. And coming to the vitamin D, sir, like I told you, micronutrient deficiency, not just the vitamin D, nowadays we have selenium, phosphate, magnesium, these are all being linked to the diabetes, insulin resistance. So definitely we would like to give them a multi-nutrient supplementation till they come down on their HbA1c. After that we can eventually stop it. And if patient can afford, definitely nowadays Thyrocare and other labs are giving an entire nutrient report. You can see that and then decide on whatever nutrient patient needs. So that's about it.
Subclinical hyperthyroidism, say, this is out of market now because all we so-called Thyrovel, what we are using, so many people do use, but all studies are no.
No, not Thyrovel, sir. I was saying about the lab.
Because Thyrovel is one brand I'm just saying, because it supplements, which is out of market now because it's just supplementary. What about, these are like add-on to our list of drugs, because when they go to physician, it is always list of drugs.
So most of them, if you put them on a good balanced diet, they don't require any medications at all, sir. If you teach them what is the right type of protein you eat in your diet, rather than giving a protein supplement, I always prefer them to eat some high protein like egg or soya or chicken 3 times or 2 times a week.
Again, sir, we are telling that no low carb diet. Again, now recent articles, there are so many coming that again proteins are involved in the development of insulin resistance. Again, essential amino acids. Yes. What's your thoughts on that?
Madam, evidence-based medicine is constantly evolving. Every day we keep getting new data. Everybody wants to contradict whatever was there previously. So as of now, whatever the stand of the international organizations is mainly focused on fiber, madam. Even the protein recommendation, whatever was there, 1 gram per day per kg, is still the same. It is not changed at all. But the fiber recommendation has increased, madam. So that is the key in this achieving this diabetic remission, by increasing the fiber and keeping the protein constant. So nowhere they have told to increase the protein.
To add to that, ma'am, it is something like low calorie dieting. It prevents the telomere aging. So it also something like it acts as a sirtuins. So these are the advantage all these drugs, what diet modification has. That's why the remission is giving, it is in upsurge because of this added advantage. Thank you, sir. It was a very informative session. Now I call our chairperson to hand over the honor. Now I call Dr. Ganesh Bhatt K to hand the token, guest of honor to our chairperson. I think it is the time to call upon our last session of quiz for the few participants or delegates present over here. Still, it's a good number.
Yeah. So today is this is the last session and the last chance to win the prize. As there are very less number of delegates, more chances are there. And you have got used to it, how to do this. Now you should be well versed with the using Slido. Started, huh? Thank you. Shall we start now? Or anybody wants to join? Okay. We shall start now. Still people are joining. Yes, now we'll start. So when to start antihypertensive therapy? So when the BP is 130 by 90, 140 by 90, 140 by 85, 130 by 80. So almost everybody got the answer. Yes, right answer is 140 by 80. Only 10% people think it should be started as early as 130 by 80. Ankle edema produced by azeltepine, aprocitentan, and bisoprolol, finerenone. So it's a mixed response. Many have taken azeltepine. Aprocitentan is the right answer. Gynecomastia is caused by all except eplerenone, spironolactone, finerenone, digoxin. Again, still there is a mixed response. Many have taken nearly 50% digoxin, finerenone. Congenital heart disease starts when the fetus is in womb. I think this is a repeated question. Yeah, that is done. Which of the following has been shown to help Some people with type 2 diabetes achieve remission. Weight loss, very low calorie diet, regular exercise, all of the above. I think when all of the everybody will answer, I think. Yes, that is the right answer. Type 2 diabetes can be permanently reversed with healthy diet and exercise alone. Is this statement true, false, sometimes true, not enough information provided? Mixed responses there. Diet and exercise alone. Okay. Only 8% are thinking the right answer. Okay. As experts are telling, false answer. People with type 2 diabetes who experience remission no longer needs to be monitored with a blood glucose level. What is about the statement? True, false, depends upon individual health condition only for a short period of time. So 84% think that it's a false statement. Yes, it is a false statement. They need to on regular treatment. Regular monitoring is necessary. You pull an unconscious person to safety. What next? Start CPR, shout for help, call 108 ambulance, look, listen, feel. So 71% have thought look, listen, feel is the first response. Yes, that is the right answer. Then you can shout for help and call for ambulance. After ensuring scene safety, you can do a cover, look, feel. There is no chest rise, no airflow and no pulse. What next? Start CPR and after 1 minute call for help. Shout for help, immediately start CPR. Run for help, call police 100. So shout for help and immediately is a major response. So that's the first thing. So ask for help and then go for CPR. Chest compression should be stopped in the following situations. After every 2 minutes while reassessing, when defibrillation is assessing the rhythm, when shock is delivered by defibrillator, if a patient pushes you away or pulls felt on checking, A and B, ABC, ACD and ABCD are the responses. So many people got this. So 87% of them put a right answer. Shashank. Yes, please come forward. Rangnath sir. Sujwal. Huh? No, ಯಾರಿಲ್ಲ ಅಲ್ಲಿ Nandaloka also can come forward, 4th person.
As we come to the end, it has truly been a privilege to witness the exchange of knowledge and ideas among experts and participants. I would like to extend my heartfelt gratitude to our esteemed speakers for sharing their expertise, our respected guests for their presence, and our enthusiastic participants for their engagement. Let's take the knowledge gained today and apply it in our respective fields to improve patient care and medical practice. Thank you once again, and we look forward to meeting you at future events. Thank you.
I request Shruti and Dr. Venkatakrishna to come over the dais and receive the token of love. Request others to come over the dais. We are really grateful to you, your great support for the CME from the TMS Pharma.
We thank everyone who have worked behind the scene. Dr. Vinyas, Madam's family, Palachandra sir, caterers, and everyone who have helped directly and indirectly, audio visuals, everybody has helped us to conduct this CME very successfully. And please rise for the national anthem, and then there will be one final group photo. And high teas will be followed later. Punjab, Sindh, Gujarat, Maratha, Dravida, Uttala, Vanga, Vindhya, Himachala, Yamuna, Ganga, Ujjala, Jaladhitaranga, Tava Shubha Name Jage, Tava Shubha Ashu Samage, Gahe Tava Jaya Gata, Jana Gana Mangala Dayaka Jaya He, Bharata Bhagya Vidata, Jaya He, Jaya He, Jaya He, Jaya 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 He. Everyone please come forward for the group photo.
First IMA members.
All IMA members please come forward for the group photo.
And with the students later.
Right.